Good morning. Today we are going to talk about an interesting concept which has been brought forward about the relationship of sarcopenia and osteoarthritis. So, whenever we have a problem, we need to approach it with an idea to solving it rather than trying to sell a product or convince someone about an operation. So we need to really assess the problem and find a good solution. So the term sarcopenia was coined by Rosenberg in 1989. He was a well-known surgeon in USA, and the words are Greek. Sarco means flesh, and penia means poverty. So poverty of the flesh. Basically what it means is that just as we have osteopenia, which is a poverty of bone, sarcopenia is poverty of the muscle. And this is a type of muscle loss which acts during aging, and when the skeletal muscle mass deteriorates from the point of view of quality, strength, and volume. And it is related in many ways to old age. It is related to the exercise level of the patient, to the level of comorbidities and nutrition, etc. So today we are going to concentrate mainly on the nutritional aspects. And it's important to understand that sarcopenia is distinct from cachexia, because in cachexia, the muscle is degraded by a cytokine-mediated degradation. So that's more pathological. Sarcopenia, relatively physiological, but it is possible that cachexia and sarcopenia can exist in the same individual. Sarcopenia is considered a component of the frailty syndrome, and it leads to reduced quality of life. It leads to more falls, and falls lead to fracture of the neck of the femur. It leads to more fractures, and it leads to disability. So you can see here in the picture that right over here, the left side is normal. The person has a lot of muscle mass, and the relative amount of fat is much less. But when you have a situation where sarcopenia develops, then you have a lot more fat and very little muscle. And this is associated with a lot of morbidity for patients. So you can see over here the two pictures. So there is another view that after surgery, if people don't exercise enough, if they don't get proper nutrition, then they may land up with a situation of muscle atrophy. So this picture shows you that if you don't do proper intervention of exercises and nutrition post-operatively after TKR, you can have a limb which has much less muscle. Now, sarcopenia is a factor in changing body composition. By this I mean the percentage of fat in a person will go up, the percentage of lean mass will go down. And it is associated with aging populations and happens in certain muscle regions, specifically the anterior thigh muscles, the quadriceps, as well as the abdominal muscles. The body mass index may go down because it's possible that since muscle is a heavy object compared to fat, it's possible the BMI might go down, but the patient has actually become much more unhealthy. And the rate of progression of this depends on multiple factors which we will discuss. And it is very common in aging populations, but today with the lifestyle of our young patients, we are seeing this more and more. So in addition, all the lifestyle issues, the junk food, the type of nutrition you take, the sitting in front of a computer 10-12 hours a day, these are all things which lead to loss of bone as well as muscle. So as orthopedic surgeons, we have always concentrated on the bone. We've talked about osteoporosis, osteopenia, osteomalacia. But we have ignored a very important component, which is the muscle mass, which is of paramount importance. And this is there more in the elderly, but is also present in those below 60. And in the prevalence of sarcopenia in patients with osteoarthrosis is quite high. It's 45% versus 31% in controls. And this affects the Barthel index. Now, by Barthel index, basically is an index which takes into account the lifestyle of the patient, whether a patient is capable of doing ADL, activities of daily living, and obviously lower Barthel index leads to restricted mobility, which leads to a poor quality of life. So it's like a vicious cycle. Primary osteoarthritis leads to loss of muscle strength, loss of skeletal mass, loss of bone mass, and the lifestyle changes, fat percentages increases, osteoporosis happens, metabolic health, mental health are also involved because the patient is homebound, bedbound, and this is a vicious cycle as I explained. And in a patient who has sarcopenia, there's an increased risk if you've had a TKR, chances of a blood transfusion, post-operative pneumonia, UTI, prosthetic fractures. Why fractures? Because if you're unstable, the chances of falling down, getting a periprosthetic fracture, a prosthetic dislocation naturally goes up. In addition, if you're unstable, chances of mechanical loosening also can develop. So we need to improve diet. It goes without saying, and this is where the intervention of diet comes into play. So, but it's also important that diet is not the only factor. We need to do exercises of targeted groups of muscles. So it has to be a combined thing. Just giving diet, just giving protein is not going to lead to anything. Okay. So to understand how protein helps, we need to understand a little bit about protein metabolism. So the basic structure of any amino acid is RNH2COOH. So basically COOH is the acidic group, NH2 is the amino group, and R is the side chain. So based on the R, we have different kinds of amino acids, and if you look at all the amino acids, all the mammals have only 20 amino acids. And of that, 9 are essential amino acids. What are essential amino acids? These are amino acids which are not produced within the body. So you have to get it from an external source. What are the names? Histidine, isoleucine, leucine, lysine, methionine, phenylalanine, threonine, tryptophan, and valine. So these 9 you cannot manufacture in your body. The other 11 you can. So you need a source to get that externally, either from your diet or otherwise. And these have different roles. I'm not going to go into too much detail, but each of them have a vital role in good nutrition and good, having less morbidity, such as leucine and then HMV, citrulline, etc. And in addition, there are things like collagen, which are dependent on the combination of different kinds of amino acids like glycine, proline, hydroxyproline, and these actually are components of collagen type 2 as well as cartilage. So there is another term, and this is a new term I think which is coming, which is osteosarcopenia. So it's not just sarcopenia, it's not just osteopenia, but it's actually a combination. So you are facing a situation where all these factors are there and they have a huge global burden, hip fractures. So as we have an older population, more hip fractures, we find that this is becoming a major component of the developing vicious cycle of poor nutrition causing poor morbidity, and then you have other problems as well. Okay, and now to assess any input, we need to look at objective data. So these are the ultrasound mechanisms to measure the anterior thigh muscles, and you need to make sure that preoperative or pre-intervention, the muscle mass should improve after intervention by way of nutrition and diet. So now if we look at this component which is being promoted, it has all the essential amino acids. So the names I mentioned a little while ago, leucine, isoleucine, lysine, phenylalanine, methionine, etc. They're all there. But in addition, you also are given the amino acids which are non-essential but are also good, required for better health. Now, several studies have been done. I won't go into too much detail, but studies have been done by Dreyer, Ueyama, Chittaranjan, this is Chittaranjan Ranawat by the way, and Pandor, and they have showed in every case that there has been improvement, but unfortunately the numbers I think are not too much. So to get statistically to get good statistical evidence, you need a lot of numbers. So I think at this point in India, with the help of the company which has brought out the medicine, they are trying to do multicentric trials, and we are actually in the process of publishing something in the Journal of Arthroplasty as well about this. So a lot of different studies will be conducted. They have focused on TKR, but I think you can also extend it to almost any condition, I mean to trauma or otherwise. It doesn't have to be TKR. I'm not sure why they picked TKR as such, because there's no nothing that says that this is only applicable to TKR. It should be applicable across the board. So I won't go into the individual studies, but it does show improvement, but the numbers, as I said, are less. This is all the clinical evidence which shows improvement, and basically I will skip all this, just show you a few slides here, that the pain also improves if the muscle mass is better. This is something we all know. If you develop muscle mass, you have less pain, and you have improvement in the rectus femoris and quadricep muscle outcomes. So I'll just come right now to the take-home message. So sarcopenia is a common preventable condition in the elderly. It happens in sedentary individuals mainly, and patients with inadequate diet and multiple comorbidities. It is often associated with osteosarcopenia because bone and muscle are part of the same coin, we can say. It leads to a vicious cycle in inactivity, difficulty in carrying out ADL, and eventually a poor quality life. While there is definite correlation with osteoarthrosis, it has been shown that it can affect all kinds of patients, whether they are trauma patients or patients with other conditions, including those who require hip surgery. So a dietary supplement of essential amino acids is a new, exciting concept which is showing promise. It's not a done deal yet. It's not been proved, I have to say, because the numbers of the studies are low, the number of patients are still low, but we are working on improving the numbers so that we can get statistically significant results. But several trials have been done, including by some of the giants such as Chittaranjan Ranawat and others, and they're showing improvement. So I think the need of the hour is to conduct large multicentric studies, and so that we can work out a way to prove that nutrition is important for all types of musculoskeletal disease. Thank you very much. So Dr. B.D. Chatterjee, you know, he's one of the leading arthroplasty surgeons of the city. He is now going to talk about how we can optimize patients for TKR, what are the preoperative issues we should be dealing with, and how we can get better outcomes by making the patient fit for surgery.
Thank you very much, Arindam, for the very kind introduction, and Mr. Chairman, sir, and dignitaries in the audience. It's a real honor to be present here. So, what I'm going to talk is the less glamorous part of knee replacement, but it's all the more, but it's extremely important because TKR is not like trauma surgery. In trauma surgery, the patient is, in a very bad situation. So, and it's an emergency. So you can take risks and you can do. But in TKR, the problem is that this patient is actually a mobile patient up and about who walks into your OPD. And so therefore, the problem of a complication occurring is much, much more, because the thought is always there in the back of the patient that I was all right. I mean, I chose to do the surgery and now I'm in, a lot of trouble. So I think it's very important, therefore, to select the patient very, very carefully. And secondly, to prepare him or her so that the chances of having a complication is minimized. And I think one should realize that the complications, occasionally may be orthopedic or may be surgeon related, but more often than not, it is actually medical. And the reason for that is that these patients have not been appropriately or adequately worked up prior to the surgery, and you can lead to a medical complication which can be avoided. So, total knee arthroplasty started in 1968 by Gunston. In fact, very interestingly, the first total knee arthroplasty is about 3 centuries old, and the first implant which was used was actually ivory. It was an ivory hinged implant which was used in Germany. Anyway, 1968 is where the modern TKR history starts, and it's one of the most successful operations of the whole millennium, as voted internationally. So, the outcomes are so spectacular that the surgery has really grown phenomenally. However, we have to be careful in selecting our patients. If you read the guidelines laid down by the AAOS, it says that it's a gold standard for the surgery of end-stage arthritis. So that means there are a couple of riders here. The first is that it is an end-stage disease, not something to be offered straight away. And secondly, one presumes that there has been a sufficient conservative treatment which has been tried out and which has not been successful. So it is indicated when the pain is intractable and not responding to conservative patients. Generally, you wouldn't like to offer it to a very high demand athletic kind of a patient. And the patient should earn the surgery with significant reduction in activities of daily living, not just athletic activities. Then it's good to score the knee, and then it gives you an objective instrument to actually see what is the difference that you've made with the surgery. Well, if it has to be tri-compartmental involvement, because it's something less than that, then there are other options which you can offer. And of course, there should be sufficient reason to do the surgery in the terms of contractures or instability or whatever. So when you are planning for a TKR in any patient, this is the way to go. You need to do a clinical assessment, assess the fitness for surgery. Templating is useful because it helps you in the technicalities of surgery. We will not go into very much detail in this particular lecture. You have to plan your approach. Today is the day and age of alignment philosophies, so you have to select one which you are tuned to and which you think is appropriate. Implant selection and fixation, we'll just talk briefly about that, and of course other technical aspects of the surgery. So I think the questions to be asked before you embark on the surgery is, first of all, does this patient actually need the surgery? Can you manage it by some other way? And are the symptoms being exaggerated? And so many things you need to pay attention to. What is the life expectancy? Is the patient going to outlive your implant, or is the patient has a very little life left, so for you to actually enjoy the benefits of the implant. Most importantly, is the pain medically fit? And we will concentrate on this part of the patient preparation for TKR. And I think the most important point here is what is the source of pain. And that is something you really must be absolutely certain that this pain is coming from the knee and not somewhere else. Many of the time, you see, these elderly patients have coexisting neurological conditions such as dementia, such as Parkinson's disease, and these compromise treatment, and they need to be detected, and the patient needs to be appropriately counseled on this. And of course, what is the result of conservative therapy? Now, there are other sources of pain. It can emanate from the lumbar spine as may present maybe a presentation of a neuropathy or a radiculopathy or a neurological claudication. The pain may be due to vascular claudication, so you have to have a look at the peripheral vascular system. There may be inflammatory causes of pain, which may be septic or aseptic, maybe cartilage injury, or it may be one of the autoimmune arthritis, which you don't really need to do a TKR. And of course, you have to do a psychogenic assessment of this patient. So this is, of course, how you assess the patient when you're preparing him for surgery. Look for deformity shortening, what is the range of motion, because all these are important when you counsel the patient. They say that the movement which you actually achieve at the end of surgery, it depends to a large extent on what's the movement which exists before the surgery. Previous surgery scars where you need to plan your incisions, what about the distal pulsations, look at the other joints, and of course score the knee as far as possible. Counseling, again, I think is a very important preparatory step, and you have to tell them what you are exactly trying to achieve, what are the benefits, what are the complications, and I think you really need to be very, very realistic about what you are offering the patient. And it's been well documented that one of the reasons for dissatisfied patients is because you have promised the sky and you have not been able to deliver. So I think one should be very, very realistic in that. And of course, you have to tell them that this may not be the last surgery. You might need to have a revision for whatever cause. These are the routine preoperative workup, and I think the peripheral vasculature needs appropriate attention. You need to see really whether this patient has varicose veins or a tendency to DVT or atherosclerotic peripheral vascular disease. So you need to stop aspirin and drugs like clopidogrel, anticoagulants. You need to manage it until the PT is normal. Urological dental procedures should be given preference, and medical conditions must be brought under control. Look for obvious signs of infection. So the normal x-rays that we do are the standing AP and lateral of both knees. A scanogram is very useful because today it will help you to decide the alignment. The varus valgus stress views will tell you the condition of the soft tissues, and of course you need to look at the lumbar spine and the pelvis, because a lot of the time pain in the hip can be referred to the knee, and these will not respond with knee surgeries. Templating seems to be a little less popular now, but I think that it does help you in many ways. You can know exactly how much of bone you want to resect. With computerization and with robotics, I think perhaps templating is not as rigid today as it used to be. It will help you size implants, it will help you position implants, whether you want to dial in a little bit of varus to sort of reduce your soft tissue releases. Most important, I think, you will need to decide the zones of fixation. So we know that the theory of zonal fixation for longevity of the implants, whether you want to do metaphyseal fixation or diaphyseal fixation if your epiphyseal region is much too destroyed. So those are things which you need to plan. And of course, you have to do plan the level of constraint, and that's where your stress x-rays become important. You need to plan your approach. Most of the time it's the approach that you're familiar with, and most of the time it is the medial parapatellar classical approach. In valgus knees, you might want to switch to lateral parapatellar if you are planning to do significant lateral releases, or if you want to do something to the patellar or the quadriceps mechanism, because it's not a good idea to incise on both sides of the patella. You may devascularize the patella. So if there's a significant soft tissue releases to be done on the lateral side, it's maybe a good idea to plan a lateral parapatellar approach. Some people like to do mid-vastus and sub-vastus. There are protagonists. And of course, sometimes you might need to do extended approach, particularly in stiff knees, which include a quadriceps snip or a tubercle osteotomy. Implant selection, well, it depends on the age of the patient. These are the days of non-cemented implants. So if you have good bone stock and in a relatively young patient, you could opt for a cementless implant. If there's a discrepancy which you might want to make up with either implants or with bone grafts, bone deficiency you need to address, and of course the requirement of a constraint. So coming to the main part, medical optimization, and what are the cardiovascular issues which you must look for, and very often they may coexist. Ischemic heart disease, so you have to take a history of whether this patient has a stent in the past or has had a CABG. And these patients need to be counseled adequately. You need to take a cardiology opinion, and certain extra investigations may be required, such as a stress echo or even a stress-induced echo, or even a CT scan, that is a vascular CT scan of the heart. So cardiomyopathy is again a problem because these patients can have low blood pressure after the surgery, and particularly dilated cardiomyopathy, I think, is a relative contraindication. I wouldn't like to touch these patients. If there's a patient with a history of heart failure in the past, the chances are that may happen after surgery, after the stress of surgery. Generally, heart failure patients are not good candidates for surgery. Aortic stenosis is again an absolute contraindication because these patients are highly at risk of getting a sudden cardiac arrest. Peripheral vascular disease, I have myself suffered with this. If there may be a dislodgement of a plaque which may block the artery distally, giving rise to distal ischemia. So if you see a calcified popliteal artery, I think one should be very, very careful about these patients. It's often a good idea not to use a tourniquet in these, and you should be very careful when you're hyperflexing the knee because you can dislodge an atherosclerotic plaque. And I can tell you there's nothing more terrifying than having done a good knee and at the end of the procedure you find that there's no pulse distally. So all hell breaks loose after that. So peripheral vascular disease you really must take a lot of care about. Respiratory diseases, COPD is fairly common, but the thing here is you have to decide whether you want to go ahead with the surgery or you want to treat these patients beforehand. Interstitial lung disease, very common in rheumatoids, and they have an extremely poor prognosis. The problem is that these don't actually respond much to chest physiotherapy and incentive spirometry. They just remain the same. So probably you need to counsel these patients. Sorry, this is not OHD. This is yes. This is obstructive sleep apnea. So that is again very common, particularly in obese patients. These patients need more observation and monitoring of the SpO2 after surgery. So you might want to keep these patients post-operatively in a monitored bed. Bronchial asthma needs to be treated. You have to make sure that these patients are in a relatively good state of health and not going into any allergic reactions. Diabetes, almost universal. The HbA1c cutoff as of now is about 8. So if somebody has more than 8, then you probably need to postpone the surgery and control the diabetes. Otherwise, they may go in post-operatively for hyperglycemia or complications such as ketosis. If this patient has been a long-term diabetic, then look out for complications, peripheral neuropathies, vascular complications, eye complications, renal complications. So that you must document very clearly and counsel the patient. Hypothyroidism, look for all these, and those patients who are not under control, I think you need to defer the surgery and get the thyroid into reasonable control. Hyperparathyroidism is another thing. These patients come with extreme pain. So you may actually tend to over-operate on these, and these patients also do not do very well post-operatively, and there is a higher incidence of implant loosening in patients with hyperparathyroidism. Hepatorenal issues, all chronic liver disease, these patients tend to do very poorly post-operatively, I can tell you. The liver has ramifications into practically every metabolic pathway in the body. So when the liver itself is damaged, I think one really should be very, very careful, and perhaps surgery best avoided. They have higher infection risk, they have a coagulopathy, They tend to go into DIC much more frequently, and they tend to bleed. There's poor wound healing. Post-operative dialysis may sometimes be needed in patients with CKD, and all of them have very poor bone stock. So it makes your surgery difficult and your long-term results questionable. So hepatorenal issues, I think one really should be very, very careful. I think some of the investigations that you may need to do, you might need to do a fibroscan of the liver, and you need to look for HBV, HCV, which are again very common reasons for chronic liver failure. Nutritional issues. We had a very good lecture before this about the importance of nutrition. I think this is something which we are now increasingly recognizing, that patients who are nutritionally poor tend to do poorly, have more complications. So we have two extremes. We have the extreme of asthenia and we have obesity. Both are nutritional issues. So those with asthenia have poor muscle tone, and they have a problem. They have a prolonged rehabilitation. They have persisting pain after surgery. Hypoalbuminemia is something I think which we have started doing routinely, and if it's very low, then you need to correct it before you actually go for the surgery. Anemia is an indicator of poor general health, and generally if the hemoglobin is less than 9, I would like to defer these cases and take them up once the anemia is corrected. So the problem, they are all increased chances of infection, prolonged rehabilitation, and poor wound healing and wound complications. So nutritional issues are very, very important, and there is, of course, today a place for nutritional supplementation before and after the surgery. So in summary, preoperative planning in TCAL surgery is mandatory if you want a good result. The objectives of surgery must be explained and realistic counseling done to avoid post-operative dissatisfaction. Don't promise them the sky. The patients are generally elderly and must be assessed for comorbidities and appropriately prepared. And at least in this part of the country, I think this is a very big issue, that you really must look at them medically very, very carefully. So you must involve the other specialty, which is very often required, and you must have them by your side when you're treating these patients. And the surgery may have to be occasionally deferred pending medical optimization. I thank you for a patient hearing.
Well, this brings us to the end of this session. So we're going to start what is the main conference from now on. So please stay in your seats as we have a battery of speakers. And there are two mementos to be given to the two speakers, Dr. Arindam Banerjee and Dr. B.D. Chatterjee. Oh, yeah. They're the same anyway.
Okay, now we are going to come to the prestigious plenary lecture, and I'm going to invite Professor N.K. Agarwal to deliver. So, but before I call him on stage, let me tell you a little bit about him. Just give me one. Okay, so Professor N.K. Agarwal is from Ludhiana, and he has done his MS Orthopaedics from Benares Hindu University and his MCH Orthopaedics from Liverpool. He's been an international expert in Afghanistan. He's worked in UK and in USA as well as Europe. He's ex-professor of arthroplasty and traumatology of DMC Ludhiana, ex-professor and head of the department, CMC Ludhiana, with 50 years experience. He designed the Ludhiana-Liverpool X-Fix system and several other orthopedic equipments. He's given more than 150 talks nationally and internationally, published in various important national and international journals. He's a founder-president elect of NAILS in 2002 and 2003, president of NAILS in 2004, 2005, and vice president IFAS 2014 and 15. So with this very short introduction, I request Professor Agarwal to please come and take the stage and tell us about your very interesting talk, which you will I will leave the title to you because it's quite a new topic.
Thank you very much, Arindam. Thank you for the introduction and thank you very much for getting me here. Good morning, friends and seniors, ladies and gentlemen. While they set up the laptop, I'll just let you know what I'm going to talk about. I'm going to talk about osteoarthritis of the knee. With each passing year and each passing decade, osteoarthritis of the knee is increasing. The workload, the load of this disease is increasing in orthopedic practice. Already today, I'm sure you will all agree that this has become the most common orthopedic patient in our outdoors. So we are going to talk about orthopedics of the knee, how we are managing them, what is happening with our management, and what we need to shift, how we need to pivot our management to be able to give the patients a better life. Thank you very much, respected chairperson, my very dear friend, Dr. Sain. Thank you. Thank you. So we are finally there. So friends, as I said, I'm going to talk about osteoarthritis of the knee. The time is short, so I'll be going a little bit fast, but we can have few questions at the end of the talk. How are we managing our osteoarthritis of the knee today? You know, patient comes to us early on, we give him pain relief, some supplements and physiotherapy. And that prescription continues for a few years till it becomes a tricompartmental osteoarthritis. And then we advise TKR, we do TKR, patient is happy and we are happier. But I asked this question, is this victory and defeat? I thought it was a defeat. And not only me, there are many others in the world who also feel that it's a defeat of orthopedics, medicine and science. We rather take pride in changing our tools from power tools to patient-specific instrumentation to computer navigation to robots and now humanoid robots with AR, VR and AI. Is our focus more on machines and less on biology? Should we not be working on stopping the progression of disease? And that is the subject of my talk today. And that is what I'm going to allude to. And my call is, let us save our knees. And how do we do it? I will tell in the next few minutes. My talk is going to be mostly science with a flavor of common sense. There is no commerce, friends. The purpose is only to stimulate a thought process amongst you all, amongst colleagues in my fraternity. Osteoarthritis is a painful and disabling disease, and it's soon going to become the commonest musculoskeletal problem. And still, we have no accurate tool for predicting the risk of onset of osteoarthritis, nor have we got any medicines to treat osteoarthritis. Is that not a paradox? So we need to look 360 degree all around the knee. What is happening? What are we doing at present? As I said, pain relief, supplements and physiotherapy and wait for TKR. That journey can be 5 to 15 years. And to make the journey short, TKR is being advised sooner and sooner. Is that the right way to go? Having done knee replacement for 35 years, I realize that there are few downsides to knee replacement. Apart from it becoming an insensate knee, 20 to 30% patients are unhappy after knee replacement. And the two pandemics which are waiting to happen is periprosthetic fracture and revision surgeries, with increasing incidence, decreasing success rates, higher complications and higher mortality. Few months back, I came across this book, The Unhappy Total Knee Replacement, the 800-page book from the West. So I'm not the only one thinking about this. There are people around the world concerned about this issue, unhappy total knee replacement. I met few months back a fellow, one of the leading joint replacement center in our country in Hyderabad, Dr. Gurva Reddy. He asked his fellow to look at 500 knees and see how satisfied they were. And they found, if you see on the right side bottom, 20 to 35% patients in different groups, up to 35.6% patient of a large chunk, they were dissatisfied. Is that the right operation? Is that an acceptable rate of dissatisfaction? National newspaper, few months back, experts are raising concern on failing joint replacements. This is a national newspaper article, and the significant, this morning I was discussing with some colleagues, and practically everybody agreed that a significant number of knee replacements are being done which are avoidable, which we can avoid. So friends, I dive deep into the whole process of the disease. looked at the etiology, pathology, read about more than 2,000 articles as to what is this disease that we are not able to tackle. What is the etiology? I learned that all aging knees are not same. Some develop osteoarthritis, some do not develop. And it is the interplay of multiple risk factors which makes a patient predisposed to osteoarthritis of the knee. These factors can be local or general, and these factors can be mechanical and biological. Here are some of the list. All this is documented in literature. Some of them are modifiable factors and some of them are not modifiable factors. Now, what is then the pathogenesis? Friends, this is a landmark study from Stanford School of Medicine, about 15-year-old published. They brought out very clearly that osteoarthritis is in great part driven by a low-grade inflammatory process. It is an inflammatory process in the body. And the second thing which they brought out is that the inflammatory proteins are not secreted as much as they are secreted in rheumatoid arthritis. So the tests remain negative in this case. Another very important observation which they concluded towards the end, that if we can target this inflammatory process one day, we will be able to prevent osteoarthritis. And then studies after this, in last 2 decades, they have re-established this pathogenesis and they have reconfirmed that low-grade osteoarthritis is a low-grade, slowly progressive inflammatory pathology, and inflammation is both at local level and systemic. Here are some of the studies which have proven this and shown this in literature. 2 years back in our own JBJS, a meta-analysis and systemic review again confirmed that it is an inflammatory disease and the markers are raised just like they are raised in rheumatoid arthritis, but not as much as they are in rheumatoid arthritis. So in other words, osteoarthritis and rheumatoid arthritis are 2 ends of the same spectrum of disease process. They are both inflammatory diseases involving immune system, and huge lot of studies have shown this thing again and again. I'm not going to go into detail because of lack of time. So in gist, all the literature today, in last 2 decades, they have established what is the pathogenesis. It's a chronic low-grade inflammatory disorder which is slowly progressive and it is immune-mediated pathology. Osteoarthritis knee is local manifestation of this systemic disease. In other words, osteoarthritis and rheumatoid arthritis are 2 ends of the same spectrum of disease process. Only thing, the inflammatory markers are not raised as much in osteoarthritis. So the tests remain negative. They become positive in rheumatoid arthritis. So friends, what are the structures involved in osteoarthritis? The traditional thinking and teaching until few years back, I was also thinking the same. Osteoarthritis is just wear and tear of the cartilage. We tell patient, aapka goda ghis gaya, aapka cartilage ghis gaya, but that is not so. Osteoarthritis involves all structures in and around the joint, from synovium, bone, cartilage, fat pad, capsule, muscle, tendon. All these tissues have increased biomarkers. So the cause of pain is this inflammation, avascular necrosis, and the bony lesions. And the source of pain is all these tissues. If we know this, then we can target them in our treatment. What should be the proposed treatment then? Since it's a local manifestation of systemic disease, the common sense says that treatment has to be local as well as systemic if we really want to control the disease process. Friends, in last 15 years, the local treatment, the biological treatment targeting the inflammation has evolved and refined itself quite a bit and is being used all around the world at many centers. Regenerative medicine and orthobiologics are established and new branches of medicine and orthopedic science. Systemic treatment, not yet that well involved, but lot of studies and clinical trials are underway and lot of drugs have shown promise. So, local treatment has to have 2 components, the biological component and the mechanical component. The biological component is to target the inflammation, and the mechanical component is to target the malalignment and deformity, correct the malalignment, because if we don't correct the malalignment or deformity, the medicines are not going to do that. So that needs a surgical aspect. So friends, variety of drugs. These are the drugs being in different phases of clinical trials around the world to target the local inflammation, to affect the local biology of the knee joint. They are being done. What is being routinely practiced quite around the world, which has now been standardized. 5 years back, it was not that well standardized. Autologous products, biological agents from blood, bone marrow, and fat are being used to target local inflammation and have shown very successful results, and they are almost standardized then. Allogenic biological agents are driven from placental or umbilical cord derivatives, and they've shown promising result as well. I've also used them. Ozone is another molecule. The intra-articular use has anti-inflammatory properties and is being increasingly used. Friends, these are the two studies from France. Bilateral advanced osteoarthritis of the knee, one side managed by total knee replacement, one side managed by biological method. 15-year follow-up. The side which was managed by biological method won hands down on all matrices, be it complication, revision rate, failure rate, success rate, patient improvement, function, patient satisfaction, everywhere. At 15-year follow-up, there can't be a better study than this. Sorry. So friends, as far as the mechanical treatment is concerned, there are conservative options, wedges and braces, then there are surgical options to correct the malalignment, variety of osteotomies that we all do. Recently, 2 years back, this implant has been approved by FDA, the medially implantable shock absorber, which we put a small incision on the medial side, not yet available in India. We jack apart tibia and femur, they don't rub against each other, and that helps in regeneration. So friends, our practice now includes all this. We also do knee lavage before we add biological agents, because that reduces the local inflammatory load. A very novel method which has been added to our practice is from Surat, Dr. Jignesh Patel's needleplasty. Under just local anesthesia, we do pie crusting of the medial structure like we used to do in knee replacement. We were doing erosion of the medial side. We do pie crusting of the medial ligament pes and serraneus and give a valgus thrust, and see from this deformity, you can restore alignment. No incision, no surgery. And then we maintain this with biological treatment and bracing and physiotherapy. Systemic treatment has to target systemic inflammation, and of course, metabolic imbalance, osteoporosis, comorbidities, and lifestyle changes are a part of systemic treatment, and they have to be a part of systemic treatment. Friends, 2 years back in our JBJS, a study was published where they figured out that a group of 300 patients of blood pressure who were given non-selective beta blockers had 54% less chance of undergoing TKA when they compared the similar patients, another 300 patients. So it means there are some drugs out there which can reduce the progression of osteoarthritis. We only need to rediscover, and repurpose them. So this really set me thinking. That is what made me study around. These are all the drugs which are being tried, different clinical trials, targeting the systemic inflammation for osteoarthritis, showing varying degree of success. Friends, inflammation as a therapeutic target in osteoarthritis, a literature review was published just a few months back, late last year. And they found variety of DMARDs have been shown to be effective, all these studies, and all these DMARDs effective in osteoarthritis, well proven, established in literature. Friends, it has been the lack of positive diagnostic tests in osteoarthritis which have deprived the patients of appropriate treatment, and TKR industry has pushed TKR. Osteoarthritis is amenable to wide range of DMARDs. We already know that. Only thing which is not yet published is the exact dose, frequency, combination, duration of different medication, and exact regime and its safety. Not yet been published. But having said that, a very close friend of mine, Dr. Roop Mukherjee, who was with me in Liverpool, over last 3 decades, he has perfected a systemic treatment for osteoarthritis, low dose, low frequency DMARDs, followed by the mitigating agents so that they don't show the side effects, and then treat osteoporosis and give general supplements and comorbidities and lifestyle changes. We have used it for last couple of years with wonderful results. Hundreds of colleagues in the orthopedic surgery in our country have already adopted it, and they are showing good results. With this regime, this is basically the regime: low dose, low frequency, alternate day, and then followed by mitigation and then additional supplementation. This needs to be personalized and customized depending on the stage of the disease and the age of the patient and the symptomatology. So our philosophy, systemic treatment, we'd give this. We treat metabolic imbalance, we give low dose, low frequency DMARDs, and we give general supplements. We have to counsel the patient that, like any other chronic condition, treatment for osteoarthritis should also be continued for life. The doses can go up and down depending on the stage of the disease. At the same time, patient must know that we can't promise miracles. We can only improve quality of life. We can't prevent aging. So that has to be clear with the patient. Our experience with M regime has been excellent. Counseling is required, and some compliance issues can be worked around. So friends, now, if a patient comes to my practice in different stages of knee joint, my basket of treatment options is full. Local treatment, mechanical treatment, biological treatment, systemic treatment, and surgical treatments. And I customize the treatment, fit the needs as per the need of the patient, and I offer them before I go for knee replacement. Of course, if patient comes very late, there are fixed deformities, there is bone resorption, there are load of loose bodies, I happily advise knee replacement. Patients are happy, I am happy, and I add systemic treatment if I feel it's necessary to add, and the patient remains happy. Not a Now, I will just show two patients here before I conclude my talk. This is a 65-year-old lady, 10 years, gradually increasing knee pain. X-ray is not that bad, this X-ray, but on wheelchair. She has been intermittently on wheelchair, and now every conservative treatment has failed, intra-articular injections have failed, not ready for knee replacement. So we offered her our protocol. After 2 years, no surgery, complete regeneration of medial joint space, correction of deformity, absolutely asymptomatic, forgotten the wheelchair, running up and down the stairs, doing all work, household work. It was unimaginable till I did this. Nobody would have believed this, that yes, this is possible without any sort of surgery. Another patient was on bed for 1 year, very severe osteoarthritis of the knee, very severe pain, but very severe comorbidities. So, anesthetist was not ready to get her operated, patient was not ready to operate. On bed for 1 year, even for going to bathroom, she needed this walker. If you can see the walker here on the side. I asked her to show me how you walk without walker. She was not ready. Very reluctantly and on great reassurance, she started. Just a few steps she took. And then she said, I'll fall down. And this was her X-ray. And then we offered her our treatment. Within 6 weeks, she started walking. She said, I'm pain-free. I'm going to kitchen. I'm cooking for my family. And I'm doing all my household work and I don't need any painkillers. And she has not come for a long time, so I called her. I said, you've not come? He said, I'm going on holidays. She has been on bed for 1 year. So these are the patients which force you to think that something else is also possible. We should think beyond knee replacement. So friends, what is the future? Just last a bit. Friends, in future, there will be personalized targeted therapy for different knee phenotypes, intra-articular genetic therapy showing very good results, and with the help of newer lab tests, machine learning, and artificial intelligence, we will be able to predict and even prevent osteoarthritis. Biological joint reconstruction is a viable and realistic goal in this day and age with regenerative medicine. Friends, my prediction is that in next 5 to 10 years, conservative treatment of osteoarthritis will be more evolved with the objective of restoration of cartilage and slowing the progression of disease. And it will be routinely observed. And the result will be that in next 10 to 15 years, the number of knee replacement surgery are going to significantly go down, just like what happened to rheumatoid arthritis. 30 years back, more than 30% of my knee replacements were rheumatoid arthritis. Today, hardly 2-3%. And same thing is going to happen to knee replacement. So friends, in summary, osteoarthritis knee is not only aging, it's not just wear and tear of the cartilage. It's a local manifestation of a systemic, slowly progressive immune-mediated pathology. And for the first time in the world, we have put a total 360-degree treatment plan and operating procedures for osteoarthritis of the knee, which includes local treatment, biological and mechanical, systemic treatment, low dose, low frequency DMARDs with mitigation of side effects, and treating the osteobolic imbalance, metabolic imbalance, osteoporosis, and comorbidities with lifestyle changes. Targeted therapy, gene therapy, and even prevention could be possible in future, and this will help us save our sensitive knees. Friends, my message then is, can we prevent OA? Not yet, maybe in future. Can we slow progression of osteoarthritis? Yes. Can we help cartilage restoration? Yes. Can we put disease into remission? Yes. Can we postpone TKR? Yes, we are doing it every day. Can we avoid TKR? Yes, maybe if the patient starts treatment early. Thank you very much. If there are a few questions, yes, I can take a few questions. Yes.
It's gone down dramatically, and TKRs in rheumatoid arthritis is a rarity now. But I just want to know, your thoughts. Since you are thinking that osteoarthritis is a lower grade of inflammatory arthritis,
I'm not thinking this. I have learned this.
No, whatever,
this is all
whatever.
published.
So it's your belief, and I respect that. So what I mean is, do you think there's a role of biologics in osteoarthritis as well?
Yes, definitely. We have used it in few cases. Yes. Yes, definitely.
In
That's
a
a good
different
point.
dose, different dose?
Yeah, dose depending on the disease condition, because this is a low grade. It's the, one end of that spectrum of disease process. Rheumatoid arthritis is this end. This is this end, the early stage. So the dose and frequency will be different. That is what we are working on.
So thank
Dr.
you.
Sain.
No, abiding by the decisions that you have actually ignited a different flame, which probably is definitely needed in the day of today, thinking osteoarthritis in a different way.
Thank you. That was the objective of
Yeah.
my talk.
So thanks a lot, and understanding that probably the time constraints don't permit other questions, and as far as the keynote speaker, there are supposed to be no questions. So thanks a lot. It has been a wonderful new idea given by you, and I hope more people will try it out and have
Thank you.
experience.
No, in the
of new
whole
things.
world, there are people who are doing local treatment, as I showed you, 15-year study, good results. Some people doing only DMARS, good results. But we have first time in the world put together a 360-degree treatment, local treatment, biological, mechanical, systemic treatment, physiotherapy, conservative, everything included.
So thank you. That was a wonderful new insight into the business. Thank you. And now I invite you to.
So I request.
Yeah.
I request Dr. Agarwal, please. Our next speaker is Dr. Swarnendu Samanto. He is speaking on the challenges in the management of distal femur fractures.
Good morning, respected chairpersons. My mentor, Professor Sen, is also there. Seniors, Indra, Orindamda, Omigoda, and all my colleagues. I am going to talk on the challenges in the management of distal femur fracture. I think distal femur fracture, if we classify whatever, probably follow the AO classification because this is the simplest one to remember. A, B, C, extra-articular, then the partial fractures, and the completely articular fractures might be C1, C2 or C3, whatever way. But I think that is the best classification to follow. So the problem is that most of the time it can come as a simple, it is not being compound, but sometimes some bone is peeping through the quadriceps and the quadriceps is also injured. And getting back the motion is always a challenge. So there are two challenges. One is the how to fix the articular segments so that you can give early motion and you can have mostly near normal movement, because if the patient is limping, he is not happy. Even if you have the excellent fixation, excellent looking X-ray, but if it is stiff, if there is some flexion deformity, then it is a problem. So I think the A1, the metaphyseal injuries are probably a bit simple. We can fix it by the open technique or the MIPO technique. The partial articular, the HOFA, the B3 looks very simple, but I think we all agree that even if you do the best possible fixation for the HOFA, they are mostly stiff. Even if you do the posterior approach, you do the fixation from the backside, you and fix with the small plate to give the anti-glide motion, or else you fix with the plate and screw, or from the front, still they are stiff. And C3 is more, C1, C2 and C3, I think C3.3 is the ultimate. It has all been complex. So I am going to present few cases so that we will understand that. I am not going to the detail of the classification, probably the large audience, we all know that how we classify this. If you see this sort of fracture, now there is also a debate that some people like the tibia, the extreme nailers for the tibia, and there are some extreme nailers even for the distal femoral fractures. So I think you can choose your implant accordingly, but the principle is same, that like your distal humerus fracture or any articular injury, whenever you fix the articular side, it has to be anatomically reduced and rigidly fixed. The metaphyseal part, you can do whatever you like with the nail or plate. It can be just a bridge mode. It is going to unite, but the problem is the articular segments. Sometimes some missing fragments, you cannot handle it, even with the harbor screw, even with the bio K-wires, you cannot manage those fragments. And sometimes these injuries are also been associated with the neurovascular problem. So then you have to sometime, because it is a compound injury, then you have to scan it, then you can go for the fixation. So like the proximal tibia fracture, you can think about the distal femur fracture like your proximal tibia, because this sometimes this been associated with the neurovascular soft tissue, all these complications. You see, sometimes there is some even there is some void on the medial side. Now there is also a debate that whenever you find some void on the medial side, you have to attack from both the sides, medial and lateral. And there is also some new thoughts, new classification system, new guideline when to go ahead with the medial sided approach, so that after doing the medial lateral side, you have to do something on the medial side, buttress it so that it doesn't collapse on the medial side and it doesn't lead to failure. Basically, it is like the bilateral, like the sandwich plating. So you see this sort of fracture, I think any articular injury, even now people are doing the CT scan for the distal radius fracture to see whether there is any articular injury. So CT scan is must for like your proximal tibia fracture. So we have to fix the articular segments like the distal humerus or the proximal tibia most accurately with rigid fixation, so that you can give early motion. That is the crux of the fixation of any articular injury. Metaphysis you can do whatever, like nail plate. Then the open wound, the vascularity, as I told you, then the osteoporotic, even the geriatric people are getting this trivial fall and they are having fractures. Even the periprosthetic fractures are also there in the distal femur. So pre-op planning is very important. We have to understand the fracture and then we have to select the approach. When we started doing the distal femur fracture, probably we all started from the lateral big approach on the lateral side and flip the patella on the medial side. We see all the articular segments and then we fix with the small screws or 4 mm screw, 6 mm screw, Harvard screw, K-wires, bio-wires, whatever. The big approach. Then the MIPO came. Then the thing is that the MIPO doesn't give you the license to do some fixation where your articular segments are not being fixed properly. So I think we have been been educated with, because from 90s onwards we have seen these implants, because that time the classic implants, the locking plates were not available during our PG days. So we have used these cobra sort of plates. If you see from the left to the right, this is the evolution how we have been taught to fix the distal femoral fractures. Now the variable angle plates are available, the long plates. So we have got lot of implants in our hand from the different sort of plates, the variability, locking implants, and the nails. The thing is then how to reduce, and I think we all do this distal femoral fracture, even in nail or plate, we put a bump on the backside so that we negate the force of the gastrocnemius, because the gastrocnemius is going to pull the fragment down so that it is being extended. You can go from the front, you can go from the lateral. Your injury pattern, the complexity of the fracture, the wound, all will dictate. We have all been learned the lateral approach, then we have done the swashbuckler approach, the modified swashbuckler from the front. But the thing is that which is the best possible way to see all the articular segments. If the articular segments are completely been crushed, it falling into the category of C 3.3, I think even if you go from the lateral side, you won't be able to attack the medial segments. You will be not seeing the end on view of the joint. It is better to go with the swashbuckler. So I am not going to give you every detailed step because the time has been limited. So all the armamentariums should be in your hand so that you can fix the articular segment fast, because it is the building the block. First you have to build the articular segment properly, then like your distal humerus, build the articular block, then connect it to the metaphysis. The same thing, same principle. Only thing is that which implant you are going to choose, which approach. I think the complexity, the type of the fracture, The wound will dictate the approach. Either you can go from the lateral approach or you can go from the modified swashbuckler or the classic swashbuckler from the front, so that you can see all the segments, all the fragments of the articular side. We can do the MIPO, but I think for C3.3, MIPO is not the way. You have to see the fragment. If it is big fragments, only two fragments, C1 or C2, you can do it, but C3.3 is beyond for the MIPO. This is the way how you can pass the MIPO surfer, then you can put the plate. Long plates. Then whenever you check this, that you have to check that your distal fragment is not been in extension, because gastrocnemius will pull the fragment backside. So you have to put the bump, you see how the bump is been given, and then you see that there is your posterior cortical continuity of both the segment, the proximal and the distal, is matching. Otherwise it will fix in extension. That is the problem. So this is the way how you fix and how you repeatedly check your C-arms. And if you do it properly, then you will get the best possible result. Sometimes the distal femoral fracture is also been associated with the proximal tibia. You have to attack that also. Rehab is very important, because unless you do a proper fixation, you cannot go with the early rehab. Remember, even if you get like 110 degree motion and the patient is having 5 degree of FFD, the patient will limp. So the primary goal is that you have the extension to nearly 0. Even if he is flexing to 90, he is happy. But FFD beyond 3 degree, patient will limp for lifetime. So you have to get back the extension to 0. So that is the crux of your physio. And then the medial side, how to do with some people are too adamant that whenever you fix the C3.3 or there is medial combination, you have to do it from the medial side. People agree, people disagree. But I think if there is a void on the medial side which is more than 2 centimeter, if there is lot of combination, then you have to fix on the medial side, you have to graft it. You don't have to wait for it. It is better to fix so that it is rigid, you can go with the early physio. You see this fracture, this has been comminuted. Then you have to go with the stage method so that you can eradicate the infection. Then you go ahead with the proper thing. Then you have to, sometimes you put the vascularized fibular graft so that is too much of bone loss. You see, this is the way how it was managed. Then you can do, you see, bone was lost when the patient came. There is loss of bone, and we did the masculae, 2-stage, and then we fixed it with the fibula, then the tibial graft. We took the graft from the front of the tibia. And you see, if you do it properly, you can get back the motion. So these fractures are always been challenged because of the complexity of the fracture, then the compound injuries, and how to get back the motion to 0 to at least to 90 degree functional range. So there are many papers are there. You have to meet the complications. Dual plating, as I told you, sometimes you have to go on the medial side. People say, I told you, and then the complexity with the TKRs, with the periprosthetic distal femurs. You can do the nail or plate. So respect the anatomy of the distal femur, understand the personality of the fracture. The open wound will make it complicated. Metaphysis, you obviously respect the biology. Maintain the same principle of any fracture fixation, the length, axis and rotation. You have to do a very stable fixation so that you can go with the early rehab, because otherwise the best possible fixation with a stiff knee, the patient is always unhappy. And always anticipate the complications and counsel the patient that you are not going to get back the 120 degree of range. Thank you very much for your kind and patient hearing. Any question we can take, Arindanda, that this time or?
See, the next 2 talks are virtual. So while we are setting up, I think please you can take 1 or 2 questions and one.
So we can take expert comment from Ramesh Sen sir on the distal femur, because always there is a debate. But my question to Ramesh Sen sir, when you will advocate the medial sided approach, when you will add on the medial plate, what is your criteria?
No, incidentally, because I don't do trauma for last 15, 20 years, so I'm not much aware of the latest. But we have done a lot of these cases before the recent concept speaking. It's very important that the stability, whenever your articular reduction remains the primary thing, whether we go with the MIS or something, but the reduction at the articular level. And then when we are stabilizing enough, the stability on the lateral and medial sides are very important, especially we remember the older implant we used to use was a blade plate or the DCS at that time. That was able to take care of the medial side. But once we have come with the newer plates also, so the stability on the both sides have become much more important. And we did use the fibula, not the vascularized fibula, but a non-vascularized fibula to support the medial sides. So whenever there is a comminution, whenever there is a integrity problem in getting the stability, we feel that there has to be a stabilizing bone on the medial side also to support it out. And that way we can have a better biomechanical stability across the fracture to give us a union. Another very interesting thing, we have found it out that because initially for the first 15, 20 years I had done a lot of this trauma and as the distal femur trauma. So we had seen that if your articular management is okay and if your stability is reasonably good, the union invariably happen depending upon the biomechanics. So personally the biomechanical stability remains the key, along with whether you support it with the graft or with the kind of a block graft with a kind of a fibula and all that.
Okay, thank you.
Okay, thank you. So please.
Has there been any anthropological study on the shaft condylar angle? Because most of the Indian plates that are available are not fitting on the lateral side. It's away from the surface of the femorocondylar angle. So when you try to fix it properly, the whole thing moves, the fracture gets displaced. The reason why I'm asking this, that we carried out a study several years back and presented in the IOA, that on the femorocondylar angle, most of the Indian plates did not match that curvature. There's one or two foreign plates which do marvelous curvature, which fits exactly into the place, so that when you put the screws in, the whole thing and fix the plate, the fracture remains steady. So whether or not that is available, or should it be available nowadays?
No, I think this is a great question. The curvature on the matching of the plate, if you are going with the longer plate, that is a problem. The problem is that I think the learning that whenever if you do the DCS or the older implants, then your accuracy has to be match to match. Otherwise, the plate is going to displace the fracture. But nowadays, with the locking implants, you have got the flexibility. Because in the DCS, the guide wire has to be your 95-degree angle, then it has to be parallel to the joint. Otherwise, that time the locking screw was, the cortical screw was there only there. So that if you give the cortical screw will malreduce the fracture. So that is the problem. But nowadays, we have got the combination of the holes, so that the basic idea is that you don't press the plate on the bone surface, because with the cortical screws, then it is going to displace the fracture. So the locking screws, at least 5 has to be there on the articular block, because you have got the variability of putting the screws. And if you want to put the plate flush on the bone with your first screw on the proximal segment, then the problem is that it will drag on the bone to the plate and the distal fragment will medialize. That is the problem. So be very cautious about putting the cortical screws on the proximal segment. Distal fragment you have with the variability. But now with the beautiful implants, the problems which you faced, I faced, Ramesh Sensor faced, because that time only the rigid implants like the DCS and the angular blade plates are there. Now with the variable angle, it is not the problem. Now what is the problem with the longer plates? It doesn't match with the bow on the top side. If you go beyond 10 hole plates, then it is a problem. Otherwise, it will match. And remember that when you give the locking screw for the juniors, those who are not been, because I have also faced the problem. If you are giving the locking screw at the end of the plate, then it should be half locking screw. If you give a full lock screw, then it is a disaster. It might break from there.
And not necessary to be bicortical.
Not the. That's why I told it should be unicortical. The last screw.
The technical change what we used to do for the same situation was that when you put a screw, I used to put in under the plate 2 washers. Under the plate 2 washers and then tighten, and that was able to maintain. That was a technical trick we used to do at that stage. Either you have a cortical bone to get under the plate or 2 washers or 3 washers depending upon the amount of deformity you are likely to generate. So you used to stabilize like that. That was a trick. Yeah, that is what we were doing. Yeah. Ideally not.
We should have Indian data available so that the contour, otherwise plate will be much more prominent. And that's why the bow as well as some washer technique we had to take because of the even 8-hole plates also that does not match the curvature. So the anthropological study for the Indian population compared to Western, that's majorly needed. Moreover, if you because of the Western people's data, the plate is much more wider. That's why anterior and posterior screw you cannot have purchased if you are not careful. You may perforate it posteriorly. Okay, so that's very pertinent question you have raised in the.
Yes, the.
Yes.
Every human is different. You can never make any plate which is perfect for anybody. So you have to depend on the locking screws only. And what Bera said, that posterior screws, but that you have to adjust so that the posterior screws must be bicortical. Or even have to reach the other medial side of the condyle. Not that just simple, but the lowest screws very rarely goes beyond the intercondylar region. Lowest screw. And regarding that washers, what Dr. Ramesh said, sometimes everybody has to use washers. This is a very common thing, particularly the lowest screw.
Yes.
And if you use the synthesis implant, where the bowing is much more compared to our females particularly, when you are going to use it, it will never fit in. About 2 to 3 millimeter gap will always be there. So put on the washers.
Same principle. If we suppose we fix the proximal humerus fracture.
Same thing,
Same
same.
thing. When you put the pillows, if you don't put your something beyond below the plate, now people are putting the artery below the plate, so that if you put the cortical screw, automatically the head will go into the varus. So that has to be prevented. And the beauty is that implant with that, now we have got the variable angle screws. It was primarily, it was only the locking screw which will go in one direction. So now the variable angle screws are there. And the question what Bera sir is asking, Indoda is asking, with the variable angle system, you can direct your screws. And the distal screws are never bicortical, because if you go if you go bicortical on the distal screws, you are going to irritate the MCL and patient will bother you for lifetime.
Particularly you can push the medial fragment more medially.
No. The problem is that you cannot, you should not go beyond the medial cortex. Should not go.
Just touch.
Just touch it and
Subarticular.
it is just the below the cortex.
Below the cortex.
Thank you.
Thank you, Swarnanda. We should conclude the session, and next session is about.
Very nice discussion, but I think we have to proceed. We have 2 virtual lectures after this. So for the next session, may I call upon the chairman to please come to the stage. Professor Niloy Das. Niloy Da, please come. Professor Omio Bera and Dr. Satish Mutha. Satish, are you here? Please come to the stage. Dais. Okay, now we have a virtual lecture from UK. And this is Kapil Sugandh, who's an expert on peripheral nerve disease. So he, as you know, peripheral nerve and brachial plexus injuries were improved a lot by one of my teachers, Professor Birch from UK, and he has worked under Professor Birch, and he's doing a lot of brachial plexus injuries. The prognosis has improved, I believe. So right now we are going to start the lecture online, and it's possible that Kapil might join us. I'm not sure. He's got the link. Please go ahead. Start.
Dear esteemed guests of the World Orthopaedic Concern Congress 2025, thank you very much for the opportunity to speak about brachial plexus injuries for non-specialists. I'm Kapil Sugand, a former locum consultant peripheral nerve surgeon at the Royal National Orthopaedic Hospital in the UK. These are some of the quick schematics you are aware about. We break down the brachial plexus into roots, trunks, divisions, cords, and terminal branches. The trunks line the posterior triangle of the neck, and you can see them between the scalenus anterior and medius. Here are some common pathologies within idiopathic and intrinsic causes. Here are some of the pathologies due to extrinsic causes. Feel free to pause to have a look at the details. So be aware of the typical patient that presents with a brachial plexus injury. Using narrow class rule of 70s, 70% will be the following. Male patients caused by road traffic accidents involving motorcycles or bicycles, having polytrauma, a supraclavicular brachial plexus injury, root avulsion injuries, plus or minus involvement of the lower plexus, and chronic pain. Appreciate the types of brachial plexus injuries, whether that is an upper brachial plexus or a lower brachial plexus, in relation to where the arm or the hand is and the abduction of the shoulder in relation to the neck. Most of the injuries you will see involve either an avulsion, a traction or stretch injury, or a rupture, depending on the relation of the injury to the root ganglion. You'll be aware of several classifications, but we use a simple one that was devised at our unit decades ago, which is a Birch and Bonney. Either the lesions are non-degenerative or conduction block, or degenerative with the presence of a tunnel, for example. The most important thing to ask is where the lesion is, and that comes with knowing your anatomy, understanding the mechanism of injury, a thorough examination of the brachial plexus, and seeing if there's a presence of a tunnel sign. Another thing to consider is how deep the lesion is. In non-degenerative lesions, there's a conduction block without a tunnel, no fibrillations on your EMG, and a distal and patchy conduction to the site of the lesion. Now, if the lesion is not removed in due course, there can be a prolonged conduction block, which can then eventually lead to a degenerative picture, which can either be favorable or unfavorable depending on the progression of a tunnel sign and if the cause is still not removed. So, as a brachial plexus surgeon, it's important to figure out the right treatment for your patient. Now, what are you really treating? Is it a conduction block or a degenerative lesion? In conduction blocks, there is no tunnel, there is presence of a distal conduction or patchy neuropathy that resolves sooner once the lesion has been removed, and there's not always neuropathic pain or is come and gone. In degenerative lesions, these tend to be high mechanisms of injury involving high energy, a presence of a tunnel, neuropathic pain with some sort of positive signs on neurophysiological testing, imaging, and demonstration of scarring under histology with a slow recovery of 1 to 2 millimeters per day, but that is anecdotal. Here are some examples of the upper trunk lesion of the supraclavicular brachial plexus involving C5 and C6 nerve roots. We have a medial winging of the scapula due to involvement of the long thoracic nerve, which is C5, 6, and 7. We have a raised hemidiaphragm due to direct involvement of the phrenic nerve coming from C5, And there might also be involvement of the rhomboids from the dorsoscapular nerve, which also comes off C5. As opposed to lower trunk lesions of the supraclavicular brachial plexus, where we see signs of Horner's syndrome, including ptosis, meiosis, and anhydrosis, due to the involvement of the sympathetic chain, as well as signs we see in the hand that we also often see in thoracic outlet compression syndromes. These are Gilead-Sumner signs, which involves atrophy and weakness of the intrinsic muscles of the hand, involving the thenar, hypothenar, and the first dorsointerosseous compartment that you can see on all three views. Much like many other specialities, we also use a nerve reconstruction ladder, starting from a neurolysis, which is decompression and exploration. We do a primary repair with sutures and tesseals, graft reconstruction, either being autograft or allograft, nerve transfers for neurotizations. Common ones are spine accessory nerve to the suprascapular nerve, Oberlins to restore elbow flexion, and Somsax to restore shoulder abduction. In chronic cases where nerve surgery may not be possible, or there aren't any donors for transfers, then tendon transfers and fusions tend to be utilized. Common ones are for wrist drop and for a foot drop. At the end, we also work with our plastic surgical colleagues for free muscle transfers, usually involving the gracilis and intercostal nerves as donors. Here you can see some examples of the reconstruction ladder in action, the first one being a simple neurolysis and a decompression of an entrapped nerve. 2 is a primary nerve repair with sutures and tesseal. 3 is cable grafting, taking a donor nerve for grafting a long segment of an injured nerve. 4 is a nerve transfer for neurotization. 5 is a tendon transfer, and 6 is the free muscle transfer. In degenerative lesions, because they take a long time to recover, as we mentioned anecdotally, 1 to 2 millimeters per day, that's the same rate as your hair growth. We understand that the shorter the distance the nerve has to regenerate, the better the prognosis. So we have 2 types of patients with lower trunk injuries and upper trunk injuries. So you either have a good shoulder and a bad hand, or you have a bad shoulder and a good hand. Now, the people who have the bad shoulder and a good hand, that tend to be upper trunk injuries, they tend to have a better prognosis because the length of regeneration and reinnervation is much shorter. The problem is that anywhere between 14 to 18 months after the injury, if the muscle group is not still re-innervated and the nerve hasn't regenerated fast enough, then the motor end plates tend to fibrose, they tend to wither away, and this becomes an irreversible and irreparable prognosis. So the patient will end up with long-term disability. So we see this more in lower trunk injuries. This is where we also have to consider distal nerve transfers, tendon transfers, arthrodesis, and free muscle transfers. Here are some prognostic factors that involve the mechanism of injury. You have worse prognosis in high energy injuries, avulsions, which is a detachment from the spinal cord, concomitant vascular injuries. Younger patients do better, especially if there's a shorter distance of recovery. The type of nerve if it's one or the other, sensory and motor, as opposed to mixed. The level of injury, where supraclavicular brachial plexus injuries tend to be worse off than infraclavicular ones. Upper trunk have best prognosis because of a shorter distance of regeneration and reinnervation. People with chronic pain and sympathetic loss have poorer prognosis. And the time of the surgical intervention, time is muscle, time is nerve. As I mentioned, that if you don't remove the lesion within a timely manner, this could lead to long-term muscle atrophy, disability, and even paralysis. Other factors are patient-induced, such as comorbidities and use of certain medications that causes immunosuppression, immunocompromise. They tend to do worse. So when should you refer to the peripheral nerve injury unit or to a brachial plexus surgeon? That is when there's an emergency, which is a transection. You don't write them an email, you don't send a message, you call them up, whoever's on call, and you explain the situation, because this is where there's a limited time window to do a primary repair plus or minus grafting. So please feel free to pick up the phone and call your local specialist surgeon for this. Do not wait. This will certainly affect the patient. There are other things that you need to have done prior to referring this on. If there's a fracture or a joint dislocation, operate, reduce the dislocation, restore stability. Without that, anything we do to the nerve will not work because of the risk of further compression injury due to instability. If there's a vascular injury and a hematoma formation, please evacuate the hematoma, repair the vascular injury. If you don't do that, that will act as a conduction block in another lesion, no matter what we do to help the nerve. If there's a traction injury and the nerve is still intact, then it's just a matter of holding your horses and keeping a very close eye on your patient with serial examinations. Send them to physiotherapy to avoid contractures, give them neuropathic analgesia, and you can always conduct neurophysiological testing in 6 weeks to look for any signs of degenerative lesions or non-degenerative lesions, as mentioned before. If there is an obstetric brachial plexus injury in a newborn, wait at least 6 weeks, because the majority of them tend to be traction injuries, which tend to show signs of healing and progression. And also, if you're concerned about a brachial plexus injury, examine the patient and make sure there aren't any such fractures that have been overlooked, such as proximal humeral fractures and clavicle fractures that also need to be stabilized in swaddling. I'd like to finally thank all of you for attending the presentation, and please do not hesitate to contact me with any questions. I wish I could be there in person, but I hope you have a wonderful rest of the Congress and hope to see you all soon in person at the next one. Take care. Bye-bye. Dear esteemed guests of the World Orthopaedic Concern Congress 2025, thank you very much for the opportunity to speak about brachial plexus injuries for non-specialists. I'm Kapil Sugand, a former locum consultant peripheral nerve surgeon at the Royal National Orthopaedic Hospital in the UK.
Okay, so we proceed without, I think it's replaying. So let's go to the next talk. Professor Manish Khanna from Lucknow was supposed to give it in person. He even bought his tickets. Unfortunately, I think his institute has an NMC inspection today, so he had to pull out physically. So his tickets were unfortunately non-refundable, couldn't do anything. But so he sent his lecture on orthobiologics. So let's start straight away. Couple of things. We are live on OrthoTV. This is being covered on OrthoTV. So anyone who wishes to hear any
lots
lecture
of
later.
congratulations to the entire team of WOC for this inaugural conference. Unfortunately, I'm not able to reach there because I'm having inspection in our institute. So even the Sundays are involved in it. Anyways, thank you so much for giving me the opportunity of the plenary lecture. Well, the topic which is assigned to me is Orthobiologic. So we welcome you all on behalf of Indian Stem Cell Study Group Association. And in next 15 minutes, we are going to discuss in orthobiologics where we have reached, how we have reached, and what is the needful which is to be done in future. Well, it's a cellular therapy. Truly speaking, whenever we say stem cell therapy, it's a misnomer. The correct terminology is a cellular therapy. And the cellular therapy means it is a therapy of the progenitor cell, a mixed cell population, which is being approved with some conditions by ICMR also. So in orthopedics, how we are going to use it, where we're going to use it, I'm just in the next 15 minutes just going to share my views, my approach, the journey which we have covered, just to fulfill the thirst, the curiosity for the learners. And as all teachers know, only a passion can be initiated, and rest is up to the listeners. So definitely yes, in last decades and decades of time, from conservative to aggressive approach, surgical approach, as far as the surgical specialities are being considered, is the best way. But even in the surgical specialties, we come across that even if we are very much aggressive, the results are not so good. So in those conditions, in those situations, we may require a help of regenerative science. It's not a new term. It was being started in 1998, at that time when we were finishing our MS. So more than, almost 27, 28 years back. So the first stem cell was being extracted from human embryos in 1998, and then the ball started rolling. For diabetes, for beta cells, insulin-making cells from the cadaver were being extracted in 99. Unfortunately, in 2001, the President Bush restricted the funding, which was being gradually again allowed in 2009. And in 2002, the California, the UCSF, the University of San Francisco, that has started a wonderful research work. So that was the seed which was being implanted in the soil at that time, and which has multiplied, and what we are seeing the result now in the right way. Truly speaking, stem cells are a new term, or cellular therapy is a new term to some, but actually it has been there since decades and decades. And our body, every portion, as we are orthopedic surgeons here, so I'll say the periosteum, the skin, the marrow, and everywhere we are having the stem cells, the the progenitor cells. Now, when we are saying the progenitor cells, actually we are meaning by the hematopoietic stem cell and mesenchymal stem cells. Now, hematopoietic stem cells, they are commonly being used, and there are a lot of work is being done in India also, and all the place, and it has been very well used in the treatment of the malignancy. So these hematopoietic stem cells means mainly we are bothered about the CD34 cells. And of course, all these cells, 34 cell, 45 cell, they secrete growth factor. When we say the mesenchymal stem cell and we extract a bone marrow, for example, so it is having very less number of cell. And again, the main content is of hematopoietic stem cell or the mixed cell population. But ultimately, the growth factors are the thing which is giving the job, giving the things, producing the results. So a win-win situation has been there. So it's a paraclean effect which has been there. Now, MSCs, or you can say the progenitor, endothelial progenitor cells, or a progenitor cell at a particular organ, at a particular tissue, they differentiate into their specific cell type, which may be osteoblast, it may be chondroblast, it may be fibroblast, whatever it may be, which automatically do the things up. If we are saying a niche, or niche may be in an adipose tissue, entire adipose tissue the niche, or a bone marrow, which orthopedic surgeon play with it. That is the iliac crest, the most common site, posterior iliac spine or anterior iliac spine. So that is a niche area in the bone marrow. A specific microenvironment is being there to make these cells rest out there, and when it is required, they do their job, or we extract them out. In orthopedics, practically decade back, it was fracture, and we all know how a fracture unite or how a cellular healing occur. But actually microscopically, if you see, so whenever there is a fracture or whenever there is a soft tissue injury, it is the platelets which release the growth factors, and as a result, the progenitor cell which are lying out there, they do their job of stimulating the angiogenesis or whatever the tissue repair is being done. Similarly, the GCS growth colony stimulating factor, gonadotropin colony stimulating factor. So these are the factors which are again being released by the endothelium whenever an injury is being there. So they are again going to stimulate the niche area to send the cells to that particular site, and that's how the repairing occurs. So we all know about the different platelet and their growth factor. A list is there, which is out of the discussion for this particular topic. And effect is already been there in the newspaper and under the cover, over the shelf, everywhere. And these are the few examples which you can see on the screen right now. Now, as well as in orthopedic, biomechanical role has been considered. So biomechanical role is not a new thing actually. In 90s at that time when we're using, or in early 2000 even, in fact, PTB. So if a tibia fracture is there, we give a PTB because we want the patient to mobilize so that the weight should be transmitted. Similarly, this is the Elizaro or whatever the external fixator which has been there. So biomechanical role is always been there. We have to understand how it is to be used or where it can be stimulated. Now, the classical definition of the delayed union was like when the surgeon feels that there's no potential to heal, no potential to unite. And of course, that depends upon the content at that particular site. The endogenous pool of the stem cell, if it is working, it is active, it is not active, then we should activate them up. If they are less, then we should stimulate more cells to come to that particular site and to do that. And for which age of the person, if the age is less, so definitely other factors are being there, which have to be taken into consideration. So these endogenous progenitor cells, you have to use this, you have to remember this term, endogenous progenitor cells, they are the main thing, whether we are talking about treatment of osteoarthritic knee, whether we are talking about, to some extent, avian or any delayed union or anywhere, any chondral lesion, anywhere, everywhere. It is the same thing. Now, it has been experimentally proven that by flow cytometry, that whenever there is an abnormal or a normal stress given to the particular site, at that particular site, with the compression, there is a stimulation. And that is why we were seeing with the walking, the delayed union fracture can be converted into a uniting fracture. Now, this slide is important for me because I was a foot surgeon, basically doing a lot of CTV cases. Whenever we do a neglected bad cases, we come across that how they are going to change their dimensions. So now the cellular definition of non-union is that at that site, the site where the progenitor cells are not active, they are in poor status of proliferation and differentiation, that's a non-union site, right? And there what we do? We may place a PRP, we may place a bone marrow concentrate, we may place an autologous MSC or an allogenic MSC, whatever it may be. Ultimately, the aim is the paracrine effect, the growth factor, which are going to do the job. Now, this I want to again re-emphasize that why the bone healing is better in the children, because the children, they have more progenitor cells circulating here and there at particular site also. So the union is better. And if you see the literature, they have actually 10 times more stem cells per milliliter of the bone marrow than adults. So much abundant. So that is why we are not bothered about any of the fractures in the children, truly speaking. In orthopedics, we can say the role is fracture healing, non-union, delayed union, cartilage repair, osteo, a list is endless. Tendon, skeletal muscle repair, spinal cord degeneration. So, I mean, its list is out to be, we can't discuss it here actually. So, we are having a lot of indications. And the publication says, I mean, not from the starting of this 2002, we came across that whenever there is a negative pressure, for example, you do a Elizaro or you do a just fixator, whenever there is a distraction is being done, actually this negative pressure is stimulating these progenitor cells to multiply, to produce the growth factors, to stimulate the endogenous cells again, and to do the job. That is why limb lengthening procedures are there. Or for example, in the CTV, you can see that even if the so much of deformity has been there, even the ligamento-taxis is producing a regeneration of articular cartilage. You can see a regeneration of a good remodeling of the bone is happening. How it's remodeling of bone is happening? It's all because of this. So anyway, in 2013, because of all these using gradually, what we thought was that yes, PRP and BMAC is very effective. So we created a group, WhatsApp group at that time by the name of Indian Stem Cell Study Group, and the newsletter was starting circulating here and there. Then we registered the body, orthobiologic body of Indian Stem Cell Study Group. We started the meetings with the Indian Orthopaedic Rheumatology Association. I'll just move a little faster. The first meeting was being done in Madurai in 2015, then 16, and the ball was keep on rolling and rolling. Gradually, it was found that not only in orthopedics, in the gynecology, in the medicine, in the neurology, very much use is there. So we created another association, Indian Stem Cell Study Group Association, where it's a body having different specialities. The scientists, the basic scientists who are contributing to it, and the clinicians in different specialities who are using it. Like andrology, obs-gynae, dermatology, everywhere. Dermatology we all know very well. 2018 was the year when we had our first international conference, and then year after year we are starting having all the conferences, third international conference, fourth international conference. Osteoarthritis is the most troubling thing, and I think we all agree that within few decades of time, it will be the most common thing. So I'm not going to go in the detail also, but publications are there because see, it is an evidence-based medicine. If you are placing a BMAC or MSC content in a joint, and if you are seeing that the articular cartilage, which is thin, has become a little grown up, or the menisci, which are degenerating, they are regenerating, and the things have been established in the literature, then it means it is working. So definitely, yes, you need a MRI for that. And in some time if you're doing a high tibial osteotomy, even then, at that particular compartment may be requiring a shot of BMAC or a MSC. Similarly, in ACL, partial ACL injuries, list is long, time is less. AVN, we all know AVN is wonderful in receiving the stem cell at a right stage, actually speaking. And then Indian Stem Cell Study Group, along with the IUA, we are doing a lot of webinar. Rather, we have done a lot of webinar. We are not actually into it. And this was a Nagpur conference. A lot of every year activity. So I don't have a time. And this we had just last 2 months back, the international conference at Goa. As far as the world has been considered, the globe has been considered. In Great Britain, the stem cell research has been allowed. In France, they're having less liberal policies. In Germany, they have a very strict policy, but in Asian and South Asian country like us, we have a permissive category, and it has been defined by ICMR, autologous with the proper Helsinki declaration with the minimal manipulation. It can be worked up, and to create evidence-based evidence, especially the level of evidences, which you can see here in this chart, the level 1, which is really difficult for a normal common orthopedic surgeon. But a common orthopedic surgeon working, doing a lot of cases, can produce a case series, at least can generate a level 4 evidence, which will be helpful. So in the end, I would like to say that yes, definitely role of cellular therapy or PRP is there in the orthopedics, which may be in the form of BMAC or MSC, whatever it may be. Only what we require is a right case selection, a proper clinical trial to be initiated to give the best result. We have a textbook, Orthopaedic Rheumatology, so it is available, and we have a lot of chapters there also on the stem cells. So if anybody is interested, they can type in the Google, they can have this book. It's available on all the platforms, published by JP. So what we can do, we can just continually support the initiatives for this basic and transitional research in the orthopedic and other specialty, and that is how we can contribute it. We are also having a fellowship program in interventional orthobiology and orthorheumatology, FIORA, which is now running into the 7th year, and a lot of orthopedic surgeons, young orthopedic surgeons throughout the country, they are, I think we have now, till now, almost 60 orthopedic surgeons are now being, cleared by the FIORA. Thank you so much for a very patient hearing. I request that we should only just try to have a proper case selection where this work can be done. That is the most important thing. Thank you so much for a very patient hearing. Thanks a lot.
Hello. So unfortunately, our next speaker, Dr. Ibriz Rakshan, was unable to attend today because of the recent conflict. She wasn't able to fly from Kashmir. So very kindly, our faculty, Dr. Samundeswari Sasinder, has agreed to give this presentation. So I invite her to the stage.
Good day, everyone. Today, I thank WOC India chapter, Dr. Radidam sir, and the Scientific Core Committee for providing me an opportunity to speak about proximal humerus fractures of the elderly. Myself, Dr. Samundeswari Sasinder, I am Assistant Professor of Orthopaedics from Puducherry. So, we are going to see about the elderly proximal humerus fractures in the elderly. So, what is the age criteria? More than 65-year-old is considered to be elderly according to the WHO classification. And United Nations says young old as 60 to 74 and old as 75 to 84 and oldest more than 85. We should also understand the core applied anatomy of the proximal humerus, the 4 parts which we are going to fix, the vascular supply and the neurovascular structures around this joint to treat these fractures well. And it is the second most common upper extremity fracture and the third most non-vertebral osteoporotic fractures apart from proximal femur and distal radius fractures. And 10 to 40% of these fractures need to be fixed surgically to have a better functional outcome. Most common mechanism of injury is trivial trauma. Like any other fracture presenting to our clinic, we need to do a detailed assessment when they have in our outpatient setup, do a comprehensive assessment according to the ATLS protocol, not to look for specific injuries, but also not to miss any other trivial fracture patterns associated with this fracture. The leading may be the pain, swelling, deformity, or any open wounds, which will help us to clinch the diagnosis. We should also look for the distal pulse, motor sensation and range of movements, because there may be an associated cervical spine injury or a vascular thromboembolism, which is, though the percentage is less, but we should not miss this kind of associated injuries. Also, we should look for the scapula, cervical spine and other upper extremities to look for other associated fractures. It is important to look for the risk factors, because it is not only important to treat the fracture, but to also treat the risk factors which will not cause subsequent fractures in the elderly, such as impaired vision, use of hearing aids, diabetes mellitus, depression, alcohol consumption, use of anticonvulsant medications, and maternal history of hip fractures. It is very important to address these factors to prevent subsequent fragility fractures. Also, these patients have associated injuries such as proximal femur, distal radius, neurological injuries, vascular lesions, and 30% of these fractures are associated with rotator cuff tears, which will be acute in onset, and we should try to assess the presence of rotator cuff tears, which will change the line of management for these fracture patterns. In addition to the morphology and assessment, we should also look for the bone quality. Let us look for osteoporosis, any comminution, impairment of vascular supply. The higher the grade, the more disruption to the vascular anatomy. Pre-existing condition of the rotator cuff we can elicit from the history from the patient, and also what are the patient demands. I think today we have elderly patients who are very active, who want to return to sports and have a better quality of life. So we should try to understand what are their demands and what are the comorbidities they are having. These classification systems, the NIRS classification, AO classification, we have which will help us to understand what kind of fracture pattern we are actually seeing in, and this also gives us a guideline to choose the appropriate implants and strategy for fixation of these fractures. So what is the recent trends happening with this fracture pattern fixation? It is not about seeing the pattern and doing the fixation, but it is all about treating the patient as a whole. What are the characteristics of the patient and what are the patient expectations? So this should be the ultimate goal of treating these fractures. Though it is most important to restore the function of the joint, but in case if you are not able to restore the function, at least it should be, the plan should be to alleviate the pain in elderly patients so that they will have a better quality of life. So the overall factors which we were looking, we should, while treating these patients, the decision making should always involve the involve the comorbidities, the surgeon's experience also. Some of the surgeons are familiar in doing plates, some of the surgeons are well in doing nails, but as far as we are able to restore the alignment and restore the biology, any technique should be fine. We should explain the pros and cons of each technique before we plan the treatment. We should not only treat the fracture but treat the osteoporosis so that no more fragility fractures are going to happen. There are few pattern of fractures such as surgical neck fractures, which are like in contact and no instability, isolated tuberosity fractures and fractures of displacement of less than 1 centimeter. These are certain indications for non-operative management, which can be treated with simple sling and swath or a shoulder immobilizer or a collar and cuff, arm sling, abduction brace, whichever is available at that point of time. Also, it is important to understand the rehabilitation protocol for these patients. There are literature which says we should start the rehabilitation as early as possible to avoid stiffness. The rehabilitation exercises should include the pendulum exercises, which can be started as early as 2 weeks, followed by pendulum exercises with lean forward, and at 6 weeks, active assisted range of movement exercises should be started, followed by strengthening at 3 months, which will give the better range of movement for the patient. So when there is an advanced like complex fractures such as fracture dislocation or a head split fractures or a head depression involving more than 20% of the humeral head with excessive varus or valgus displacement, then we should consider operative management. This is the X-ray of the humerus, which shows the various radiological parameters which we should consider for fixation. So what is the literature evidence says? Though for certain fractures we do fixation, but in compared to non-operative management, the outcomes are comparable. And the various and the two major technique which we use for fixation of these fractures is nailing and plating. And the literature evidence says that this plating or nailing doesn't have any superiority over other techniques. But intramedullary nailing may be a better choice because it has less chances of screw cutouts and pulling of the screws. Regarding with the approaches, which approach to choose, whether open or minimally invasive approach, when you are more familiarized with the technique and well versed, you can try using MIPO because it has less risk of stripping of the soft tissues and better preservation of the vascularity and better healing. And deltopectoral approach is better than deltoid split approach. Again, it comes with the experience of the surgeon. So what are the few recent advances which are available to improvise fixation in elderly patients? Always address the fracture as a whole. Look for the removal of inhibitors to bone healing, like do the proper alignment, introduction of bone healing stimulants, application of bone augments or substitutes, and modification of fracture fixation constructs. Always get the alignment right, achieve a proper reduction and fixation, and use of traction sutures intraoperatively for the tuberosity fragments will help in better reduction and repositioning of the tuberosity fragments. And there is literature evidence which shows use of bone cements can help to prevent screw cutouts in case of plate fixations, especially in very osteopenic or osteoporotic bone. Use of fibula strut augments for more complex fractures and fracture dislocation where there is excessive bone loss. The strut grafts will help not only help to give the mechanical stability but also improvise in the biology and better healing. Recently, I had the opportunity to learn this multi-knock nail with screw-in screw technique, which also helps to get better stability of the fracture construct. And there are certain fracture patterns, such as head depressed fractures with fracture dislocation, and patients who are very old, fragile patients who need a faster healing and better quality of life. Arthroplasty is recently gaining more evidence, the fracture RSAs. So these fracture patterns, we can consider doing a fracture RSA which can have an immediate better quality of life for the patient. These are literature which shows that TSA or RSA has better functional outcomes over hemiarthroplasty. And we should also not fail to address the psychological and social factors at 3 months post-operative, because treating these associated factors will have a better functional outcome rather than treating only the fractures. So the take-home message is, while treating proximal humerus fractures in elderly, we should not aim focus only on fixation strategies, but also to consider the overall improving the overall patient quality of life and treat the associated comorbidity and the predisposing factors. Thank you, one and all.
We now have a panel discussion. May I invite Kaustav Mukherjee to please come and talk about the case-based scenario. I'd like to invite the panelists, Dr. Satish Mutha. Please come. Obhijit Bandyopadhyay, I don't think he's here. Are you here?
So we have 20 minutes for this. So we have 3 cases, so we'll discuss 3 cases, interesting cases. So let's come to the first one. So, 65-year-old lady sustained slip and fall at home on a flexed elbow. Known diabetic on medications, 5 days old trauma, initially went to a traditional bone setter in a village. And now he has presented to the outpatient department for further management. So there is no deficit and the skin condition is reasonable. So taking from the X-ray. So before this, I want to say one thing, that I might not be able to show all the necessary investigations because most of these patients have a thing with them and they have to do it in low socioeconomic status. You have to do the cost cutting and all. So based upon this X-ray, so what is your take on this? So, Abhishek.
So first thing will be definitely the control of the diabetes and that as a first
so that's
concern,
control. And we did a FBS, we did a HbA1c, it's controlled diabetic.
And second one is the
skin condition.
Yeah, skin condition.
Skin condition is perfect.
Perfect and that. So no role of a CT scan, I think, because you already mentioned and that over there.
So I think this is a pretty big fragment, so you can make out the thing from the X-ray. So what is the diagnosis now? I will go back to the X-rays again.
Yeah. So there is a capitulum fragment is there.
Yeah.
The olecranon is fractured, and along with the condyle fracture is there.
So there is one lateral condyle fracture also. So there are actually 3 components to it. If you see a lateral condyle fracture, a capitulum, and an olecranon. So the mechanism of injury is on a fall on a flexed elbow, and the force transmitted from the olecranon fractured that and then went up to the capitulum. Yeah. And then a final varus valgus thrust motion has caused the final element of the fracture. So that's important to know. So whether there is any role of a conservative or operative management, any role of conservative management?
No.
So everyone agrees for operative management. So now we have opted for that. So what is the approach that you're going to do, and what will be your choice of implants for fixing this? Single approach, 2 approaches, 3 approaches. So any sequence of fixation, or how will be your take on it? Sir?
So I would definitely start with
Mike.
Definitely start with the posterior approach.
Yes.
First thing I have to fix is the olecranon. That is for sure.
Okay.
Once the olecranon is fixed, something like a Boyd, I can see the lateral condyle there.
Okay.
It seems to be a full thickness fragment.
That's a full thickness fragment, yeah.
So probably a couple of CC screws or one screw of wire or something. Now, once that is done, very unlikely that there will be a lateral capitulum, the capitulum and lateral condyle separate. I mean, we need to do a CT and C. It's unusual that the three will be separate.
So you want to fix the olecranon first and then?
The olecranon, lateral condyle, if it's a type 1 capitulum, I would even excise it. There is no problem.
Okay.
Type 1, type 2 in a 65 lady with all these, you can excise.
So you want to
the
do a
capitulum.
single posterior approach or?
Yeah, single posterior lateral condyle and excise the capitulum. If it appears to be big on the CT also, then maybe I can
So
add
you want
a lateral.
to use the
and fix
window
it.
of the lateral condyle and then go anteriorly and then take it out.
Yeah, you can just go from there or a separate coccus kind of thing and remove it from
So two approaches.
Just one thing I'd like to emphasize, we should always insist for CT in this case of
I agree, sir, I agree.
Whenever we plan operation.
Definitely.
It may cost 3,000, but without that we should not proceed. More in the elderly, because there may be coronal fracture and other fragments.
Definitely.
Which are
And
most
there
likely
might be
to
an
occur,
extension
okay?
into the trochlea
So that
also.
is the general message we should always convey. Look.
But sir, these are different scenarios.
Part
That's what
of
I
the
agree.
preoperative
That's the first thing I said, that CT should have been done. But
No CT, no operation. So that nowadays even the district subdivision hospitals are there. So we should spread this message clear. No CT, no operation in this kind of complex intra-articular fractures.
Fractures. Agreed. So, anything else, sir?
Nothing, as Satish Mundra sir told, we can go to posterior approach, and with the condyle window, if we have a window, we can go anteriorly. Depending upon the capitulum fragment, you can fix it with screws and do it sequentially. Yeah.
Okay.
My take will be otherwise. So through the olecranon posterior approach, I could fix the lateral part first. That will avoid any separate incision.
Yes.
And then I will proceed for the olecranon. Okay. That's my other approach. That's another approach we can take. Okay.
Okay. So let's come to this. So we utilize something called the fracture window technique. So we use a simple posterior approach. Already there is a olecranon fracture, that is your first window. And if you just elevate it, you will get the second window, that is your lateral condyle, because that was a big chunk. All these chunks were entire big, large fragments. And so we just used a bone hook to indirectly reduce the capitulum, and then we fixed it in the posterior anterior screws. So the fixation is from the front. First capitulum gets fixed, then the lateral condyle gets fixed, and then your olecranon comes into a TBW. So minimal cost of implants, you don't need anything else, just screws, Herbert screw, 1 cc screw, and K-wires. So we kept the cost to the bare minimum.
There is two different fragments. One is capitulum, one is lateral condyle.
Yes.
Many times there is, you have done the CT and there are paraoperatively.
Because sometimes what we could have missed it, if the capitulum fragment was big and it was going into the trochlea, then it would have been very difficult to fix in this way, and then would have landed in a surprise intraoperatively. That's why CT scan was absolutely necessary. But yes, I don't know how to defend it, but that's the scenario. We mobilized, so I will come to the next slide, that's what. So we started mobilizing them from 3 weeks onwards. So this is the X-ray at 6 weeks. So the flexion had around 5 to 110 degrees, supination reasonably good, pronation also reasonably good. And she is doing very well. So 6 months X-rays, she had a very good functional movement, she could do all the things of a daily activity. So this below is the pictorial depiction of what we have done. So first window, if you see, is the olecranon. And the second window, second picture is the lateral condyle window. And then you just pass a bone hook, reduce it anatomically. It is very easy if it is a big fragment, but if it is multiple fragments, very difficult to do it by indirect reduction. So the latest thing that I want to show is there is a classification that has come up for the coronal shear fractures of the distal humerus. So if you see the type 1, type 2, and type 3, type 1 is a big chunk that is involving only the capitulum. Type 2, capitulum extending into the trochlea, and type 3 is a multifragmentary. So this has come up, but what actually made me think about doing this initially, I thought I will use a dual approach for fixing these fractures. But what made me think is this case report which was published recently in the Journal of Orthopaedic Surgery, where they found out that we can use the olecranon window, we can use the lateral condyle window, and you can use it in a single incision. You can go around and fix all these fractures. So we recently published this case also, and because it is a very rare fracture triad, lateral condyle, olecranon, and capitulum has not been reported in literature till date. So this was our first case, and we got it recently published, and it is up to come in the June issue of JOCR. So what I want to show is the understanding the pathomechanism of the injury, the coronal shear injuries, is that when you land on a flexed elbow, the force transmission first goes and fractures the olecranon, and then it goes on to transmit into the capitulum. And the final movement, when the patient goes into a valgus or a varus thrust, it causes either a lateral condyle fracture or a medial condyle fracture. So you have proposed this classification, the injury mechanism. So yeah, that sums up the first case. Any comments? Sorry? Yeah, if you don't have a olecranon fracture, then you have to use a lateral approach. Otherwise, you cannot go.
In the AO classification, there is also already mention of the coronal fractures, and that's in the AOTS we had also a detailed discussion on that. That's a well-known entity, okay,
Yeah.
and that needs separate approach, right?
Okay, so we'll move on to the second case then. So, second case, a young male in the early 30s presented with inability to walk for the last 3 years. There's a history of tibia fracture which was operated at a native place and has been complaining of a pus discharge for the last 1 year. So for that he underwent nail removal again outside 2 years back. Since then he is complaining of pain on and off, skin condition not great. So these are the 2 x-rays that I could retrieve from the patient, old x-rays, first trauma in 2019. So it was a closed tibia fracture, so which got nailed outside, and this was the x-ray in 2020. So what's your take on it, Abhishek?
This patient has a discharging sinus, right?
Yeah.
Okay.
So
from the
he
fracture,
had when
from the fracture side.
From the fracture side.
And the nail is still inside.
No, he underwent a nail
Sorry,
removal.
and
So
that.
yeah.
Still he has a discharging sinus.
Yes. So this is the thing he has come with now. So he's not been able to walk. He's using PTB support for that. He's using on and off. He's limping. Skin condition is not great. Occasional pus coming out. Yes.
So if you are looking at osteomyelitis, infection, that will be the first thing. You will have to do an MRI. You will have to locate wherever the infection is. If there is infection, you will have to radically, mercilessly debride it, bring down whatever bone has to come out, and then you manage the defect, whatever it is. If it is a small defect, you can acutely dock it and fix it. If it's big one, then you can, if you're good at Elizero, you can transport. If not, you can use a tibia cement spacer or something like a mascele, and then take care of the defect.
Yeah,
But first
patient
thing will
is
be the
like, I
infection.
want minimum setting approaches. I mean, doesn't want multiple operation.
No, I don't think he's in a situation where he can ask for it. Okay? I mean, you can definitely debride and put a cement nail and all that, but you cannot guarantee that's going to be his last operation. So if you have to do the right thing, then this is a cement nail may work, or antibiotic coated nail, but now there is enough literature to show that in delayed presentations, antibiotic coated nail may not give you the desired outcome.
Result. Yeah. Amir sir?
One step, one operation solution is simple.
Elizarov.
Definitely, that's well noted. If you have the expertise with the Elizarov or with the LRS, it can be done.
You can do it.
Though patient compliance is very important factor.
Education,
And
how to...
patient compliance.
Compliance. He has to come
So
and
you have
visit.
to counsel beforehand.
Yes.
So him if he is prepared. And the skin condition must be shown before presenting this, because with the local skin condition. Regarding the first thing, go back please. So there is a term, without even the magnitude of the fracture, you can see that shows high energy trauma. So internal degloving occurs.
Yes.
So there is the chance that even
Closed
infection
injury, yeah.
and sloughing occurs in this. So we should be very much cautious about the skin. So ISS, injury severity score to be,
Yes.
or other things should be measured very well. That's the most important point
Preoperatively.
before. And in this case also, I think what we've called, that means for day one, I won't say that day one failure, but you can see there is
A lot
the
of distraction.
there are too much of distraction.
Distraction
That
and
tells
the
that some telltale stories,
Yeah.
and there should have been 3 screws also.
Exactly.
The distal fragment, you can see. So they are the things I think, and the nail is proud. You can see
Yes.
at the proximally. So all those things points, the operation was not done in a competent way. Okay, there is much to be improved,
Must to
and
be
that
improved.
could have altered the prognosis of the patient. So it's not always that, in spite of us, many times fracture unites. Okay, they are the 2 comments I'd like to make.
Okay, sir.
And regarding the other thing is definitely 2-stage procedure is very well established compared to one thing. So thoroughly debridement, exercise, give the intermediary antibiotic, nails, indigenous thing, and then take it out and then do the renaling or the ESR CRP is enough to guide even without MRI, because the MRI interpretation in most of the time is not so much like the PET CT, which is
Exactly.
much more
So there might be a subacute infection which might be
yes, much
missed
more
out.
predictive of the subacute infection, which is not at our disposal. They are the few comments I would like to make.
Yes, sir, the same thing as such.
Okay, so let's go to what's done. So this is the X-ray. I think everyone unites with this. This is a non-union, probably infective non-union. ESR CRP was done, were found to be elevated. So what we did was a single-stage procedure. We went for an Ilizarov. When intraoperatively, we had to remove 8 centimeter of the bone. It was full dead, thick cortex, nothing inside. And we had to debride it thoroughly, and then we put on the frame. Then started distracting it 1 millimeter per day. But the problem here next, what Amir sir was telling, that if you are doing Ilizarov, it's very important for patient compliance. And this patient was traveling far off to me for the OPD checkup. He failed to show up multiple times. And he took the advice from someone that if you turn it more, then your treatment period is getting short. And then you will be in a phase where you can graft it, and then you will be able to walk again. So now comes the real problem. If you see the third picture, so he's 1.5 months before the expected time, because if you see the gap and if you calculate it, you will get the days, how much time will be the distraction phase. Now the problem is the regenerate quality is poor. Now how to deal with this? Now we have done a grafting, because patient is like 3 months I have accumulated 10,000 rupees. Now I am in a stage to do the operation. You have to do it now. If you don't do it, I will be difficult for me to do that again. So the real problem with Ilizarov is to educate the patients about distraction, and then if you land up in a poor regenerate, then it's a big problem. Amir sir, your take on it, because sir is expert.
So now it has been much more improved. So many things can be done. Now, number one, you could have sampling shortening, day 1 shortening plus
accordion maneuver. That's
a bit accelerated docking. That means say you can be 5 up to 4 centimeter you have dock compressed without affecting neurovascular status.
Yeah.
Whatever actually number 1. Number 2, after say within 7 days, 3 millimeter every day, 2 to 3 millimeter every day, you could compress without affecting neurovascular. So by 10 to 15 days while he's inside in the hospital or under your control, you could have dock it accurately so that soft tissue invagination and contact is good. More soft tissue problem is not there, and there can be early newborn position. Number 1. Number 2, if you do the multiple osteotomies, trifocal osteotomy, you could have there is distally enough length you could have that. Also, in the sequential day, then you can shorten the period of distraction. Okay, so instead of one side, you could have 2 side distraction. So these are the things which is very much readily possible.
So we can train the regenerate.
Putting a nail, putting a such simple stains like thing that would avoid that translational or angulation problem of the transported segment.
Yeah.
These are the very
the things. And lastly, you could have after, say, a period of expected lengthening, you have gained, you can up to 2 centimeters, you can accept shortening, you could have fixed a plate.
Yes.
So that the period of in the frame is over. So much more improved things have been come. Okay.
So
what do you recommend at this stage, sir? He has a regenerate which is not satisfied.
It's very simple. It's very simple. You just reverse. You just compress it again.
We can compress it, sir. We can
You
go
just,
back again.
You just
and then
compress it
wait.
few days. Compress it few days. That will be enough.
So a lot of things have come up. We have the accordion maneuver. We go up front,
So,
go back.
you just go
wait
back
for
and
some time.
yes, yes.
Yes, sir. Sure. Mike.
Why I am not satisfied with the regenerate? Yes. Yeah. Sir, what's the...
Sir, actually the thing is, it has to be a longitudinal stria that has to be seen in all 4 cortex. So,
if I can say, sir, what is needed, that should be uniform.
Uniformity.
Sir, that should be ideally uniform. Okay? That's the thing. There are regenerate qualities has been now defined much more way that may be more related to the osteotomy than the speed of destruction. Okay? That tells that if that would have been the speed, then there would have that type of longitudinal throughout. That means here some periosteal as well as soft tissue as well as endosteum has been disturbed. That's why there is less bone formation compared to the posterior aspect. Okay, that's more not with the speed, rather with the technique of the osteotomy itself. Okay, so that's not simple. However, that is also acceptable regenerate if you continue with it.
We can do a conservative wait for some time and see how the regenerate is behaving, because most of this time this fibrocartilage can form into bone when you start weight bearing. So that's how the bone starts forming. So it's not always necessary that if you see a poor regenerate, you should go in and do something then and then. So you were saying in it something.
No, just the tilt which has happened in the transport fragment, that can be prevented like one would.
We can do, sir. We can do that.
Yeah,
because this case was done very, very early when I was started doing.
If you use a drop wire and take a
we can now we have half pins, sir. So we can put in the half pins and we can do that.
Then,
so that's there. So we're running out of time. So poor regenerate, how to deal with this now? So the patient became impatient. That's the first thing. So he turned the rings faster than he was supposed to do. And regenerate quality is poor. And unfortunately, our patient is also poor. So we can't afford to do something fancy at this stage. So what are the bailout options we have at this moment? So you reduce the rate of distraction, try accordion maneuver, stop, reduce distraction rate, start early weight bearing in a frame or in the splint, and start biologics. You can also do that. So what we have done is we waited for that. We waited, and then I think the frame was removed after a long period of time, and we were lucky to put him on a PTB cast, and he got the regenerate quality that he needed. And he was able to walk again, and I think we have a video of him. He just sent me some few days back. So he's walking unassisted. He has some amount of shortening, 1.5 centimeters of shortening, but he's okay because he didn't walk for 4 years. And he's able to walk again on his limbs, so that's the most rewarding point of a result of surgery. So even if you are stuck in something of a poor regenerate, they usually go on and heal well if you try to protect the regenerate over time. So that's one thing of Elizarov that is a great thing. So last case, I think we are running out of time. Quickly, we will go to this. So this is an open shaft femur fracture. So a young adult in the mid-30s sustained an open injury, history of an RTA, two-wheeler versus four-wheeler. So a long horizontal wound over just above the knee, approximately 20 cross 5 centimeters. No other associated injury. There is no deficit. Everything is fine. Okay, so the same thing happens. I cannot give a CT. So, yeah, so I will just try to quickly tell what is the scenario. We took him to the OR and he found that the complete quadriceps was cut just above the patella. So there was a big trochlear fossa chunk, the lateral chunk. And we had 24 hours. From the time of injury to the time to the OT is 24 hours. There is no gross contamination. So how will you plan, sir? Will you go for a definitive fixation? You will debride, wait, put on an X-fix? Yeah, that's two independent chunks. One big chunk, another very small, just a cartilage chunk. Yeah. Patella is fine. There is nothing in the patella. There's only a quadriceps
No,
thing.
from what the wound picture that we can see, it seems to be a relatively clean wound. So
Yes. It's
maybe
a
you
clean
can
wound.
fix those two tiny fragments with some wire or screw or something.
Okay.
Close the wound, tag it, and just put a retrograde nail and stabilize it.
There is a complete quadriceps cut from the patella.
You have to repair it in any
Repair.
case. Yeah.
Okay.
You
So
will still not mobilize. So you can fix the femur through a retrograde nail and do the soft tissue work, whatever you
want to put a
require
retrograde
do.
nail.
Yeah,
Okay. And for the tendon repair,
yeah. Repair the way we repair it. If the tendinous portion or the muscular portion, but it will be an end-to-end repair if possible, since it's an acute injury.
okay. Sure. Amir sir. Okay, Vishnu. Yes, yes, yes.
Yeah, as sir said, the same thing is the damage control principles have been done. It is a clean wound, then we can fix the fractures.
So acute
stabilize the-
sitting fixation. Okay.
Acute fix, anyway, you have to stabilize the femur and fix the trochlear fragments. After that, depending upon the intraoperative condition, you can do the tendon repair.
Okay.
And anyway, you can post-operatively, the patient will be immobilized depending upon the post-op protocol, slowly and
So immobilization, how will you do it? What's your way of immobilizing? You put on some long neck knee brace. Fine. Abhishek, anything extra?
I think if we do a good debridement initially and
So that's the key. So you have to do
so
a very good debridement initially.
Very good debridement initially, which
So
comes
if
with
you are
experience.
fixing something acutely, a very good debridement
You can always
initially.
go for a
remains the
welcome
key.
nail, or
Yeah.
like this thing. A welcome,
After that,
yeah.
choice of nail is yours. You
No
can
less
do
than
antigrade, retrograde. That's
fixation
yeah.
over there, like whatever will be there, or maybe we can do
Okay, Amir sir.
So in femur is much more tolerant. The day one fixation is acceptable compared to tibia. Though 24 hours, 4 hours delay, we should keep it in mind. So thorough debridement should be there. And in femur, it's very much possible, number one. Number two, if any doubt, we can add also the stimulant type of things, so
Yes.
that in the soft tissues, that will add to the control of infection.
Control
If
of
you have
infection.
any doubt, that will add another thing.
And you have to add a good antibiotic IV coverage. So
Of course.
yes,
So
triple
that's
antibiotic.
it, but the local delivery is much more better. Number
Exactly.
one. And of course, in these cases, nail is a good.
Nail is a good
nail is
option.
the option, and as it is distal part, so compared to antigrade, it will be better because already we have to go to up to the knee because
Yeah.
to see the trochlea. So
Yes.
it's we are not opening it up. So knee
It's
joint
already
is
open, sir.
already
Yeah.
communicated.
It's already communicated
So it's
open.
better to have distal locking into the compared to
Antigrade nail.
antigrade nail.
Okay.
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 They're the mind take. And tendon as usual. Okay.
Okay, so I have a small video. Let's see if it is playing. So intraoperatively, the entire quadriceps was cut. So I will be able to show maybe the chunks of the trochlea. Yeah, so you can see the two big chunks of trochlea. So the lateral is the bigger one. Medial is not that big. Medial was just a flake of the cartilage. So what we did is a transpatellar repair. We drill holes through the patella, take ethibond sutures, then take it out. Standard repair of a quadriceps tendon as we're doing. And because we didn't have retrograde nails, we had to go with the antegrade nails because these are cheaper options that we are getting. And and they was immobilized in a long knee brace, as you can see in the X-ray. So comments?
I would like to make it, if don't mind, okay, comment that with this kind of fixation, you can see that there will be toggling the nail. If you have no other option, at least you do polar screws, so that on either side, if you narrow it down, so that there is not toggling. Okay.
Okay.
On either side, then that movement will be restricted. At least if you have no other options. Okay.
So this is a follow-up at 6 months. So he had a reasonable stiffness because we had to immobilize him in a long knee brace for 2.5 months. So after that, at 6 months, he has around a knee flexion of around 80 degrees. He's walking unsupported, and if you see the skyline view, we had to put in a Herbert screw for one of the trochlear chunks. Otherwise, he's painless, mobilizing. Fracture is showing consolidation, and if you see at 1 year X-rays, we were able to get a knee flexion of 90 degrees, but he was able to do all his household activities. Only thing he had problem is he couldn't sit down and squat, but he's able to ride his motorcycle going back to his job. So he's happy because he have a full flexion. So no FFD, and he's able to have a knee flexion of around 90 degrees.
So did you nail first or did you
No,
repair the
I did the
quadriceps?
debridement first. I did the debridement, thorough debridement. I did the repair first, then I closed the wound.
So quadriceps repair you have to do in flexion. Otherwise this stiffness will come. If you are not able to satisfactorily flex it on table up to 90, then you are heading for stiffness.
Okay.
So you have to fix the femur first, stabilize the femur, then repair the tendon and final fixation in flexion so that you can give some kind of mobilization early into the rehab. Like 2 months
how is your,
long leg knee brace means it is going to be stiff. Yeah.
So how long, like how early you mobilize them, sir?
So depends on table how much. Ideally I would like to tighten it in 90-degree flexion.
Okay.
Because the quadriceps tendon is quite strong. You can take that. At least 30, 40, 50, but in extension definitely not. Cannot
But you
be
are just
repaired.
repairing with ethibond sutures, sir. That's what I'm
But
asking.
if it's transpatellar, yeah, ethibond, fiber wire, whatever you like. But in extension and then immobilizing means it is going to be stiff. Yeah.
So any take on this from the floor?
Swarnendu, you would like to make any comment? I think tendon.
Before fixing the patellar tendon, you have to fix the femur.
Okay.
And as because the retrograde nail was not available with you, probably you was forced to do the antegrade. But it is another one because you are opening on the top. There is no point in that. But ideally, it should have been the distal femoral nail.
Okay.
And completely agree with the comment that you have to fix the quadriceps at the end in 90-degree knee flexion. If you do the same thing on the inferior side also, you do it in 90-degree flexion because on table, if you don't fix it 90, you will end in 90. That is the problem.
Okay.
And mobilize as early as possible, like once the wound is healed, like 2-3 weeks. After 7-10 days, even you can start the CPM. Otherwise, you will get the stiffness. And as I mentioned during my talk, the main problem is the FFD.
Yeah, there's no FFD, sir. So
No,
that's what.
you are great that you are not having the FFD, but he is not going to gain anything extra.
Yeah, so he has 0 to 90 degrees of motion.
He is satisfied because in our country, most of the people are happy with 90-degree flexion if he can bike ride or the other day-to-day activities.
Yes.
Swarnendu, I think what he has done rightly, so even after nailing, if I am not satisfied with my repair, then I might have to augment it with the tendons also. Because the knee flexion is very, very important so that I can allow it by movement by 3 weeks. Okay? That should be my aim.
Same thing I am telling.
Yes. No, now I was talking to Adi. If, say, there is because it is presented late, say 3 weeks, there is needed extensive debridement, end-to-end apposition is not quite good, then will you mind to put that, take some tendon and graft it also, so that to augment it, or not?
If it is a compound wound and it is 3 weeks late, still you have to augment the quadriceps because you have to debride. Debride means you have to make it a surgical wound, and you have to put some graft to augment the tendon if there is a tendon loss. Otherwise, how will get the extension?
So
patient will crumble and he will fall.
So that's the message, I think, that so you debride it thoroughly and do the repair with the 90 degree of the flexion so that otherwise you will to have achieve maximum amount of flexion. Number 2, and for that if needed, you don't hesitate to augment it. Okay? That's the message from the chair. Thank you.
I think we're running short of time. Okay.
Thank you very much.
Yeah. So next up is the inauguration ceremony.
So we end the session here. Thanks to the moderator and all the panelists. Okay. Thank you all.
Thank you, sir.
And thank the contribution by the delegates also. Thank you.
Good afternoon. On behalf of World Orthopaedic Concern India Chapter, myself, Dr. Chinmoynath, Honorary Secretary of the WOC India Chapter, and the Organizing Secretary of this conference, welcome you in the inaugural annual conference of this organization, which is newly revived WOC India chapter. We are running actually 1 hour late in this conference, so without much ado, may I start the proceeding of the inaugural session by welcoming Dr. Arindam Banerjee, President of the organization, and also the President of the WOC International. Dr. Shoshindar Shanmukhasundaram, he is the Vice President of WOC India chapter on dais. Dr. Siddhant Goel is the Treasurer of WOC India chapter, and Dr. Gigi Kaur Gourda. Dr. Gigi Kaur Goza here. Dr. Gigi Kaur is the President of West Bengal Orthopaedic Association. Dr. Romeo Bera, past President of West Bengal Orthopaedic Association, and our Guru of Orthopedics, and past President of WBOA and many other organizations, Dr. Indrajit Sardar. May I call upon stage all of them to without wasting any time. May we proceed to the inaugural function. In our Indian tradition, every occasion of knowledge sharing and the enlightenment, we light the lamp of wisdom, and may I request all the dignitaries on dais to proceed for the lamp lighting ceremony.
या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युतशङ्करप्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा शुक्लां ब्रह्मविचारसारपरमा.
So now there will be a welcome song by our Dr. Mrs. Mukherjee. I'll request her to come on dais. She's Dr. Indrakshi Mukherjee. She's a pathologist, assistant professor, and she is wife of our EC member, Dr. Kaustubh Mukherjee. Thank you.
Good afternoon, everyone. I am going to sing a Rabindra Sangeet, so if kindly please join. Aguner porosh muni ছোঁয়াও প্রাণে এ জীবন পূর্ণ করো এ জীবন পূর্ণ করো এ জীবন পূর্ণ করো এ জীবন পূর্ণ করো দহন দানে এ আগুনের পরশমণি ছোঁয়াও প্রাণে আমারি দেহ খানি তুলে ধরো তোমার ওই দেবালয়ে প্রদীপ করো নিশিদিন আলোক শিখা জ্বলুক গানে নিশিদিন আলোক শিখা জ্বলুক গানে এ আগুনের পরশমণি ছোঁয়াও প্রাণে আধারের গায়ে গায়ে পরশ তব সারা রাত ফোটাক তারা নব নব নয়নের দৃষ্টি হতে ঘুচবে কালো যেখানে পড়বে সেথায় দেখবে আলো ব্যথা মোর উঠবে জ্বলে ঊর্ধ্বপানে ব্যথা মোর উঠবে জ্বলে ঊর্ধ্বপানে এ আগুনের পরশমণি ছোঁয়াও প্রাণে এ জীবন পূর্ণ করো এ জীবন পূর্ণ করো এ জীবন পূর্ণ করো এ জীবন পূর্ণ করো দহন দানে আগুনের পরশমণি ছোঁয়াও প্রাণে Thank you everyone.
Thank you, Dr. Indakshi. Now, I'll request Dr. Arindam Banerjee to deliver his welcome address to this occasion.
Good afternoon, everyone. This is not going to be a formal welcome address, but just a few words. We have been trying our very best to revive the Indian edition of WOC, and we have registered it in Kolkata. Unfortunately, as you know, nowadays it's very difficult to register new organizations, and there are a lot of rules, and one of the rules is that you can't use terms like Hindustan, or you can't use global, world, etc. So we were unable to do that. So the nearest name which they agreed to was so it's been registered as Empathetic Orthopaedic Concern, but it is the Indian chapter of the WOC International, as we have given it full recognition to be our Indian chapter. Now, as you know, building any organization from the scratch is very difficult, but I have been very lucky that I have been supported by a group of very young surgeons who we will call to the dais in a few minutes and to felicitate them, and they have been very active, and we have been able to do this conference in spite of several problems. Just remember, we were at war last week. Everything nearly came to an end, but I'm pleased that we were able to hold the organization, take it forward. But a few speakers could not come because of the situation, especially from the northeast, from Kashmir, etc. So I would like all of you to please note our organization, be part of it. We have a lot of plans. We plan to set up fellowships, a lot of training courses, a lot of virtual seminars which we've been participating in. And I would request all of you to please become life members. The next conference we are planning for WOC will be around the same time, perhaps in June in Chennai. And the following year, perhaps Mumbai. Satish is here, and Vishnu is here. Sasindra, I think, is a bit tied up. So they're taking we are trying to organize this as an all India grouping so that all parts of India are represented properly. Now, Chinmay, we won't spend too much time on this, so I'd request you to start the next point.
So now it's time for felicitation of the executive committee members of WOC India chapter. So I hand over the mic to Dr. Shivli Dashgupta.
Hello. Can I invite Dr. Indrajit Shardar to please facilitate some of our members? Dr. Arindam Banerjee, our president. Dr. Shardar? Sorry, one more. Dr. Chinmoy Nath, our secretary. Sir, একটু মাঝখানে যান। Dr. Amia Bera, if you could facilitate our next two members. Dr. Siddhan Goyal, our treasurer. And Dr. Satish Mutha. And Dr. Gigi Kaur, if I could invite you to felicitate our last two members. Dr. Shobhik Das. And Dr. Vishnu Senthil. If we could also invite Dr. Kaustubh Mukherjee to the stage. Dr. Banerjee, if you can felicitate him.
So it is all about the felicitation program. Now the final is the national anthem, which is sung by which will be sung by all of ourselves, and I will request all of you to stand up and join, and it will be led by Dr. Indrakshi.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल बंगो विंध्य हिमाचल यमुना गंगा उच्छल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मागे गाहे तव जय गाथा जनगण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे.
Thank you, everyone. Now we have to proceed to the next session. And as our guest speaker, Professor Ramesh Sen, has to leave for his flight, we have to prepone his lecture. That lecture is Professor D.K. Taneja Oration. Professor Taneja was our WOC India chapter's past president when it was there 20 years back. And he has donated for his lecture in his, oration in his name. Professor Taneja unfortunately could not attend this conference, but his blessings is with us. He is in the convalescent stage of his surgery. So may I request Professor Ramesh Sen to take the dais.
Sorry, can we have the slide of Dr. Ramesh Sen, Professor Ramesh Sen, please, first? So it is a great honor for us to have a oration by Professor Ramesh Kumar Sen. He is giving the inaugural DK Taneja lecture. Now, I had requested Dr. Taneja to give the first lecture himself. He unfortunately had a knee surgery done about 2 or 3 weeks ago, so he could not make it. But he was, so because Professor Ramesh Sen was coming, it was a great honor that Dr. Taneja was very happy and said that he should give this lecture on my behalf, and I'll do it next year. So to introduce Professor Sen, he's been an orthopedic surgeon in practice for 35 years. And his forte is, as we all know, pelvic surgery and arthroplasty. He's the principal director and head Department of Orthopedic Surgery in Max Hospital, Mohali. Former professor orthopedics, PGI MER Chandigarh. Author of more than 200 research papers and 15 chapters in books. Faculty in national and international AO courses. More than 35 international and national orations, more than 10 fellowship awards. In fact, we traveled to UK together, I think in 2008, on the IOA UK fellowship. He's the founder president of AOPAS, past president NZOA, and past president IOA 2021. And he's a member of the AO International Pelvic Expert Group. May I please have his oration medal, please? Can you please hand it to me?
And this definitely is a privilege for me to be talking and introducing Dr. Taneja. I remember in 92 I got the JJ fellowship, and at that time Dr. Taneja was the fellowship secretary, so I had a very good acquaintance with him, with his dynamic management of that time. And subsequently we all know that he has been a former dean and principal of Medical College at Indore, retired in 2003. He was a medical director at a hospital and founder director of MGM Allied Health Sciences. He was president of WOC 2018 to 21 and president of OSAC. Then during the OSAC meeting also, I had the privilege to be seeing him, and in IOA 2000, which was organized. Had 4 international awards, 5 national awards, including TKS Gold Medal Award. I edited 15 books, published 80 plus articles, and delivered more than 150 guest lectures. And all of us know the kind of dynamism he has. Definitely it's not good that he's not here this time, and I'm really obliged that he thought me to be the person to have the first oration which is named after him. And can I have my slide please there on the So my link with the WOC goes back to the WOC. So my link with the WOC was way back in 99 when I was in CCOT in Australia, in Sydney, and that time my all presentations were a part of WOC, and all the link goes to WOC of that time. And because incidentally at that Dr. Shanmugasundar was the president of WOC, and I remember all those activities. WOC was very active. We had a yearly or twice a yearly the pamphlet also we used to get about the activities, and I hope with Arindam at the helm of affairs we'll be getting the WOC back soon in this area. So now coming over to the orations, I thought when we talk about WOC, we're linking with a world which is not that privileged enough to have the best of these things. So we always deal, and you must have seen the morning talks also, most of the time we are taking the problems which are in relatively that situations. And trauma, as we know, is one of the ignored, belittled, denied, misunderstood, and untreated cause of human suffering. As far as pelvic trauma is concerned, it's not like that. We were there right now from the time of the Sushruta when evolution happened for all the surgeries, and then it continued till late. So pelvis is taken as a keystone of the human architecture on which the body stays over. And if that is neglected, we can estimate what is the kind of malady we are looking in. So I'm just going with the cases. You look at this case. a young lady, 24 years old, got a wide open this pelvis. Nothing was done. After 2 years, she had no issue. She can sit, she can stand, she can walk, she can do everything. I'll give you another case. Look at a deformed pelvis with the significant displacement. This person, this relatively younger boy, has also an ankle problem. And he came to hospital not for the gait, for the pain. He came for his ankle problem. Because he was having that pain at that point. Here is another case. Significant displacement of the hemipelvis, but this child had significant problem. Definitely a limb shortening, inability to even sit properly. May not be that displacement in the posterior pelvis, but the lady is not able to stand even. And down there, with the same kind of a problem, the person is not able to sit properly. A coccyx, a very small problem. The person had problem in the sexual life, along with the lady who had a dyspareunia during the sex, and these are the problems. So what I gave, it is a spectrum of the problems which the patient can have, from being normal in a very abnormal pelvis and being abnormal with not so big an injury, and that is the spectrum we are here. Ischium, a kind of a minimally displaced but was significantly symptomatic. And this is what this thing. Now, this is something which we know as a problem. When we look at Indian population, we have level of acceptance which is much more than what the Western population will have. We don't know it till we don't score it out on a proper scoring system. Here is a patient who had got a problem. The scoring system for pelvic considers 23 by 30, while for the quality of life it is 9 out of 10. He doesn't feel much of the problem. Another lady, you can see total sacral non-union. As far as evaluation, she is 65 out of the 100. But quality of life is 10 by 10. Meaning by functional quality may be compromised till it does not affect our day-to-day activities. We are happy with that. And that is the lesson. Now, what was our conventional management? Conventional management was giving a traction. But was that traction giving us a good anatomical reduction? Here, this is the traction treatment and that is the operative treatment. Obviously, traction never makes our reduction appropriate in most of these cases. The question was, does this make a difference in the outcome? If you look at the functional scores, no, displacement does make. And then when we looked at their quality of, these are our own studies, when we looked at their quality of life also, this was also affected. And that was a very interesting thing which we published long back, 15 years back, that if sacroiliac joint is disrupted, it is much more painful than a malunited sacrum. This is one of the latest publication we had with my US people, where this is the classification we proposed for malunion, non-union of the pelvis. We studied 11 original publications, 7 of the pelvic malunion, 2 Surgeries. And what were the indications when we are looking at them? We are looking for pain, gait disturbance, and standing and sitting difference. And what is made? No, this classification has differentiated between malunions and non-unions. Most of them, because many of the time these things are combined together. But what are the problems with which patient will still present? I gave you these things. But gait abnormality, limb length discrepancy could be the cause, and low back pain. If these symptoms persist in these patients with the pelvic malformations, they are likely to present to us. And when we say we have to intervene in a late case, the indications primary is pain, which could be disabling enough for the patient, and then is the limb length or instability. Now, how do we define that this pain is due to that very injury which we are seeing in the spine, because in the pelvis? Because there could be multiple sides. So one of the ways I am asking this lady to stand, first she stood on the normal side. When she was to stand on the affected hemipelvis, now she is not able to make it up. And that is the problem. Now, whether it is due to that very joint, what we need to do is, we need to infiltrate the suspected area. So here I am infiltrating the suspected area, and then now I am asking again, this was her preoperative. She can stand on the normal side, but when she has to stand on the affected, as I showed you earlier, she is not able to make it up. But once the anesthesia in the local area is given, you can see it now. So this side is not moving. Can you make it? The video, yeah. So now you see the two sides. Now she is able to stand on the normal side, and then she stands on the affected side also. So that means the instability or the pain which was there on the affected side is now taken off. So that side should be operated upon once it is defined. We do look at the hemipelvis in 3 columns, anterior, middle and posterior. Technically speaking, if you say radiologically, they should be matching on the either side. We do have a deformity index. Then once we are evaluating them, we should have a proper evaluation of his sitting ability, standing ability, and the specific kind of the x-rays which you can see on the last of the x-rays to see it out. Definitely we need to evaluate the gait mark also. If it is malunited, we can have all those problems, including inability to properly sit, stand, and walk around. So how do we look at the sitting imbalance? Because that's one of the very common symptoms. It could be a vertical displacement, malrotation, or a sagittal. So mostly it has been defined the deformity in a AP plane, deformity in a vertical plane, or it could be transverse plane opening out and closing in. And depending upon that, we put up our reconstruction also, defining whether we need osteotomy, when in the osteotomy fixation we need grafting or biology. So, because pelvis is a ring, we have a front and we have a back. We might have to go back, then correct front, and then to go back, or it could be the reverse, reverse way also. Now, our classification says they can be undeformed non-union, that there is no displacement, but there is a non-union which is symptomatic, as I showed. It could be a malunion. It is not painful, but it's a disability in the form of a limb length alignment. It could be unstable as well as malunion, or it could be partially stable. So first I give you an example. A patient had a trauma, mild, sustaining pain, which we didn't see on x-rays. After some days, the lesion appeared. At that time, we just gave a binder and she settled on a binder. The x-ray shows a kind of a callus formation and non-union, but it settled. Now this is a part of the ilium fracture. You see, it's out of the ring, but this lady was not able to walk because the abductor attachment over this iliac fragment did not allow her to adequate ambulation. She was reasonably till she required surgery, and this surgery was again not very simple, though it looked to be a simple fragment. The fixation in a non-union is very difficult. You see the number of plates I had to apply to give her a union. This is a kabaddi player. You know, the injury was not very big, but he was so symptomatic he could not play kabaddi till the time we stabilized him, and thereafter he was back to the game doing the same level of activity. If it is not adequately stabilized, you say, somebody has done anterior fixation, not posterior. Now this patient is not able to stand even because it is the posterior instability. We simply went posteriorly, stabilized posteriorly, grafted obviously. Now he can walk and stand over there. Another patient with the same kind of a situation. Anteriorly fixation done, posteriorly neglected. Now this person can stand on the other side, but cannot stand on the affected side. So again, our management was standard, going posteriorly, stabilizing that way so that he could stand independently. Or the lady which has an inability, we just put up 2 plates to stabilize it. One thing we learnt was that when you have to stabilize the non-union in the bank, you have to create the anterior continuity. Now, creating anterior continuity is very difficult with this kind of, you can't close this hemipelvis which has been there for a lot of time. But then how do we do it? We do by a kind of a fixator for a time being, because that ring, once it is complete, will allow sufficient stability in the posterior construct for that to get healed, and thereafter you can take out the ring, the posterior stability, the union has happened. There is another case of a young 22 years female. She has multiple trauma. Everything was done reasonably well except for the sacroiliac joint, which was fixed. She came to me after about 6 months of this management, and you see the difficulty she has in walking around. She was not able to walk around, and that screw which was put had come out. So what we just went inside, did the fixation, transiliac plates application, grafting in this area, and for anterior part, which I'm saying, we need anterior stability, we put a infix, both the side shin spin and then a rod along with. She was at 6 weeks, and then we removed this thing at 6th month. She was able to walk around comfortably well. Another case, 54 years male, some local management was done. It was not settling down. He was still with the kind of a support to go around it. So what was required? Anterior stability, the posterior stability, and we did accordingly, and now he was able to walk around in that situation. Another male with the significant problem around, he has been bedridden for several months because multiple surgeries, fixator, everything had been done to him. And when he had this kind of injury, you can see again it was a situation which one is to be settled down, and the same thing was to be done. We assessed that it is the left side only which is giving a problem, not the right side, which on the X-ray looks to be a bigger problem. And that what we did, we only stabilized the affected side which was clinically infected, and this is the kind of the outcome. And subsequently at a year when thereafter he came for his knee replacements also for the same thing. Now we go to malpositioning, vertical displacements. Now this is a young boy. He came from Leh area to my place with 1 month-old injury. I tried reconstruction. I tried posterior plating. Then I went anteriorly to put up 2 screws, and because he was a child, somehow my screws came out the very next day. The first post-op day, the screws came out. Anyway, you look what happens. Post-op, a 2 years follow-up, and 4 years later, and then 6 years later, and 8 years later, things get well accepted. So the deformities, even they are radiologically there, may not be affecting clinically. Another boy, 20 years, you see malunions, but he doesn't have any problem front or back. There is another patient who had deformity, but he is happy because clinically it is not affecting me. You can see his abilities to sitting, standing and walking around. But this patient did not accept the limb length inequality. He wanted something to be done. 3 months had already been passed. He wanted surgery to be done, and that is what we did it. Now it is very difficult to anatomically get back until you don't increase the amount of surgery over that. So we were happy with this thing, and I could not really trace out the video which he came after 10 years to me, but he's quite happy. He came for another patient. Anyway, it could be unstable situation in the vertical displacement. In those cases, what we had to do is, we might have to go posteriorly, put the pedicle screw, then displace it down there to get that reduction and fixation, so that we can get the reduction and stability in vertical situation. This boy who came from Maharashtra with a very difficult problem, hemi-pelvis was badly malpositioned, and this boy had a difficulty even in the sitting also, and had this foot drop also in that situation. So what we could do was, we realigned the hemi-pelvis. We could not realign fully, but were reasonably well, and shortening was still there. He settled down to an extent, and then after 15 years he comes back to show himself. The limp stays because he is a foot drop also, but then he's much happier. He just came to say thank you that I had operated him 15 years back. Anyway, there is another girl who was there in Maharashtra somewhere, or she was operated upon there for this kind of a fixation. She was not comfortable to walk around, so she came, and then again there was a significant displacement, and you can see that thing also. So what we did was, there is a new osteotomy which we have put up in the records. This is a L osteotomy. We did L osteotomy, push it as much as possible, and this is the kind of a reduction we could do, and that made her comfortable. I don't have post-op because she has gone back. Then there could be a situation, a 25 years young lady, where you can see the fracture was not very significantly displaced. She was put on traction. You know, traction doesn't always give us stability, and within that traction she got that displacement. It was an unstable kind of an injury, and now you can see the picture. She is not able, she does have a problem in the back. She's not comfortable. She can sit, but she has this discomfort. And if you look at the kind of this thing, there is her gait. That's important to see what is the gait like, the kind of a limp. Now she's young, she's to be married, so she's not happy with the limp she's having. So she said, you have to do something, that my limp is gone. So we go with that kind of a situation. This was the displacement in those specific views. So again, we went with the same kind of an osteotomy where we cut half of the ilium. We don't go to the sacroiliac joint, we stay away from it, and that half we try to reduce it down there, and this is the kind of display here. We could reduce it fully, and we could get back both the hip joints to the normal level. And now you see the preoperative as well as the postoperative, the limp over this area, you can see it out. So now she is happy that now she can walk around comfortably without a limp in this kind of a situation, and her aim was achieved over there. Another boy, he came from Rajkot, Gujarat, with a significantly displaced hemipelvis. Now, he is happy. He was not happy for his inability to walk properly. So you can see the limp present in him, and you can see all the work of which we did for his pelvis. And then again, here we went in two stages, considering we might be able to reduce it first in the first go, release everything, and then go. Somehow we were not very comfortable with. So eventually, when we went for the second time, because we are not touching the site of this thing, Mali Union, we are going further laterally. We could not reduce it fully, but we could reduce the amount of this thing over there. And again, you can see the kind of a difference. Whatever we did was sufficient enough that now his ability to walk was much, much better, and he didn't have a limp and was quite happy. We were not happy because radiologically it was not so good, but he was happy functionally as such. So looking back at that, when we see these patients may be clinically important, when we are able to give them clinically, it's good. Now here is another case of fracture. You can see the pelvic fracture, the acetabular fracture, and everything along with tibia. And wherever she was managed like this kind of a situation. Something was done for the hip, nothing for the pelvis, and and this was the condition when she came to us. You can see the foot, you can see the disability she has got, and she was poor lady who was who was working on that machine, sewing machine, to have her this livelihood. She was in a difficult situation. So we found her pain was in the back, so we stabilized the back, and then subsequently, because the anatomy of the hip was very bad, we could get our displacement with this kind of a cup, which technically looks very odd. But we had a stability over there, and we went with this cup, and then we started the rehabilitation with the little limb length discrepancy, and then now at 18 months follow-up, she's very happy, though we know she has got a limb, but she's too happy because now she's independent, she's able to manage herself well, and she can even put these things also. Now, whenever all these reconstructions, we must appreciate, not everybody will get satisfied if we are willing for, because there is a big difference in the reconstruction of the hemipelvis. So literature says 65% were extremely satisfied, 60% were still satisfied, and 17% remained unsatisfied. So we did a review long time back, in 10 years back, we did all the review of all non-unions of the pelvis, and this is exactly what we found it out. And then we published also that this surgery definitely is complex. It takes longer time. It's a greater blood loss. It is a higher complication rate. It's better that we are able to prevent these malpositioning, malunions. And we do surgical intervention if the clinically patient has significant disability or pain. We must correlate the site of pain with the kind of a local infiltration. And when we are doing it out, definitely we have to freshen the margin, we have to realign whatever best possible done, we have to release posteriorly, especially the sacrotuber and sacrospinous ligaments, then come anteriorly, so it could be, and definitely a time must be taken for this thing. And this is the subsequent, one of the editorials we have written, that we should focus on prevention of these deformities. Whenever we have a pelvic displacements, we do early care and then subsequent management, that we are able to take care, so that we don't fall in that category of a neglected trauma. Trauma is a fact of life, we can't deny it. It does not, however, have to be a life sentence. Thank you.
Thank you, Professor Ramesh Sen, sir, for coming here, blessing us and enlightening us with your wisdom and knowledge. Now, sir will rush for his flight. Safe journey, sir.
Thank you.
So now we will continue with the arthroplasty session. in which the chairperson is Dr. Indrajit Sardar and Dr. Chandan Pathak. May I request Dr. Sardar and Dr. Chandan Pathak to continue with the session.
So moving on to the arthroplasty session. So the first talk will be given by me, newer developments in total hip replacement. Okay. So the background for the hip arthroplasty has been a long journey. So starting from Sir Chandler's principle of low friction arthroplasty and the constant attempts to get the main goal of the replacement surgery to increase the longevity and the durability of the implants, we have come along a long way. So for that, we need to achieve accurate implant positioning and restoring the native hip biomechanics, which is an important technical objective in the total hip arthroplasty. And this last decade has seen an exponential rise in the number of THAs. So we are expected to get a lot of cases which needs revision that comes up. So what are actually the advances and innovations in the total hip arthroplasty? So what has technology done to us? So, and what it has to offer in the future. So we have virtual reality, surgical education, we have contribution of the 3D printing models, and the new thing that has come up is the robotic total hip arthroplasty. So we need to identify the potential areas of faults and areas where we can improve the outcomes. So how it all started? So it's all started from the low friction arthroplasty principle, and where we have been seeing that we have been using hybrid fixations of cemented stem, uncemented cups, but gradually it showed that it had a high failure rates and survivorship rate of the acetabular component was not significant at 20 to 25 years. So the main thing that were identified was the poly wear and the osteolysis. And these were the main failure for the first generation uncemented acetabular cups. So the cementless acetabular cups had a good fixation ability, but the ability to survive beyond 20 years was considerably low. So the thing which were used in the past were the pre-coat femoral stem. So it had shown that in a study that aseptic loosening was 31.6% with an average of 8 years. And the pre-coat stems with good cement mantle, however, showed a good survivorship more than 25 years. So we started using these were initially the non-cross-linked molecular poly, but later we started using the highly cross-linked poly. So in a nutshell, the experiences of the outcomes were poor due to the poorly designed implants, undersized femoral components, and poor cementing techniques. So the periprosthetic osteolysis and excessive wear of the polyliner became a constant issue. But what have we upgraded to? So we have upgraded to the second generation acetabular cups, which have come up with an improved liner locking system, polished taper femoral stem, and highly cross-linked polyliner. The proximal and the distal cement centralizers have achieved more of a mantle grade A, and we can easily prevent the grade C mantle defects. The wear rates have improved. So the extremely cross-linked poly have showed a quite low wear rate of 0.05 millimeter per year. But the real challenge in our scenario in the Asiatic population are they are high demand population, and they will ask and they will involve their daily life activities will involve squatting, which started leading to a high incidence of impingement. So that's a new problem that started coming up. Now with the impingement thing, we tried to cope it up with using larger femoral heads, 36 mm. We started using newer biomaterial. Tribology have come up with a newer articulation surface, ceramic on metal. But the result in the problem is that the increased mobility resulted in wear, which again led to other kinds of complications like pseudotumor, hypersensitivity reactions. And this also resulted in the loosening of the implants. So we are now in a thing where we have to find out where the arthroplasty has advanced and where it has the potential scope of advancing. So the newer things that have come up are the direct anterior approach. So this was an American Academy of Hip Society polling which was done in 2022, where they have stated that 56% of surgeons have started shifting to doing a direct anterior approach to the hip. Biomaterials and tribology, they have newer articulation surfaces with improved alloys and biomechanics which ensures better implant longevity. Component implantation precision. So this has reduced the rate of the wear, dislocation and implant failures, and we can use it by navigation, imaging and robotics. We are getting customized implants. The choice of interface is ours. If you have good quality uncemented implants, and even the cemented implants are also good. And the hip revision arthroplasty sector has actually developed a lot in these few years. So this is a paper which has been doing a work on the direct anterior approach to the hip. And it has been stated that it is already there. It was already there before also. And the approach is between the tensor fascia lata and the sartorius. And you're using a smaller incision. It's a tissue sparing approach. It had recorded a lower dislocation rate and faster mobilizations of the patients. So the advent of the new surgical instruments and tables have used the DAA, a good and more feasible tool for the surgeons. But again, the ideal candidate, it has been stated that a thin individual is an ideal one. BMI should be less than 30. And you have to see the offset. So the problem is if it is having a wider pelvis, then it's difficult. A wider horizontal iliac wing limits the access to the femoral canal, which causes difficulty in broaching. Acetabular protrusio cases, difficult to do. And if there is a posterior wall defect, then it is difficult to address with a direct anterior approach. But what are the advantages? If we see the advantages, it allows for a good radiographic confirmation. There are better pain scores been reported from various studies, lower dislocation rates been reported. The length of the hospital stay has reduced considerably. However, there is a risk of a sensory nerve, lateral cutaneous femoral nerve, but usually it recovers and it's not a motor component that is going to cause any issue to the patient. Now coming to the implants, how have we advanced? So there have been considerable advances in the acetabular cup, the shape, the screw orientations. The revision cups have come up with better augments and better screw projections. We have started taking into account the spinopelvic mechanics, and that has been a considerable improvement, especially in fused spine patients. Ceramics and alloys have upgraded, and we have come up with the newest stem designs for the femur. So the cup position, which was the ideal teaching to restore the normal joint force, and which has been important that to keep the mediolateral position. But the height of the cup is also important, and we are now having templates. The templates are helping us a lot because we can now preoperatively plan the cup, we can plan the cup size, we can plan the femoral stem size. That have been helping us a lot. Acetabular component positioning, the traditional concept of the Lewin safe zone have already been there, where we have been told the version and inclination. But the thing is that with still this kind of degrees of versions and inclinations, we are still having the impingement and the edge loading. So in order to reduce that, we need to take into account the lumbar-pelvic stiffness and the sagittal imbalance. So this concept of functional safe zone have come up. So the functional safe zone, this was an article which was published in Arthroplasty, and they have given a concept of a combined sagittal index. The combined sagittal index, they have started doing it, and what they found that out of the 292 patients, 14.2% of the hips were outside the Lewin safe zone when the patient was sitting or standing. And these were the hips that were at a considerable risk of dislocation, even when we are keeping the version and the inclination to the Lewin safe zones criteria. So acetabular cup positioning in the primary total hip arthroplasty, so we have the things are changing a bit. So you are taking into account the pelvic mechanics, the pelvic incidence, the lumbar lordosis, all have been taken. And the most important concept that have come up from this paper is the change in the sacral slope. So there has been a classification for that also. And I will come directly to the classification which was given by the hip spine classification in this paper. And if we are seeing at a considerable stiffer pelvis and a spine where the cup orientation is about to change, they have stated that according to the criteria of 1A, 1B, 2A, and 2B. So they have given the inclination and the version range, so where we can keep this cup position. So this will help to reduce the chances of dislocations, even when the cup has been put in a normal position. Screw positions in the cup, what has changed? So this was the paper where we have the construct stability. A study was done, a mechanical study on the construct stability of the acetabular cup, whether it was affected by the screw configuration in the bone models. So right now we have multi-lock cups that have come up. So this allows the screws to be put in different orientation. And in the presence of a posterior segmental bone defect, the spread out constructs, they have given a better axial torsional strength. They had the better ability to do a control of this. We have been using the jumbo cups recently a lot, and they have been a great tool for a revision arthroplasty where a lot of bone defect is there, and we can easily address it with these cups. And they actually do a substitute for method of filling of the bone defects with the bone grafts. But the problem is there is an elevation of the hip center due to the bigger cup. And to stabilize the hip, it do a favor because you can use the larger head and it increases the jump distance, but the problem is the leg length discrepancy after the revision total hip arthroplasty. So this was the paper which were using the jumbo cups and whether they need a more complex revision strategy, and it was found that the jumbo cup survival rates were pretty good. But the problem is we have to adjust the leg length because with the higher hip center, we need to adjust the offset, and if you are not taking care of it, it can lead to a leg length discrepancy. So it decreases the momentum of the hip abductors on an average of 28%. It was shown in a study by Delp. And there was also a dislocation rate of 10% by Luque's study. So the jumbo cups in the revision total hip arthroplasty demonstrated excellent 15-year survival rate and acceptable failure rates. So the evolution of the cups have continued, and we are using newer generation dual mobility cups that have been used that are already in use in a lot of centers here. That also as a very good thing because we are using two articulation surfaces, and it has been advocated in many of the old patients with poor muscular control over the hip, and it has reduced the dislocation rates. Now, the new thing that have been published in the Hip Society in 2023 are the highly porous acetabular cups. So they have been used in a complex revision total hip arthroplasty, and what we are using is there are three distinct cup augments. The type 1 are the superlateral flying buttress, and the type 2 is the elliptical pattern which is used for cavitary defects, and the type 3 is the medial footing augments. So all have been explained here, but the main thing is that the porous tantalum component that showed a better biointegration of the cup into the bone. We are using a 3D printed acetabular cups also. The 3-dimension, the main thing is that it can be customized. It's a highly porous structure which gives a better bone fixation. But the main advantage is that even if you're using a bigger cup, you can use the thinner walls, and this allows the surgeon to use larger femoral heads. So you can use even a 36 mm head with a smaller acetabular cup. The next thing that is coming up is the use of computer navigation in the total hip arthroplasty. So the use of navigations have increased from 1.9% to 4.4% in all the primary THs. And the use of computer navigation has been reported to be associated with a reduced rate of revision following dislocations. But the accuracy of the acetabular cup positioning was done in a CT-based evaluation in a robotic-assisted total hip arthroplasty, and this study also showed a very good outcomes of the patient with reduced revision rates, reduced dislocation rates. Imageless navigation have been doing the study. A lot of things have been coming up, and this is something new in the specter of the hip arthroplasty. So imageless navigation, CT-based navigations have all been there, and they are doing pretty well. They have increased the accuracy of the acetabular positioning and have reduced the leg length discrepancy and have good outcomes. The femoral stem in arthroplasty have also evolved over time. So you have this type 1 stem, which is a single wedge stem, type 2, the double wedge stems, type 3 stems, which are mostly component of the Wagner stem, which are also surface treated proximally and distally, metaphyseal diphyseal junction. Type 4 stems, which are cylindrical, they have excellent survival rate of around 98%. Type 5, the Estrom stem, which have been used quite a lot these days to fix both the metaphyses, especially in the revision scenarios and for complex cases with a lot of femoral deficiencies. Type 6 stems, they bow posteriorly. These are anatomical stems, they are conical and narrow. We have also been using the short stems because the main thing is that we are doing so much of arthroplasty and the stem loosening can be there. So if you are using a shorter stem, the next stem can be a little bit longer. You don't have to go and fill the entire femur. So the short stems are also been out, and they preserve the bone stock, reduces the incidence of thigh pain, and have been doing good. But the pitfalls of uncemented stems are there. There have been the study from the Helio, which was the joint registry data from the UK. They have found out the 3.1% incidence of periprosthetic fractures are there. And the incidence of subsidence have also already been reported in uncemented stems. So the shift of the stem was started with a cemented stem, then it shifted to uncemented, and again we went to cemented. So there is a subsidence rate also, and there are current concepts in the cemented femoral stem designs as well, which have new classification systems coming up. So yeah, I will skip that part. So the recent thing is that cemented stem again have been started to be used. There is a renewed interest with majority of the American Hip Society already going and shifting to the cemented stems because of the improved cement fixation techniques. And the future is we are already going into the AI-driven patient-specific femoral stems, and the robotics is taking up a new shape in the total hip arthroplasty. Thank you. Next, I would like to call upon Dr. Biplay Dalui sir for a talk on reverse shoulder arthroplasty indications and surgical approaches.
Thank you, Chairperson sir. We have heard a lot on hip replacement. There are certain similarity between hip replacement and shoulder replacement. Reverse shoulder is not a salvage procedure anymore. There are certain selective situations where you have to choose this option as primarily. The most classic indication is the calf tear arthropathy. When there is long-standing deficiency of rotator cuff, the shoulder joints gets degenerated. This is a classic indication for reverse shoulder. In glenohumeral osteoarthritis, we usually prefer anatomical shoulder, but when there is severe bone loss on the glenoid side, then you have to opt for reverse shoulder rather than anatomical shoulder. Another classic indication is four-part fracture or fracture dislocation, where reconstruction is not possible, or because of severe osteoporosis, chances of failure is high, then you have to think of reverse shoulder. If your anatomical shoulder or hemiarthroplasty fails, also post-fixation of proximal humerus fracture, you need to think of reverse shoulder if your fixation fails. There are certain other situations like chronic dislocation, when there is massive irreparable calf tear in elderly patient and in some rheumatoid arthritis, you need to consider reverse shoulder if it's symptomatic. Before doing the surgery, CT scan is essential, particularly 2D CT, where you need to calculate version of the glenoid. There are few angles or few lines that you need to remember, and accordingly you need to calculate glenoid version. Look for any bone loss on the glenoid side. If there is significant bone loss, then you need to order for augment, just like your knee replacement. There are two surgical approaches in your hand. Either you can go for classic deltopectoral approach or anterior superior approach. This is a 77-year-old male presented with calf tear arthropathy. You can see there is proximal migration of the humeral head almost touching the acromion, and acromion has become like an acetabulum. That means there is no rotator cuff. In this case, we opted for reverse shoulder replacement. We did CT scan. CT revealed there was no glenoid bone loss. It was in this case, we decided for reverse shoulder through deltopectoral approach. We know deltopectoral approach, it's a classic. You need to start from the coracoid process, extended towards the deltoid insertion, dissect subcutaneously. You need to incise clavipectoral fascia inside. Once you have done that, you need to identify long head of biceps in the bicipital group. Then you need to do biceps stenotomy from supraglenoid tubercle. Then you can easily dislocate the shoulder and bring out the humeral head and go ahead with the surgical procedure. In this particular case, we did reverse shoulder. This was postoperative X-ray of that particular patient. Another surgical approach in your hand is anterior superior approach. Another female patient, 77-year-old. Though it was a case of osteoarthritis, but there were severe glenoid bone loss. That's why we had to do reverse shoulder in this case, and we used anterior-superior approach. This was MR scan. On anterior-superior approach, you need to start the incision near the anterolateral angle of acromion. You need to extend it distally 5 centimeter, beyond which axillary nerve is there. You cannot extend more. Whereas in deltopectoral approach, you can extend your incision according to your need. Then you need to dissect between anterior and middle third of deltoid. Again, you need to do bicep stenotomy. In this approach, you do not need to do subscapulary stenotomy. You are preserving subscapularis. That's why you will get a more stable joint. And you need to dislocate the humeral head, and subsequently you need to follow all other steps of reverse shoulder. So this was the postoperative X-ray of that particular patient. Now, if you compare both the approach, both can give similar clinical outcome. There is no superiority of one approach over the other. You can choose any one depending upon your own choice. This is a case of 4-part proximal humerus fracture. Patient was very elderly. There was severe osteoporosis. So we had to do reverse shoulder in this case also. This was CT and this was postoperative X-ray. Another case where proximal humerus fracture was fixed with plate, but the surgeon failed to recognize there was persistent posterior dislocation of humeral head. In this case, we did CT, and there was locked posterior dislocation. We had to do reverse shoulder in this case. Chronic dislocation, another indication, another situation, you have to think of reverse shoulder. This is a case of 71-year-old female. She had epileptic attack roughly 2 years ago. Since then, she was having persistent dislocation, and we did CT. Head was grossly deformed and locked dislocation was there, and had to do reverse shoulder in this case. This is one of our own patient. Patient had proximal humerus fracture dislocation. We did CT. She presented late, maybe around 2 months after trauma. We noted that head was dislocated too much medially. When we are trying to retrieve the head, because of fear of neurovascular injury, we could not retrieve the head. We ended up doing a hemi. But patient was not happy. She had severe restriction of movement, and she came back roughly 3 years back, and we had to revise it with reverse shoulder again. So in conclusion, there are multiple indications for reverse shoulder. It's not only restricted to fracture scenario. All your failed fixation or failed hemi, you can revise with reverse shoulder. Indications are gradually expanding. To perform this approach, you have two approaches in your hand, either deltopectoral approach or anterior superior approach. You can choose any one depending upon your expertise and your choice. Thank you.
Any questions? I think after this lecture, we have Dr. B.D. Chatterjee's lecture. So we can ask questions after that. So overview of total revision, total knee replacement by Dr. B.D. Chatterjee.
Thank you very much. It's a great honor to be here, and my sincere thanks go out to Dr. Arindam and the rest of the organizing committee. So the new epidemic which we are facing today is the revision arthroplasty, especially of the knee and the hip, as a direct consequence of the explosion in the number of primaries that are being done. So we look at some of the reasons why the revisions are increasing and what are the solutions which are on offer today. So this is the incidence, is about a little bit more for aseptic revisions and a little bit less for septic revisions. But I suppose in our country it could be the other way around. This is a very interesting paper by in fact, my good friend actually, Peter Sharkey from Rothmans in Philadelphia. So this was published in 2002, and you can see that the commonest cause of failed TKR was polyethylene wear. Now, we all know that the polyethylene was the weak link in the chain, and that was rectified once the polyethylene underwent changes and we started getting the highly cross-linked polyethylene. Now, interestingly, the same group wrote another paper in 2012, and there the commonest cause of failure was instability. It was no longer PE wear. So that's an interesting finding. Now, okay. So we look at some of the factors which influence failure. It can be classified as patient factors, surgical factors, and implant factors broadly. So if you look at patient factors, the males have apparently a higher risk, which is understandable because they have a higher level of activity and more muscle action. Osteoporosis accelerates loosening activity levels, as we said, and rheumatoids seem to have a worse prognosis. But I think by far the most important factor is our surgical factors, basically surgical errors. Among them you have malalignment, as you can see, varus placement, or an example shown here, or you have ligamentous imbalance, in other example, and incorrect sizing, as you can see, a very large femoral component has been placed. If you look at instability, then inadequate ligament balancing is the most common cause, and the two very predominant studies, one by Fairing, very famous studies actually, and one by Sharkey et al., and they have shown that this is about almost a quarter of the cases are because of inadequate ligamentous balancing. So we have to remember that instrument systems may be precise or improving all the time, but they do not guarantee a perfect alignment, and therefore I think a lot of the time this depends on the surgeon's experience. Maybe the robotics which are coming in now might influence this particular reason for loosening. Aseptic loosening, again, almost a quarter of the findings, and 13% due to failure of bone ingrowth. So this was a problem with uncemented implants, which has been addressed to some extent, and I think we are getting better results now with the modern uncemented implants. And the average time is about 4 years. So coming back to polyethylene wear, almost a quarter of the causes are that. And the quality of polyethylene is one of the factors, but one must remember that the pattern of wear in the knee is a little bit different from the hip. In the hip, it is a volumetric wear, which is directly related to the cross-linking of the polyethylene. Now, in the knee, it is more of a design-related issue. And to be precise, it is the relationship between the congruity of the poly and the femoral surface. So if you have a round femoral surface on a flat poly, that seems to be a recipe for wear. Now, as you can see here, the wear in the poly can be either a front wear or a back wear. The front wear where the poly articulates with the femur, and the back wear where the poly articulates with the tibial base plate. And you can see from this picture that the results of wear can be really quite disastrous. There's extensive bone osteolysis and metallosis. So this shows that when you have a flat poly, this was the trend some years back where the poly was very flat, and the reason for that was that this gave very good rollback. So the designers thought that they went in for this because the rollback was good, so the flexion achieved was good, but then the downside was that it caused extreme wear. Infection, of course, is another cause, almost 15% in the two studies, and the infections can obviously be early or late, and the problem here is the biofilm formation. The other epidemic which we are facing today is periprosthetic fractures, supracondylar femoral fracture being by far the commonest, and this is again another very important cause of revision. So these are the clinical indications when you go in for a revision. The surgical challenges that you face in this revision scenario are either soft tissue related, ligamentous instability, and various types of bone defects. So if you look at them individually, Eng classified the soft tissue problems. Absent PCL is regarded as grade 1, can be easily addressed by using a posterior stabilized implant. When the LCL is absent, then this is the grade 2, and this again can be addressed by increasing the height of the post and the box. Example is the TC3. But when you have a bilateral both the MCL and LCL absent, then there's a significant coronal plane instability, or when the MCL is completely absent, and this usually requires the use of a hinge. Example here of a severe lateral collateral instability managed with a constrained implant of the TC3 type. Another example where there's a severe disruption and of both the collaterals, and this required the use of a hinge. If you look at bone defects, then type 1 is a localized defect. It can be managed with bone grafting usually. Type 2, when you have the cortical rim is intact. Now this is important because this means that the collateral stability has been maintained. So here again, this can be managed with just the next level of constraint. But when the bone defect is more extensive and the collateral insertions are gone, then this requires the use of a hinge. Now coming to bone defects, we have the augments and wedges which can be used to address bone defects. An example here of a severe tibial condylar defect managed with a wedge. You can do impaction bone grafting. Advantage here is that you don't need to machine the defects and lose more bone. You can pack it nicely around the stem, but it's highly technique dependent. You need to be conversant with the procedure. If you have a bone bank, you can use massive allografts. In this example, you can see a split femoral head which has been used. Trabecular metal is another very useful tool. It's a high flexibility metal with porosity which has osteoinductive effect, and it allows ingrowth of host bone, and they can be shaped into various ways. This is the tibial part, the tibial and the femoral components shown in this picture. And then we come to metaphyseal sleeves. These are porous coated stepped devices. These actually load the bone, and by Wolff's law, it causes a good regeneration of the host bone. And particularly when you use it with a mobile bearing tray, this is a very, very good way of doing this. Some examples: an infected knee treated with two-stage revision. This is the implant, in the spacer in place. This is the bone defect. When you take out the spacer, massive loss of bone. This is the trial of the sleeves on both sides, the trials in place. This is the definitive implant, and this is the final X-ray after the surgery. Yet another example of a two-stage revision. Massive bone loss managed with very adequately with the sleeve. Here is a periprosthetic supracondylar fracture which was fixed with a plate and also revised and managed to attain union. This is a non-union after a periprosthetic fracture which was fixed and had to be revised with a hinge. But again, as you can see, it showed good union. Now when there's not enough bone stock available, then you have to go and replace the entire distal femoral part, and then end up with a tumor-like prosthesis such as this. So in summary, aseptic revisions are commonly required for implant loosening, osteolysis, and stability. Diagnosis is usually done by X-rays. MRI may sometimes be required with metal artifact suppression technology, but it's important to operate them on time because any delay will cause loss of bone. Ligamentous laxity and bone deficiencies can be restored. We have the means to do it today, and in septic failures you can either do a one-stage or a two-stage depending on the situation and your training. I thank you for a patient hearing.
VD, can I ask one question? What is your opinion about alignment?
Okay.
Does that have anything to do with loosening?
Yeah, so you really opened a Pandora's box. So uh, it used to be very simple. The mechanical alignment theory proposed by Insol was very easy to understand, and it seemed very logical. That everything is straight, 90-90, that's it, and it was easy to replicate. And in its favor, I must say that in more than maybe 85% of the time it was okay. There was no problem. Uh, Now somehow to explain this 15% of dissatisfaction, we had this group of Howell and Hollinger who said that this is, but frankly, I mean, I have to take their theories with a pinch of salt. I mean, we really don't know whether it is that which has caused this 15% of dissatisfaction. So they said that it is the soft tissue releases that you do. But I think it gained ground more with the publication from Australia, which came out with the CPAC classification. So the message from that was that all knees are not the same, and they have classified that there are 9 types of knees. Now, the majority of them, if you bring all of them into one alignment, then you may be okay in 85%, but you don't. But you may have a problem with the 15%. So people are now talking about the customized alignment. Now coming to revisions, it's again very interesting. So mechanical alignment, properly balanced, in fact has a low rate of revision. Now when you look at revision rates after unrestricted kinematic alignment of Howell, then there are 2 important papers, one Nakamura from Japan and other is the Dorset's paper from US, where when you have an unrestricted mechanical alignment, the moment you cross about 5 to 7 degrees of varus, the results are disastrous. So there's no doubting that theoretically the kinematic alignment may be very, very scientific, but it has its margins, it has its limitations. That's why then people started talking about restricted kinematic. And then they have this, where again they've brought in boundaries so that you can do kinematic alignment, but you have to be within this place. So it's a sort of a combination of tilting the implants and at the same time doing a reduced amount of soft tissue release. So it's a sort of a compromise. So I would say that I think if you have aligned well and I think the most important thing is balance. It's more than alignment, it's the balance. If your coronal and sagittal balance is good, that knee will last, even if it is slightly off the vertical.
Besides, there's another thing that we don't have any reliable Indian values for the natural knee.
Yeah, unfortunately,
we have to depend on Australian and Japanese stuff.
Yeah, that's true. Yes, I mean I agree. We don't really have our own values, but I think we can adopt those concepts. Maybe not the values, but we can adopt those concepts, and I'm sure they will apply here. I mean, what I call it, I know what I call it is common sense alignment. I think if you have a knee which is in severe varus, don't put it in valgus. Yeah. I mean, similarly, if you have a knee in valgus, don't put it in varus. I mean, it's good to accept. And yeah, you have to balance. I mean, you can't get away without balancing. But I think the extremes of balancing and soft tissue dissection, I think you have to avoid. And the surgical technique has evolved over the years. And if you look at yourself, I mean, we are not doing the kind of soft tissue releases that we used to do, maybe a decade ago.
Yes.
So it's more of, applying common sense, I think.
That's a reticence.
I think, yeah. I mean, it's common sense alignment. Okay. Thank you very much.
Any questions for Biplab? Biplab on the reverse shoulder.
And just I have one question or suggestion that while doing for malunited or non-united proximal humerus for reverse shoulder, I think it is better pertinent to mention that axillary nerve functioning is normal. So that is the first thing before you go for reverse shoulder in those cases.
I know there are many arthroscopists around, but what do you mean by an irreparable rotator cuff tear? I know these people can do wonders with the arthroscope, but even without an arthroscope, if they do a mini open, which was demonstrated earlier and which is much easier to do and done very well by many others, do you think that that is a thing to be followed up? There's nothing called an irreparable arthroscopic repair. I think Shondendu has something to say on that.
I think the question what Indroda asked, the whether the calf is irreparable, any calf. There are lot many criteria on that. That some cuffs you just cannot repair. One is the first, easy to remember is the one if the cuff is retracted up to the glenoid. So that is not going to come. Second point that we have to remember is the type 4 fatty degeneration of the either supra or the infra or the subscap, whatever, the Goutelier classification. So this is beyond that. And the indication what Biplab is mentioning to is not the reverse is indicated for the irreparable cuff. There we first will try with the tendon transfers. It is not the first choice of the option. And the cuff or the reverse is the best indication for the reverse is the calf tear arthropathy. When it has gone up to the acetabulum and that is known as the acromion, that is known as the acetabulization of the acromion. This is a false joint between the undersurface of the acromion and the humeral head. So there is no space left. So there, even if you do the tendon transfer, it is not going to function. Because if your three of the tendons, subscap, supra and infra, all three are gone, then the deltoid is only the functional muscle which is going to act. So that's why I think Chandan mentioned one point that if you want to do a reverse, you must have a EMG and NCB to prove and document that your deltoid is functional, not the clinical aspect. If your deltoid is not functional, it is a day one failure and it is a, I think, a unjustified decision to undergo revision this RSA. RSA is not indicated at all. This is who is going to function because deltoid is the only muscle which is going to function in RSA.
Just, I was coming to say what Shanendu winded up. The workhorse for this RSA is deltoid. So, deltoid should be worked properly and deltoid had two types of fibers. So, EMG, NCB will tell you about the contractibility and the power of the fibers of the deltoid which will actually let the thing go. And another point is you should do a little bit of nowadays CT scan of glenoid. If you need a backup, you can do an augmented glenoid in this case. Yes, yes.
It is a must. Even more important than MRI.
My point is that if you have a destroyed, what do you call, glenoid, you can have, now the things are available, you can have an augmented backup.
Another thing, in cases of the proximal humerus fracture, suppose if we have to choose between the reverse and the hemi, it is better whether the tuberosity is repairable, then hemi will be probably the better option than the reverse shoulder. Because after the reverse shoulder, what if it is fails, then what will do you have to think?
Just like your hip replacement, when you choose hemi arthroplasty of hip and total hip replacement, the age is the factor. If the age is young in shoulder proximal humerus fracture, then you need to think of hemi. If the patient is less than 60, go for hemi. If the patient is elderly, 70, 75, reverse is the option. because your tuberosity will not heal.
Rotator cuff tear with arthropathy.
If the patient is elderly, 70, 75 years, that cuff will not heal. Re-rupture rate of rotator cuff is roughly 20-25%. If you are repairing in an elderly patient, then your re-rupture rate would be much higher, maybe 40%, 45%.
I think what we are discussing about the reverse and the hemi, the take-home message and lot many papers are there. The age is the main important factor, and I think if you read the maximum papers, they have given the guideline that is 50 years or it is less than 60. The result of the hemi is much better than the reverse. If it is more than 70, then the reverse is probably the choice. Otherwise, if you put a reverse in a 50, 60 year guy, this is a problem, because this is not going to last more than 10 years. Even the 15-year data is just coming. So the 10-year mark we should take off.
Fine, I think we've gone through this. We are not having the next session. Chinmay will just say this.
May I request the presidents to, chairpersons to stay there, and we have to felicitate 2 or 3 of our EC members whom we could not felicitate in the inaugural session. Dr. Shovik Das, please come. Then Dr. Shashinder and Dr. Samundeshwari. May I also request Dr. Arindam to felicitate the chairpersons, Dr. Arindaji Sardar and Dr. Chandan Pathak, with a memento.
Mementos, please.
Another memento, please. Now there will be slight change of program. May I request there will be a presidential oration by Dr. Arindam Banerjee, and may I request Dr. Amitabh Narayan Mukherjee and Dr. Biplab Doloi to chair this session.
Hello.
Dr. Arindam Banerjee is the president of WC India chapter, as well as the president of WC International. He is a consultant orthopedic surgeon at NH Super Speciality and Multi-Speciality Hospitals, Kolkata, and the director of Medline Nursing Home. Already I told he is the president of SICOT, of WOC, and he is the examiner of the SICOT and a former chair of the SICOT Education Committee and Education Day Committee. And he is the former president of NAILS and AOTS as well. And he is a valedictorian, University of Vienna, and senior IOS fellow in 2008. And he is the Indo-Bavarian traveling fellow in 2016, and is the editor in chief of major research work from Springer Nature, and he will deliver his presidential oration. May hand over the session to the chairpersons, Dr. Amitabh Narayan Mukherjee and Dr. Biplab Doloi.
So with this, I will request, I would say Punky, his used name, long association, Arindam Banerjee to speak about. It gives me a real pleasure that I am 30 years old member of original WOC. So this WOC is again taking a good shape in the hand of Arindam. That's a really pleasure for us. Arindam, please go ahead.
Yeah. Can we have the slides, please?
And Arindam is from National. No one has mentioned it. I remember his, college days.
Okay, so I've been working in orthopedics since 1986. So this being 2025, it's 40 years of working in one subject. So what I would like to do is draw some lessons about what is in and what is out in orthopedics. Especially, I'm just going to talk about trauma today because the entire orthopedics is a very broad canvas. So the first thing is that there are very few laws and facts in biological sciences. We generally work with hypotheses and theories. Most of our views are based on statistics and probabilities, and not on something like the laws of physics or mathematics. Therefore, our old ideas are constantly being replaced and being challenged, revised, and what was the gospel maybe 3 or 4 decades ago may stand discredited today. And sometimes the theories change so much that there is a 180-degree change in the concept. So let's just spend a minute trying to understand what is theory, what is hypothesis, what is fact, and what is a scientific law. So if you're sitting under an apple tree and the apple falls on your head like it fell on Newton's head, then you can have a hypothesis that the apple fell because of gravity. If the apples keep on falling regularly, then that hypothesis will become a theory that every, we might have a concept that this is what normally happens. It's a theory. And it becomes a law when we realize that every object which is falling from above to below, it becomes the law of gravity. So these are the basic concepts. And based on this, we have to understand that in orthopedics, all of us here, the senior people and some of the people in mid-career, we have been witnesses and participants in a sea of change. All of the operations theories we learned as junior residents, many of them are obsolete, and we have to understand what has changed. A lot of change has happened in surgical incisions, in surgical exposures of fractures, and how we protect the neurovascular structures, how we handle the soft tissues. The equipment which we use, the general instruments, have changed in design. The purpose of the operation has often changed. The surgical steps and the goal of surgery may have changed. The use of CDs, C-arms and 3D CTs have become much more paramount. The traction tables, the radiolucent hand tables, material sciences, metal alloys, what we use, the polyethylene, the flexible reamers, the different kinds of anesthetic techniques which we have, the changes in the MIPO techniques, the new regional blocks, the antibiotic regimes, the intensive care support, the use of specialized orthopedic equipment, the way we reduce fractures, often using indirect reduction of fractures, the entry points of nailing, they have all changed. What has changed even more? Orthopedic implants. The type of implants we use nowadays were not used when we were in training. Now, when an operation improves, and this is a graph I just made yesterday. So generally, if you have, on the left side, you can see here, that this is how technology improves. So you had music cassettes, then you had music CDs, and then you had music on iPhones, and then music on cloud, and then Spotify. So these are the graphs. This is how it changes. But in scientific and biological studies, it changes, in my opinion, this is my opinion only, it changes like a spiral staircase. So on one side, you have the progressive improvement in technique. If you are doing an operation repeatedly over 30 years, your technique will improve, obviously. But in addition, there is change in the material sciences, there is change in knowledge, and there is change in clinical results. So clinical results wise, you are getting input that this operation worked, that operation failed. Knowledge is increasing with dissemination of knowledge through the internet, worldwide knowledge we are getting access to. And in addition, the material sciences are changing in the sense that, for instance, you previously had a reamer for a K-nail, and then the metal changed, and you are getting a flexible reamer, so you can do another different kind of operation. The 3D CTs are coming into, you can do a 3D CT. That's technology you didn't have. So you can do a different kind of operation. So this is causing the improvement of an operation. So with this background, let me just go quickly through what I think are the changing hypotheses. So what did we learn previously? that open fractures should not be internally fixed, number one. That's what we were taught. It should be externally fixed. You should not touch the fracture. Open fractures need immediate debridement within 6 hours. That is what we were taught, that you have to get up in the middle of the night and do the debridement. Or something like a 3B fracture, it should not be nailed. You can only put an X-fix. So all these theories are out. So what's in? So the thing is, internal fixation can be done in open fractures if you do adequate debridement. Now, you should not do it for every case. Obviously, if you have a biologically contaminated wound, you should not do it, because that would lead to a surgical disaster. But anything short of that, practically, with adequate debridement and with repeated debridements, you can do an internal fixation almost everywhere. Now, coming to the 6-hour rule of debridement, we have realized that this original hypothesis was based on the study of guinea pigs, and it was a paper in 1898 done by Frederick, which made people get up in the middle of the night and do a debridement. That now has changed. That doesn't mean you can do it 7 days later, but definitely you can do it within 24 hours. But what is important is the quality of debridement. So you need to do it in a way that the debridement is adequate. And if it is not adequate, revisit the patient and do it again. And finally, 3B fractures can be nailed. It has been shown by the Edinburgh School very adequately that 3B fractures can be nailed by the fix and flap technique. And in fact, I think we were one of the first groups in Kolkata to do this in West Bank. What was West Bank then? And we have done many cases with colleagues, with plastic surgeons. And we had two very good committed plastic surgeons, Dr. Monish Ghosh and Dr. Anupam Gulash, who helped us. And we've done many of these cases very successfully. Now, why has this practice changed? The reason this practice has changed is that the firepower of antibiotics has improved, and open fracture is no longer a life-threatening injury. In 1850, if you had an open fracture, you died. But with the newer IV antibiotics, it's no longer a life-threatening injury in most cases. Understanding of microbiology and understanding the behavior pattern of bacteria is better understood. So when Lister brought out his work, he improved the mortality of serious open fractures. He brought it down from 50% to 9%. Then our knowledge of vascular anatomy has improved. And this allows better wound coverage. So the wound coverage has improved amputation rates to the extent, we have to remember that 3 decades ago in USA, if you had a 3B fracture, the amputation rate was 15%, which is no longer the case. We improve with wars. Actually, orthopedics improves every time there's a war. So the Crimean War, we learned lessons, and then these were used in the First World War. We learned lessons. They were used in the Second World War, the Vietnam War, the Korean War. Every war makes our understanding of fractures better, and we treat them better. It's we can say, collateral damage of war, but the quality of debridement has to be improved, the quality of implants has improved, the quality of surgery, by which I mean not damaging soft tissue. Because in our time, surgeons used to think that, it's just, soft tissue is just impeding our approach to fracture. So once we learn to respect soft tissues, our results improved. Okay, coming to plate fixation. Fractures, one concept was fractures must be fixed rigidly. That was the original AO concept. And there should be only 2% strain. And primary callus should not happen. Then, so fractures must be compressed for union. To achieve union, we have to have compressed the fractures. And fractures should not damage both the subperiosteal and the endosteal layer. So that, all these thoughts are now out. So what's in? So absolute fixation has been replaced by relative fixation. So instead of a 2%, less than 2% strain, the strain can be between 2 and 10%. Of course, above 10%, it's also not good. Correction of rotation, alignment, angulation is adequate in most cases, or if not in all cases. And the other thing about compression, we have realized that controlled distraction, by which I'm talking about the Elizarov technique, can also give rise to callus. And today, I think in the last 5 years, we are seeing a lot of the nail plate combination. So people are putting both a nail and a plate. Theoretically, they are injuring both the periosteal and the endosteal surfaces, but that is also working. So this hypothesis has also changed. So these are some of the curves. You can see the elastic Young's modulus of bone, and you can see how the concepts have changed, right from, if you can see here, the rigid fixation to the flexible fixation. So in rigid fixation, we had smaller plates, more screws. Now we have moved on to larger plates and less number of screws. So why has this hypothesis changed? Because bone and muscle vascularity has been mapped out better through many anatomical studies, and we realize that bone has much more reserve than we thought before. Absolute fixation based on Perrin's work leads to devascularization of bone and necrosis. Zero callus leads to lack of bone strength, and this leads to refractures once the implant is removed. So every butterfly, every fragment today does not need fixation, though I would say a lot of people are using a lot of circlage wire nowadays. I'm seeing a tendency. I'm not sure if this is good. Maybe large butterflies need to be put back in, but whether everything needs a circlage wire, I don't know. So this is a concept. We are in the middle of this change. And controlled and systematic distraction of a fracture can be used appropriately. We have a few landmark papers. I will not go into them. But looking at it, IMN was associated, intramedullary nail was associated with lower rates of infection and less fracture healing problems as opposed to the external fixator. This is based on a lot of work. Primarily, again, we should always mention the Edinburgh School, the Court Brown School. And another thing is that interlocking nail reduces the incidence of complications like infection, non-union, and is more acceptable to patients than external fixation. And this is another paper based on the work of the Edinburgh School, who have revolutionized this concept provided the debridement is done properly. And this is another one, another concept, that there was a thought that if you have an open fracture, you should not ream the fracture. So with the SPRINT trial and multiple other trials, it has we realized that there is no need to use, you can use ream nails. You don't need to use unreamed nails, because unreamed nails are fragile, they easily break, and the size is less. So it leads to more instability. And if you used ream nails, then you have the chances of non-union come down. Changing hypothesis, again, nail fixation. So what's out? So one of the concepts is that you just need to align the fracture in some way. Put something through the proximal, put something through the distal, and you get a relative fixation. Then there was a concept that reaming destroys endosteal vasculature. And finally, do unreamed nails, as I just mentioned some time ago. Now, that is out now. So what's in? What is in is that there are many more options now in nailing. You have more options of locking. You have polar screws. And the newer generations give an extension of the fracture scenario. Reaming initially destroys the endosteal vasculature, but given a few weeks, it comes back and the chances of union actually improve. And as I mentioned, unreamed nails are rarely used nowadays. We put in a thicker and stronger ream nail. So you can see here the previous concept. Just put something proximally, distally, put it together with screws on both sides, and you're done. Well, the job is not done nowadays. So you have the options. You have lots of locking choices. And as you can see on the right side, you have the nail and plate. which you can do for a specific unstable case. Why has this hypothesis changed? The hypothesis has changed because we have better understanding of nail entry. So we've studied all the different types of nail entry points. We have better cutting tools which are sharper, and therefore they actually do less trauma. The nails are better designed. The better techniques of reduction are understood with the use of the shank screws, etc., where we don't actually have to violate the fracture to reduce it. Now, RCTs have been shown, as I've shown you, that ream nails do better, and extended indications of nailings can be used for complex fractures, and even radical ideas, things which we would think are very radical, like a supracondylar nail. Even these concepts have come out. We used to think that it's a crazy thing to violate the knee joint and put a supracondylar nail, but the proof of the pudding is in the eating. It does work. So that's why supracondylar nails are being done frequently. Another thing, pediatric hypothesis. These were older concepts. One in our time. Children's fractures should not be fixed. Very few pediatric fractures need fixation. And fixing pediatric fracture leads to infection and growth disturbances. So most of these thoughts are out now. So what's in? Well, pediatric fractures can be fixed, should be fixed if required, and we can do it if we protect the growth lines. Many fractures have better outcomes with less residual deformities. So pediatrics fractures which were not fixed, longitudinal studies have shown that they were left with residual deformities. They had life of deformity. So nowadays there are better options. You can fix them. Of course, it is again important that respect to anatomy and growth lines is essential. And the other thing to remember is that the implants must be slightly less, must be designed a little more differently than from adult fractures. So like this, you can fix all these fractures. You can see here, they're different for adults and different for children. For instance, you can put in a 10-year-old, you can put a plate in the femur shaft, but that would not be acceptable in an adult. You can put TENS in a forearm fracture, provided you don't breach the growth lines. You can, it's often better in some cases than just opening up everything and putting a plate. So why has this hypothesis changed? The first thing is child rights. Children have many more rights than before. So previously you could make a child stay in bed for 6 months or a year, and it was perfectly acceptable. Now children and their parents may not accept it, so you have to find another way. The quality of the life of the child also matters. Prolonged inactivity, going away from sports is no longer acceptable. Third thing is that pediatric orthopedics is a subspecialty, and implants designed for children are available. We have to remember a child is not a mini adult. So the shape of the bones are different, the implants have to be different. And follow-up of children's fractures show that they are, if you fix them, they are not associated with any kinds of infection or growth retardations, provided you follow the rules. And good fracture fixation, if done properly, is associated with less deformity and less morbidity. So other current beliefs, I have not tried to cover everything, but I have tried to cover a few points. An implant is not a reducing tool. So the reduction has to be achieved independently, and the implant is merely a holding tool. Number 2, nail plate combination is acceptable nowadays for specific fractures. Number 3, perfect reduction of a fracture is expected. Now that is something we always talk about, that this fracture, this fixation failed because the reduction was not perfect. So we did a neck of the femur, we left the fracture in varus, and our fixation failed. So nowadays there's a lot of emphasis on a perfect reduction of fractures. Some fractures respond well to a lot of rigidity, others to relative rigidity. In children's fractures, over reduction in torus fractures is sometimes desirable, and as I showed you earlier, plates should be longer with lesser number of screws. Soft tissue damage should be kept to a minimum during surgery. Blood supply of the fracture should be preserved at any cost. Wherever possible, a close reduction should be done, indirect reduction of fracture fragments and MIS techniques to be used. But, this is important, but this should not be at the cost of the reduction or restoration of alignment. So, if you have done a MIS and you have not reduced the fracture, that is not acceptable. So, you should try MIS, but you have to reduce the fracture. If you can't reduce the fracture, you might have to open it up. I mean, so the accent is on reduction. Now, personal beliefs, I believe a few things myself, having worked for 40 years on this line. Rehabilitation should be appropriate and consistent, but there's no need for bravado from the surgeon. So you don't need to make the TKR walk in the evening after operating in the morning. You can jolly well let the patient have some rest for 2 days and do that. There's no point in causing the patient unnecessary pain. The main thing about physiotherapy is consistency and regularity. Weight bearing and loading of a fracture which you've done should be progressive and graded. Don't jump in. Do it slowly but consistently. Implants should be made of good material and be MRI compatible nowadays. There's no need to operate on every case you see. Operate on the ones which need operation. You don't need to over-operate. And not all implants are better. Now, in my opinion, this is my opinion only. I'm not saying it has to be yours. For instance, the screws. I think the hexagonal screw, for instance, was a better shaped implant was a better for the screwdriver than the current star shape, because I think the star shaped has lots of problems. So this is just a thought, because I've been, we are doing a lot of star shaped screws nowadays, and I think the hexagonal was better. So in the next 20 years, there's going to be a lot of debate on this. Who is an orthopedic specialist and who is a subspecialist? I'm already facing this problem. I think we've become like general surgery. We are going to become general orthopedics soon. And then there are going to be individual subspecialties who will work on different bones. So that is coming. It's already come in my generation. AI and robotics will play a big role. Drugs will play a big role. And diagnostics will play a big role. So thank you very much. I think I tried to summarize all the changes which have happened in the last, this is not exhaustive, this list, but I think this is the tendency and this is the direction we are taking. Thank you. Thank you very much.
Thank you, Pangi, for such a elaborate discussion on the journey. It was really nice to share with you, because I also stay in the same age group. You please stay back.
May I request Dr. Amitabh Narayan Mukherjee to felicitate Dr. Arindam Banerjee.
Honor to Arindam Banerjee.
May I request Dr. Biplab Doloi to felicitate Dr. Swarnendu Samanto. Now it's time for the panel discussion, which is moderated by Dr. Arnab Karmakar. And the panelists are Dr. B.D. Chatterjee. I'll request Dr. A.N. Mukherjee to stay there as a panelist, because Dr. Indrajit Sardar, I think, sir, has left. And I'll request Dr. Swarnendu Samanto to be in the panel. So, Dr. Biplab, please.
Okay, so straight away we'll go to the cases, sir. We'll not waste any time. So, this is the first case. 53-year male, fall from stairs, but that doesn't match the X-ray. Some neurological disease he was suffering, which was treated, but he was able to move and ambulatory. 1-month-old injury presented to us. So mostly you are looking on the left side now. The right side has also got another injury, but on the left side. CT scan?
Yeah, CT scan.
CT. Everybody. But somehow the history was not, because this sort of injury, what could be the possible sort of injury, sir? Bilateral acetabular fractures, neck femur.
This is basically osteoporotic fracture. That's why it has gone into the floor, the quadrilateral plate has been blown off.
Maybe maybe dashboard sort of injury could have caused this, but
Maybe, but this is mostly because this sort of injury, bilateral osteoporosis is the reason.
yes. Okay. Sir?
Yeah, I mean, it's 1 month old, so the neck has got resolved on the left side because there was a fracture there as well. And it's a bilateral, I don't know, maybe a bitrochanteric compression sort of injury which has caused this kind of thing with an additional neck femur on the left side.
Yeah.
Bitrochanteric compression.
Definitely, this is a compression injury from the lateral compression injury,
Yes.
because you see there is a fracture in the pubic ramus.
Yes, sir.
So this is a compression injury, lateral compression injury, LC type.
So definitely CT scan. So these are the 2D CT plates. Maybe I'll go to the 3D CT. This is the 2D CT. So if you can see, there is fracture on the sacrum ella also on the left side. And right side it was a anterior column, but left side it was a central dislocation, neck and the sacral ella sort of thing. This is the 3D. So from the 3D you can see the sacrum is also fractured. There is an anterior column fractured, central dislocation, but anterior column is not very much displaced on the left side. Neck femur. 1 month old. So how to proceed? Definitely this head is not salvageable now.
There is no question of salvaging this head.
Yes, sir?
53.
53, yeah.
So ORIF is absolutely out of order. You have to go with the hip, total hip.
Total hip.
Totally, the only thing is your floor has been disrupted. The ideal time of doing this is around 3 months, but you cannot tell the patient to wait for another 2 months just to be on the bed, because you see the other side is also been broken.
Yes.
So the patient will be definitely non-ambulatory for
Yes,
some point of
yes,
time,
yes.
because the other side you are not going to fix anyway,
Yes,
because
yeah.
that is the superior, the congruity is there. So that
At
is
the time of presentation, the other patient didn't complain anything on the right side.
No.
Pain
by,
was not
by
there.
1 month. Suppose
Yes.
suppose this is the injury. Forget about the left-sided injury. Definitely, you will keep this patient non-ambulatory for minimum 8 to 12
8 to
weeks,
12 weeks, yes.
because this is a floor injury. Only thing is that your superior dome is intact.
Yes.
So that side, probably even after doing the your THR, you will be making the patient dangle the limb and everything, but you don't able to make the patient walk with the walker. So we have to go with the THR with the consent that you will be still be non-weight bearing for another 1 month, because you have got the other sided injury.
Right.
And as because this is a floor blown off, most of the columns are looking intact, if I am correctly interpreted the CT scan, because it was too glary.
Yes.
I think you don't have to go back. I think the columns are intact. So it is a floor injury. So this is a clear-cut protocol of fixing this sort of floor blown off scenario. You can go with the impaction grafting, and you can go with plus minus mesh, because mesh is also what Arindam sir is talking to, what's in and what's out. Mesh is still in. Some people's hand, this mesh is out, but in my hand, mesh is in.
That means you'll put a mesh and then bone graft and then
Bone graft, it has to be impacts and bone graft. It is not only bone graft. Even now people are telling, if you do your impacts and bone grafting correctly, you don't need the mesh.
Sir,
And
what will you do?
No, I don't think I'll go with that. I will use a peripherally a rim fitting cup. The new peripherals with peripheral screws, you have the pinnacle. So I will most probably use that. I will keep a cage as a standby. It will not be my first option, but it will be a standby in case I'm not able to get a rim fit, because you will not get a floor fit here. You will get a rim fit only. As large a cup as possible with peripheral screws. That would be my choice. The femur is a no-brainer.
Anyone else want to have any different opinion? So for this fracture scenario, is there any special articulation will keep, like dual mobility?
No, you don't need that.
I don't think you need dual. You see, the enthusiasm for dual mobility is now on the decline. And we have seen that if you use a large head, a 36 head, it is almost as stable as a dual mobility. Yeah.
Like so, and any tricks to extract the head intraoperatively? How to extract that?
Use a corkscrew.
You can corkscrew, but sometimes if you can go inside also, that is also
No. That has to be the feel, and you can use the CM.
Yes.
You are doing this, suppose you are doing in the lateral, you just take your one shot, you know, because it is too osteoporotic to go inside.
Yes.
So this is a very, very fragile bone. You can immediately go in. So that is a problem.
What I do, I don't know they will agree with me. I have a sunspin, cancellous sunspin. I initially put the cancellous sunspin, use it on a joysticks, and then I put the screw in and
take it out.
And hold both of them together and take it out.
Okay. So what I did, after opening, I felt the head was not moving at all. I tried to push it also, and it was solidly fixed. So I thought that I'll rim over it and see how much. Because it is the only inferior, do you have a pointer? Only inferior 1/3 was the part of the head, but superior dome and the anterior and posterior column was intact. And the inferior part was on the head only. So I started rimming over it, and then the cartilaginous portion of the head was taken up with the rimmer, and then I created the cup on it in situ without moving the head a bit. So if you can see, this was only the part of the head, but rest of the thing was normal. So then I increases the depth, and finally this is the sort of deep cup I have got. Even after the final rimmer, 48 size, the head was not moving. It was solidly fixed, and I tried to push it also to check after every rimming I tried to push and see that whether the head is moving or not. So this was after the final. So this was the part of the head that we rimmed, and this was the part of the acetabulum. So I finally got a cancellous bone all through around, and then we fixed the cup. Because we felt it was solid, and then we put 2 superior screws. So normal cup we could be able to use with, and then finally we reduced. So this was the intraop CM after. So this was the part of the head, and this rimmed up to this part, and then we fixed. And finally it was solid fixed. Maybe we could have approached it differently, but as I felt that the head was not moving at all, and there was a bit of union going on there, so I didn't disturb. And that's as per BD sir's your opinion, that I have seen also you doing that type of fixation, that peripheral rim fit cup. So we used a drill, and then the cup was really solid.
No, I think this is a good idea that if you find the head is completely incarcerated, then it's a good thing that you left it. The only thing why I would like to use a multi-hole peripherally screws is to put in additional screws into the pubis and the ischium.
Ischium, yes.
Because sometimes you can get an abduction failure in these
osteoporotic bones,
yeah,
especially.
Yeah. So
Yes.
I think if you get 2 more fixation, 2 screws down, it would be more secure.
Right.
No, you need inferior and inferior fixation, because otherwise that can cause abduction failure. Yeah, so
you can. What I think Amiyo sir is asking, whether we can increase the size of the cup.
Use as large as possible.
As large as possible,
large as
because
possible.
you cannot rim beyond. That problem is that patient is already osteoporotic.
Yes.
And I think the idea of using the multi-hole, definitely you have to use the multi-hole for this. Because if you see the recent literatures or the recommendation of fixation in because you see the last time in the CME lecture of the WBCon, I told that if you use that multi-hole cup, you must fix the ischium and the pubis. Then only you will have the problem, this thing. Otherwise, this is going to toggle.
Yes, sir. So 48 we used, that also I thought ki some part of the cup was hanging. So I don't think that we could have increased too much on this. So we settled with this, and so I'll go to the next. So except otherwise it could have been used other screws in the other two zones, then that the fixation would have been much
A multi-hole cup. Only thing is the multi-hole cup.
Yes, sir. Okay. This is the second case. A 37-year-old angstpon diagnosed, treated, operated twice but the right side, but repeated dislocations, bedridden for last 5 years. CT scan was done. This was the version of the cup. Just no, this is version, sir.
This you are talking of the. This you are seeing from the. This is the your sagittal cut.
Sagittal cut, yes.
So you are seeing the basically you can tell it by version, but
Yes.
it is basically the inclination.
Inclination, this and
This is basically this is known as the Larry Dodd's idea.
Yes, yes.
This is known as the anti-inclination.
Yes.
In one view, you can judge both the inclination
and version.
and this is
combined.
Larry Dodd's idea because that you can judge from this CT scan.
Yes. So it
But
seems
to know the anti-version is the best cut is your coronal cut. এটাই তো coronal cut.
Yes. So how to proceed this one, sir? Already operated twice. Revision. So definitely we understand the cup is not in proper position. We have to revise it.
And obviously, because the cup is basically it is like an umbrella now, and that too in a ankylosing situation, the problem is much because you have got a flat back, stiff spine.
Yes.
Flat back, stiff spine falls into the category of 2B, the classification wise. So that calculation you have to take care,
Yes.
so that you give the proper antiversion and inclination. And the thing is that your 1, 2, 3, 4, 5th option, that is the dual mobility, probably this is the only one indication wise the dual mobility will serve you or save your life. Because even with the perfect inclination and basically the Larry Dodd's idea, the AI, still it can dislocate.
Right. So any special tricks while this sort of situation? This is how after we remove the cup, and once we expose, we can see that there is no abductor. The GT was smoothened because of the multiple surgeries. There was absolutely no abductors, and the soft tissue, because he was bedridden for 5 years, so the muscles and everything was very stiff. So this is after removal. The acetabulum looks okay. Bone.
Did you use the exploit to remove this?
No, sir. I just put screws. Once
No,
I
वो
put
तो-
screws, then it came out.
ফিমারটা কিছু করেনি, খালি অ্যাসিডোবলের কথাই বলছি।
But acetabulum, it wasn't.
No, sir. I just put screws, then take out the shell, then use thin osteotomes, and it came out easily. It came out easily. And after removing it, you can see that there is not much of bone loss. So bone preservation was there, and we could have gone with a.
But there is no acetabular bone loss. It is only the acetabular is loose.
Yes.
It has easily come out because from the X-ray itself, it was looking like it was a loose cup.
So in abductor insufficiency, they say that the dual mobility is not of much use. That's what they say. So the only thing you have to use is a constrained cup.
Constrained cup. Otherwise, you have to
And
mobilize.
I think this is a case where you could consider the transfer of gluteus maximus to the trochanter.
But that was
because-
very difficult, sir.
Yeah.
Hardly we could feel the muscle belly in this.
It
case.
was
Very
would
stiff.
be very fibrotic.
Very
yeah.
stiff.
Even if you power up, if you see that the greater trochanter is completely is looking like a bald skull,
Yes.
then it is a problem. If whatever constraint you give, this will dislocate
Yes.
until you do the muscle transfer.
Yes, sir. So we fixed it with a multi-hole cup in reduced version. So we settled with 58 uncemented multi-hole cup. The cup stability was good, and finally, because of we were not able to do any muscle transfer, so the abductors was not there, so we had to settle with constraint liner. And because the patient has got almost all 4 joint ankylosed, both the hip replaced, the mobility is restricted. He is not going to be very much mobile. So even at a lower age also, we have settled down for a constraint, just to avoid any further surgery, so that at least the in-home ambulation is there. So that we fixed with constraint liner. This is the constraint liner. This is the X-ray. So maybe the version looks okay this time. The stem was perfectly all right, so we didn't do anything to that.
Can I say something?
Yes, sir, absolutely.
Some of us must have noticed in such of these cases, Garg is doing a procedure in RG tying rope procedure, like taking a. I think we should. I have tried.
No, definitely, sir. If this patient was not an Angspon, definitely what sir suggested, the transferring the glute max to the GT as an abductor.
Gluteus transfer is different. That's not in this. In these cases, they are doing that tying of the rope.
Recurrent dislocation of the hip. But recurrent dislocation of the hip in instability or muscle balance problem, that is the way. But here the issue was different. Yes, so we need to address the issue. Bolo, please. Just to prevent dislocation.
Yes, that will give the additional stability and will prevent the dislocation to some extent. But
Again,
in long-term follow-up, what will happen, God knows.
Yes, right.
But this is a standard procedure in literature.
Yes. This is the final follow. This is the patient is around 1.5 years now. The hip is still fine, and right side we have done this TKR also, that gives him some mobility, at least up to 45 degree of knee flexion we have gained with this. But because of this quads is really stiff and fibrosed, not much movement is possible. But at least he could ambulate by himself now. This is the final. Thank you, sir. I will stop here. Thank you, all my panelists, chairperson.
Thank you, Arnab, for this nice case discussion. Now it's time for the plenary lecture, because plenary lecture will be delivered by the CCOT President, Dr. Bikash Kanduja, and he'll be waiting in 5 minutes. May I request Dr. Shashinder to come here and take charge and communicate with Dr. Bikash Kanduja. And may I request Dr. Amrish Jha as chairperson. Dr. Rajiv Raman has not yet arrived. So I request Dr. Amiyo Bera to be the chairperson. So after this there will be rheumatology session. After this plenary lecture there will be rheumatology session. And then there will be arthroscopy session. Then there will be spine session. Yeah, while we are waiting for Dr. Bikash to appear in the Zoom, can Dr. Ritika to deliver your lecture? So Dr. Ritika will speak on breakthroughs in knee arthroscopy, and it should be finished very quickly because.
Good afternoon, my respected seniors and colleagues. So my topic is breakthroughs in knee arthroscopy. It's a vast topic, of course, and I'll try to say as much as I can find out. Right? So undoubtedly the most common knee surgery we do in sports is ACL repairs. So the recent trend has been increased interest again in ACL repairs or retaining the original native ACL, individualized reconstructions, remnant sparing reconstructions, and using regenerative adjuncts in the procedure. ACL repair, when we are doing or at least attempting it, it needs to be the cation selection needs to be meticulous. Acute femoral avulsions less than 3 weeks duration, Sherman types 1 or 2, young patients, definitely with lower activity levels, or at least patients who are not involved in sports which require high degree of pivotal injury possibility are preferred for this. Of course, the advantage is that we are going to retain the native anatomy, which also instead proprioception, neurovascular originality, everything can be preserved. So the fixation methods are suture anchor. You can use an internal brace. Multiple new methods are also available, like dynamic intraligamentary stabilization, where we can use a spring technique to provide an anterior tibial translation during the range of motion of the knee. A bridge enhanced ACL repair is also possible, or a BEER, which basically one of the main things which prevents the healing of a native ACL is the the synovial tissue fluid. So this provides a matrix which protects the ligament during its repair stages so that the healing can be happen, and also it gets reabsorbed with time. Individualized ACL reconstruction is where the notion is that one size does not fit all. So with the advent of precision medicine right now, depending on the patient's anatomy, the variations in the patient's anatomy, the functional demands, the graft choice and fixation choices are done based on that. The aim is to cover 80% of the patient's footprint. Single bundle, double bundle, again, the question comes to the, based on each patient, every case is treated differently. Depending on how wide the tibial insertion site is and how wide his intercondylar notch is, the decision is taken. Most recent studies have suggested no difference in the outcome in both the groups. Remnant sparing ACL, in this we preserve whatever remnant is there. It of course helps in regeneration of the proprioception, and also it helps in revascularization and integration of the ligament. In skeletally immature patients, the recent dictum is to avoid delaying the surgery more than 12 weeks because it has been shown that there is increased risk of meniscus and chondral injuries. The type of fixation we would go for will depend on the potential growth, physical growth left for the patient. The role of bone morphology is also important. The tibial slope which we measure, especially in the lateral side, is going to decide the type of, if any other intervention might be required. It increases the stress and shear force in the ACL. There is also increased risk of meniscus.
Sorry, can I stop you?
Yes, sir. Yes, sir.
So just to tell everyone that we are being joined by the current president of SICOT, live from UK, and he's going to talk about 10 tips for orthopedic surgeons. Vikas, can you hear me now?
Right, thanks very much for the kind invitation. Absolute pleasure to be here virtually. Thanks very much to the World Orthopaedic Concern and to you, Arindam and Sasi, for the kind invitation. I bring you greetings from our biomedical campus in Cambridge, which is ever expanding and would be delighted to host you if you ever wanted to visit. It's an important year for us because we celebrate the 35th or the choral anniversary of the first hip arthroscopy being done by my mentor in this institution, in fact in the UK, Ricky Willer. These are my disclosures. None of them are particularly relevant to this talk. So rather than giving you a subject matter talk, I thought I'll talk about the 10 top tips which I think have helped me, which hopefully would be helpful for you and for every orthopod. So it starts here. I was a registrar or a senior registrar in 2004 at the Royal London Hospital, and I wanted to train in hip revision surgery. So I went to my mentor at that time called Garrett Scott, and I asked him, where should I be doing my fellowships for revision hip surgery? And he said, I've got a good friend in Cambridge called Ricky Willer. I'll speak to him. Why don't you go and have a chat with him? And he was doing the maximum amount of bulk allografts in the country and maximum number of revisions at the time. And he would be a good person to do a revision hip fellowship with. So dutifully, I went along with the advice and saw him in 2024. He did an interview and he said, okay, fine, you come back and see me in 2006. You've got the fellowship 2 years later, and we'll start the fellowship. Suddenly, in 2005 December, I get a text from him, 0630 hours at Wellington Hospital. Now, Wellington Hospital is in London and not Cambridge. So I'm wondering, why is he actually calling me at the Wellington Hospital? Anyway, I go to him at the Wellington Hospital, and this guy is going through a midlife crisis, and he's moved his whole practice from Cambridge to London. And basically, for that whole year, I traveled from Cambridge to London after actually moving my own house from London to Cambridge and moving my kids' schooling, etc. And it was the other way around. More importantly, what happened was that we did not see a single hip resurfacing or hip revision arthroplasty that year. And all we did that year was young adult hip arthroplasty and a lot of hip arthroscopy, over 450 hip arthroscopies that year. So the first thing or the first lesson that I learned is serendipity. And I'm becoming a firm believer in serendipity. I went to learn hip revision surgery in Cambridge. I landed up learning a lot of hip arthroscopy in London that year, or between London and Cambridge that year. So whatever comes to you, you've got to actually accept it with open arms. And if you think about it in a deeper process, then serendipity process is an extremely important process. You go with any unexpected event with a prepared mind, you recognize the potential, you seize the moment, amplify the effects, and then you evaluate the effects. So that's lesson number one. You maximize serendipity and believe in serendipity. Lesson number two, you need to understand what it means to be a good surgeon. Sometimes a lot of us are actually just focused on surgical skill because that's what it means to be a good surgeon. Yes, that's extremely important. You need to have good surgical skill. You need to have the compassion for your patients, but you also need to be a thinker. You need to be a researcher. You need to be a good writer. You need to be a good orator. You need to be a good teacher so that you can actually push your students forward. And then eventually you need to be a good manager and a leader. And all these attributes, if you look at any surgeon that you admire around the world, you will see that a lot of them actually have these attributes. So don't just focus on surgical skill and compassion and communication, but also focus on all these attributes because all these take to be a good surgeon. Now let's focus on surgical proficiency. How do you actually achieve or attain it? I can see the desire in every Indian postgraduate student to have instant gratification at the moment, but it does take time. You know, surgical proficiency, ideal thing is you do your postgraduate degree, MS or DNB, whatever you're doing, you spend 3 years in a busy department, then you spend 2 to 3 years in a subspecialty of your choice with good mentors, actually doing subspecialty fellowships, and then you travel and see skilled surgeons around the world to pick up tricks and tricks. That's your base surgical proficiency. In UK, it takes about 15 years to become a consultant. Whereas in India, I'm seeing 3 to 5 years' time, people are calling themselves as consultants. And then probably if you're put up with a big case or a complex case, then you're struggling. But this is what you require for surgical proficiency. And then the next step is becoming an expert. Now, what's the definition of an expert? The expert is somebody who's got knowledge, who's got skills, who's got the experience, and who's able to apply them, okay? So either it's 10 years or 10,000 hours. That's the definition of becoming an expert. But most importantly, you need to have the experience of case diversity and exposure and to be handle complications and problems. And you really require the 3 Ds of dedication, discipline, and determination to actually achieve that, and commitment to lifelong learning. So workshops, conferences like this, peer interaction is key to develop to becoming an expert. And then is steps to becoming a key opinion leader. Everybody wants to be a key opinion leader. Yeah, that's absolutely fine and good, but you need to have the surgical proficiency. Then the next step is to become an expert. And the next step is becoming a key opinion leader. And what distinguishes you from an expert to a key opinion leader is research. So if you look at all top institutions in the world who have an international standard, be it Harvard, Cambridge, or the lineage, and they have elite personnel, that is what differentiates you from becoming an expert to a key opinion leader. So surgical proficiency alone, unfortunately, will not get you to be a key opinion leader globally. And you really require research. Now, in research, there are two tenets. You really need to ask the right question. And because all of you have so much of clinical exposure, patients will tell you what the right question is. So please listen to them, because the good questions will, or the impactful questions will come from actually the patient. So ask the right question and then choose the right methodology to actually answer that question. All of you who are still trainees out there and in your MS or your DNB programs, please start this right early. So don't waste your MS thesis. Think of the right question and think of the right methodology to actually answer that question. Invest time in a higher degree, for example, an MD or PhD. Timing is whenever you're inspired. All you need is substance P. That is the passion and the perseverance for research. You need that growth mindset. You need the curiosity and the 3Ds that I've said earlier. Obviously a commitment, but it teaches you a lot. It teaches you time management and a lot of other skills that will come with a higher degree. Personally, I started my PhD only after I became a consultant with the University of Kent, because I knew the mentor that I wanted to work with in engineering, and I knew the topic that I wanted to work with it as well. And I actually finished this PhD 5 to 7 years down my consultant job. It was difficult because I was doing a busy job and I was doing this as well. But from this came a lot of outputs, lots of publications, lots of grants, invited lectures, awards, eponymous lectures as well. And most importantly, we were able to actually set up a clear research program in Cambridge via my PhD. So a lot of outputs. The next thing that I've learned is you really need to create pathways for people to grow. And I've done that in this organization that I work in the hospital, or any other organization that I'm a part of. You really need to create pathways for people to grow, because if they grow, you will grow automatically. So we've created pathways for lots of MDs and PhDs, for postdocs to actually grow, and actually fellows to come from around the world to do research and clinical skills as well. Now, hopefully this works, and this I got from this Australian comedian. Hopefully this will work.
You don't have to have a dream. Americans on talent shows always talk about their dreams. Fine, if you have something you've always wanted to do, dreamed of, like in your heart, go for it. After all, it's something to do with your time, chasing a dream. And if it's a big enough one, it'll take you most of your life to achieve. So by the time you get to it and are staring into the abyss of the meaninglessness of your achievement, you'll be almost dead, so it won't matter. I never really had one of these dreams, and so I advocate passionate dedication to the pursuit of short-term goals. Be micro-ambitious. Put your head down and work with pride on whatever is in front of you. You never know where you might end up. Thus be aware the next worthy pursuit will probably appear in your periphery, which is why you should be careful of long-term dreams. If you focus too far in front of you, you won't see the shiny thing out the corner of your eye. 2, I'm not an inspiration.
So be micro-ambitious. You know, it's good to have dreams, but you really need to seek perfection in short-term goals. So when I was training in shoulder surgery for 6 months, because we had rotations of 6 months of shoulder surgery, 6 months of foot and ankle surgery, then in those 6 months, I wanted to be a shoulder surgeon. In the foot and ankle posting, I wanted to be a foot and ankle surgeon, because then you're actually putting all the effort in and seeking perfection in that goal. And you have a 6-month plan. Go for a course, learn a new skill, do one part of an exam, do an audit, do a presentation, do a paper. So your CV is actually looking good in all the attributes every 6 months. And that's how it is in the UK, and that's how we work. So be micro-ambitious. The next step is find a true mentor or a guru who really believes or she believes in your success and growth. Bounce ideas, discuss difficult cases, discuss your life and your aspirations with them, so that you actually are able to grow based on good mentoring. The other thing I've learned is, this may or may not be true for some people, but definitely true for me, that you are actually the average of 5 individuals you associate yourself with the most. The 4 top physicists around the world, extremely good friends, and when they got together, they really created magic. and all of them big guys in their own right. So you really need to look at whom you're associating with, who are your close pals, because you are going to be the sum of those 5 individuals you associate yourself with. We are growing and evolving at a fairly constant speed and a rapid rate. And you really need to be focusing on technology. You need to understand our art is the art of surgical research and also of performing surgery. How do we learn surgery? We learn surgery through the Fitz and Foster model of motor learning, which is cognitive, associative, and autonomous. I don't have enough time to go through this, but essentially, you need to invest time in technology because that motor model will only be will be spearheaded and will be rapid if you actually invest in technology. So get hold of the simulators for arthroscopy. Even low fidelity simulators would be good, and do invest time in technology, in learning technology and the appropriate use of it, AI as well, because that will help you going forward. That's tip number 7. Tip number 8, whatever you do and whatever you spend your time in, rather than just running around, just try and focus on why you're doing it. What's your purpose? And I think it is important to spend some time on thinking about it, whether you are following the Japanese principle of Ikigai or you want to follow the Hindu philosophy of Karma Yoga. You really need to find out what your purpose is and why you're doing things. You will find much more pleasure and much more dedication in doing that. Success. I'm sure all of you have watched this. Hopefully this clip will work again. This scene, really, really powerful scene.
किसी महापुरुष ने कहा है कि कामयाब होने के लिए नहीं, काबिल होने के लिए पढ़ो. सक्सेस के पीछे मत भागो. एक्सेलेंस का पीछा करो.
That's absolutely true. You really don't need to chase success. You need to chase excellence. You really need to define. And the other important thing is, having spoken to a lot of you youngsters out there, a lot of people don't want success, don't want to be excellent. That's absolutely fine. So you really need to define it, and you need to understand whether you really want it or not. Because if you want it, then it doesn't come easy. Everybody sweats. Everybody is spending a lot of time to actually get there. And there's no instant gratification, unfortunately. Finally, you really need to talk about work-life balance as well, because that is what is going to get you out of difficult times. And I'll leave you with these words.
I worked a lot, learned a lot, and ran a lot of miles in that small space. But the world is a whole lot bigger than that. Even when I was just starting out, I knew that tennis could show me the world, but tennis could never be the world. I knew that if I was lucky, maybe I could play competitively until my late 30s, maybe even 41. But even when I was in the top 5, it was important to me to have a life, a rewarding life, full of travel, culture, friendships, and especially family. I never abandoned my roots. I never forgot where I came from. But I also never lost my appetite to see the very big world. Effortless.
So do spend time with friends. Believe in your family. Orthopedics will continue, obviously. So you need to focus on that. And finally, remember that it's not about you. It is about the patient in front of you. Eventually, we do all this actually for the betterment of our patients. And that goal needs to be very clear right in the beginning and right in the end. And based on this philosophy, over the years, I've developed a good service, clinical service for young adult hips for the whole of East of England and also Northern Ireland. We've got a fairly good and well-enhanced research group with lots of PhDs, MDs, and postdocs as well now. A well-developed research program, grants over 5 million, fairly decent research output coming out of it as well. Definite textbooks in hip preservation surgery. A spin-out from the University of Cambridge called ArtioSense, which would help joint replacements, measure forces, and leadership positions in all these societies and journals, just based on these 10 top tips and philosophies that I've given you. It's been an absolute pleasure talking to you guys on a Sunday. I invite you all to join us for the SICOT meeting in Madrid from the 3rd to the 5th of September. If you haven't booked or haven't got planning for it, then do. It's going to be a really big and a fun meeting. And I'll stop there. Thank you very much indeed.
Thank you, Vikas. Can you hear me? Vikas,
I can hear you.
Yeah,
Thank
okay.
you.
So thank you for sacrificing your Sunday morning. I know how hard you work over the week. So thank you from the bottom of my heart and from the entire WOC fraternity and the Indian chapter. So this meeting is going very well, and we hope to have you in Madrid as well to say a few words for the international WOC. So we'll be in touch, and we are trying to set up a good program for the Madrid conference. And I think at the end of this meeting or during it, we will also encourage youngsters to submit abstracts and also to try and participate in this SICOT and future SICOTs. So thank you once again, and see you very soon.
Thank you very much, Arindam and Sasi, and to the WOC. Have a fantastic rest of the meeting. Thank you very much for the kind invitation.
Great. Thank you. Thank you. Thank you. Okay, Ritika, continue.
So we were talking about the tibial slope. So often increases the stress and shear force on the reconstructed ligament. So it's recently recommended for in revision cases if the angle is more than 13 degrees. Again, this needs to be done on a case-by-case basis, the decision. The next anatomical thing we look at is the medial tibial condyle, because a shallow condyle will decrease the congruity of the joint and thus lead to increased strain on the ligament. A dome-shaped notch, again, the wider the notch, it will require a bigger footprint, and maybe you have to consider a double bundle for such cases. A pyramidal notch is the blue line, the pyramidal notch is good for most cases. Rotatory instability is another factor which comes in, especially in patients with a high-grade pivot shift, somebody who has hyperlaxity. We might want to do an additional procedure for such patients. Meniscus repair has been much talked about, with the importance of being the solid primary fixation and needing to abrade the margins so that the biological process of cicatrization is stimulated. It will lead to some decrease in the radial length of the meniscus. However, the repair would be stout and the healing will be stimulated. We have many methods of getting a good repair. There are more versatile methods of fixation now, helping us to put circumferential compression stitches, doing a good root repair. Ramp lesions, again, they are often called hidden lesions because they are very easily missed. 9 to 40% is the reported incidence in literature, because often in an MRI we will not detect it. If you are very aware about the contusion in the tibial condyle, then it is reported more. However, even with a direct anterior scopy also it is often missed. Posterior medial portal, using it with a 70-degree scope, has been found to get 100% to be able to identify these lesions. And when they are not dealt with intraoperatively, it will lead to an increased instability, both AP and rotational. It increases the strain on the reconstructed ACL, and even the meniscal tears have been reported to progress further and faster. When it comes to meniscus, the aim is to repair, replace, or regenerate so that we can delay the onset and progression of osteoarthritis. You might have to augment the repair with a fibrin clot in certain cases. If at all it is not salvageable and we have to try to substitute it, one option is an allograft. Allograft can be done for both. The bone plugs are often used for fixation. As long as both the roots are fixed and stable, there will be decreased in the peak contact pressure, which is the aim of the procedure. But of course, allografts are difficult to obtain and they are expensive, and sometimes the matching with the donor and it is also a difficult issue. So if there is an intact meniscal rim, and sometimes in partial cases you might get away with putting a meniscal scaffold. These are also expensive, but they are available and they are made out of collagen or polystyrene, and they can be shaped even in partial cases. They help in the ingrowth of tissue from the periphery, and they can also be embedded with biologicals to help in the healing. 3D printing in this scenario is under study right now. Tendon autograft has also been used. It is being used mostly with gracilis or semitendinosus graft, and it has also been some studies do suggest that there is a good, it also substitutes the meniscus to a good extent. Collateral ligaments, in collateral ligaments, double bundle autograft is going to help to get an anatomical reconstruction. Internal brace augmentation is used. Modified Bosworth technique is a good thing to do. In LCL also, there is certain studies with suture augmentation, improved fixation techniques are under study. Multiple ligament deficient knees, it needs to be a case-based decision on what to do, a single stage or double stage. Again, it depends on the initial presentation and the status of the patient at that time. For cartilage repairs, microfractures are often done. We can also do an osteochondral autograft transfer for a small, 1 to 4 centimeter square lesion. However, in bigger cases, an autologous chondrocyte implantation is often required. The third generation ones, the matric induced ones, there are 2 steps. The first step, the cartilage biopsy is taken from a non-weight bearing area. It is cultured in a scaffold. It is integrated into the matrix. Along with, we can use biologics like BMP and other growth stimulants and use a fibrin glue in the second surgery to put it back into place. There are many advances when it comes to the patellofemoral joint, many new techniques which are going to decrease the risk of patella tunnel injuries, etc. Allograft has been a very good advancement in the recent days. It avoids the donor site morbidity. It gives a versatility to the surgeon when planning for the surgery, specifically in multiligament injuries and revision surgeries. Technological innovations have helped in the procedure. There are many flexible instrumentations available with better visualization. Biologics like PRP, bone marrow aspirate, they are definitely controversial. More studies need to be done and they are being done, and hopefully we will have a better thing in the future with a known effect of helping the healing process of our ligaments. Computer-assisted navigation helps in precise correction in osteotomies, in individualized ACL reconstructions, in difficult revision situations also it is going to be helpful. When it comes to robotic or image-guided knee arthroscopy, there is a future scope of having robotic tools which will give us an extra degree of freedom to use leg manipulators, to have better depth perceptions. Augmented reality is used intraoperatively for better visualization, and also it can help in surgeon training and simulation platforms. Post-operative enhancements, the protocols right now in place which decreases the period of immobilization, decreases patient care, and those are definitely helping the process. And remote monitoring is also one of the advantages right now which we can use. So there is much to be done in regards to AI using smart implants and tissue engineering. So there is a lot we can do further. So to conclude, these are the things we are looking at now: ACL preservation, meniscus preservation, articular cartilage surgeries, and the other orthobiologics and bioreactors in use. Thank you.
Thank you, Ritika, for the excellent talk. So the next talk is by Dr. Samundeshwari Sasinder. So she will be talking on new horizons in shoulder arthroscopy.
Very good afternoon to everyone. It's a post-lunch session, so I hope I will keep you all awake. I thank WC and Dr. Arindam sir and the scientific committee for providing me an opportunity to speak about new horizons in shoulder arthroscopy. Myself, Dr. Samundeshwari Sasinder, Assistant Professor of Orthopaedics from Puducherry, India. The arthroscopy itself is evolving rapidly, and it is no longer about just fixing what is injured, but it is all about restoring the function with precision. That is what we are going ahead in this subspecialty, and it is very important for us to stay updated along with the recent trends which is happening in this specialty. I would like to go through these advances in the following subheadings: the expanding indications for surgery, the technological advancements which we have today, the imaging and navigation advancement, what are the biological augmentations which are at present in the treatment modality for us, the evolving techniques, and what are the future directions. The expanding indications: for instability and rotator cuff, we have newer implants and newer anchor sutures being developed, and we are also focusing on subscapularis repair, suprascapular nerve release, scapulothoracic bursitis. We are getting into more endoscopic arthroscopy, which involves scapulothoracic bursitis, glenoid bone loss management. Now all arthroscopic Lataje has been proposed, and there are more expanding indications for doing a reverse shoulder arthroplasty as well. This is a case example of endoscopic proximal humerus plate removal. Other case example of scapulothoracic endoscopy where scapuloplasty and resection of the Lascars tubercle is being done. This is an example of recent advancements in shoulder replacement where we are heading towards stemless hemiarthroplasty, the Arthrex Eclipse shoulder replacement system. Let's see about the technological advancements. With regards to the anchors, we all now have the all sutured anchors and knotless anchors. The all sutures anchors which has less bone loss, and hence it is easier for revision. We do a lot of revision cases as well now. And knotless anchors, it is more helpful for doing faster procedures. With the instrumentation, recently we have come across the Synergy Pan scope. Hence, no need to switch the scopes of different degrees like 70, 30. And Arthrex has now come up with this system which has ultra wide view also. So you can see whenever you want, you can just switch the mode in your hand itself. And the nano needle which can be used in the outpatient department for diagnostic as well as therapeutic procedures. Next comes the single portal arthroscopy, which is also coming into the market, where in the single portal we can use shaver and then scope view as well. What is happening with imaging and navigation? 3D printing, preoperative planning and intraop navigation are coming up, especially for reverse shoulder arthroplasty. Arthrex has come up with a VIP system, which will help us for more improved diagnostic accuracy as well as in shoulder arthroscopy for diagnostic anchor placement. In biological augmentations, we have PRP, BMAC and scaffolds coming up for cuff repairs, and patch augmentation, which we are all doing recently. Especially it's useful for larger tears and for revision cuff tears. This is an example of the patch augmentation and PRP and BMAC done for a case. Evolving techniques. For irreparable cups, we are advancing towards doing superior capsular reconstruction and balloon spacer as a interpositional arthroplasty, dermal allograft, and the outcomes and current, we don't have the long-term outcome studies, but we are currently doing this for irreparable cuffs. Arthroscopic Lataje has been proposed and it's being in practice now, and it's technically demanding, but now reproducible with more guides and promising early results with, especially in patients with glenoid bone loss. Biceps stenodesis, we have developed multiple techniques, intra-articular, subpectorals and suprapectoral approaches. And all arthroscopic stenodesis has also been developed. The learning curve is huge, but it has less morbidity and faster recovery. We do have cartilage procedures for OATS and MASI for shoulder, especially in a younger arthritic patients. The future directions, robotics in shoulder arthroscopy is under evolving and exploration. Smart implants are being designed especially for RSAs, like the sensors to detect the deltoid strength and sensors to predict the healing and monitoring. And AI in diagnostic and surgical planning is also on the way. To conclude, shoulder arthroscopy is rapidly evolving, hence mastery of new tools and techniques and understanding them will help us to apply in our patients to have a better outcomes. The need for continuous learning and early adoption is the key. Thank you one and all.
Now, any question to these two papers? No.
And I have a question.
Yes, sir.
Yeah. Do you feel there is much better result in arthro-Latarjet? Have you witnessed too many arthro-Latarjet in Singapore, and what is your take on that?
Technically, it is demanding, so the learning curve. We did around like 20 cases of arthro-Latarjet. I had opportunity to see our 6 months outcome. I cannot predict the healing rates, but once we learn, I feel like we can avoid the open incision, especially for patients who have like bigger muscle mass, where the approach is difficult. This will be better.
So have you seen any neurological injury while dissecting your nerves, axillary nerve, and so the nerves
No,
you
sir.
have to dissect out?
No, sir.
No. Thank you. Thank you for the excellent talk. Thank
So we end this session, okay?
Yeah. So
Thank you.
thank you, the chairpersons, and may I request Senior Orthopedic Surgeon Dr. Gurupada Bera to felicitate the chairpersons, sir? Yeah. And next talk will be, we have to have some change of program, and the next talk, for the sake of time, the next talk will be delivered by Dr. A.N. Mukherjee on shoulder prosthesis. That is also on shoulder prosthesis, my journey. And the chairperson will be Dr. Vishnu and Dr. Sharnendu Samanto. May I request Dr. Sharnendu Samanto to come because Dr. Manish Khanna is absent in this conference. So we are running very late. So Dr. Mukherjee, please, and Dr. Sharnendu Samanto and Dr. Vishnu to take the chair.
গুড আফটারনুন। সি আমি জানতাম বইবার লোকে বলবে তোমাকে ঢিলছুড় মারবো তুমি যদি আবার শোল্ডার বলো, কিন্তু আমি আবার বলবো। সো গুড আফটারনুন টু ইউ অল। দিস ইজ রিয়েলি এ জার্নি, সো আই এম শেয়ারিং। আই উইল গো টু কন্টিনিউ শেয়ার ইট বিকজ now I feel it's my duty to inject, to invent something by the juniors, although I could not see any juniors. So to start with, I thank IORA for giving me the honor of being a president, and here WOC for calling me. This is my 30 years old WOC membership, live membership. This is the, you can see 96. I got the WOC membership. So that way I am the oldest WOC representative in this podium, I believe. So start with, I will go straight away. And extensive research has been conducted for last 30 years on the shoulder prosthesis. So where the reconstruction of the proximal humerus was difficult, in that case, this procedure was started 30 years back. First presented 1999 in Howrah Con. They are before that in Chennai conference. So this is the first step, the biomechanical, this anatomic and the cadaveric study. You all must be knowing. You have seen all the cadaveric studies has been done on the geometric dimension of the cadaver. And this is the retroversion. You will be surprised to see that Indian bone has a retroversion from 25 degree to 40 degree. I have given the both on that side. So on this basis of this cadaveric study, we did an radiological study to find out the parameters if everything has gone right. So these are the findings of the cadaveric study. Humeral head 33 to 51, head shaft is 115 to 135, average was 125. Diameter of the proximal humeral canal in Indian was 8 to 12. Anatomically, the version was 25 to 45, average 30, which is far away from the Caucasian. Bulk of the humeral prosthesis on the medial side. So this was the first generation of the prosthesis made by near our PG hospital. The shop is closed. I feel pity for them. So night and night they sit together and we made this first prosthesis. And on this prosthesis, the functional outcome was done. Before that, we inserted in the cadaver, see the cadaveric thing, and we taken replica of the same thing on the radiology and matched with the other one. Next comes the biomechanical study. We did a biomechanical study on the average Indian arm, 2.75 kg with a pulling force of 90 degree on the myosius anchorage. And this all through doing this calculation, we have found this design has a less glenoid wear because less force on glenoid and less dislocation because there's a less force on the downwards. So these are the biomechanical criteria which we have. So after that, taking these biomechanical criteria, the clinical application was done after getting the patent and the what do you call that approval? Ethical approval. So this was the Indian patent of 2002, I believe. 2005, applied in 2 and 2005, so now it's around 20 years now. So this is with the standard protocol, dentopectoral, take out the head, remit, and this is the version. This is most important, the retroversion. And then you go ahead
with prosthetic replacement. These are the retroversion, initially how we used to do. And if you have gap, you used to fill up the gap with the grafts which has been taken away from the excised humeral head. So these are the few cases of the first generation. This was the forepart, this was the head split fracture. So next comes the further modification of the centralizer, and then it came on the Mukherjee's prosthesis on a sterile claim, the monoblock. Then subsequently these instruments were designed and they came in practice. These are the these are the thing how it worked, the centralizer, and this is the ethibond tie which has been very important. So then pointer on kore dao, then time noshto hobe na to. Acha, then it comes like you can put this ethibond tie like this and they do the meiosis anchorage. Subsequently, this is the case where you can see, okay, go video chole na. This is just a this is just 14 days. You can see this is the earlier case when ethibond was not there. We used to tie up with the SS wire. So this is another one. Manav used to tell me, "Tumi sob shomoy abduction dekhao, kokhono forward flexion dekhao na." So this made me to work to see the forward flexion. That was the forward flexion possible. Kire bhai. So you can see that was the forward flexion with the monoblock. So I have indebted to my all the friends because they have attributed some of this journey. So this is like you have a split of the femur. You can tie up and do an prosthesis. You can same way do it here also. So thereafter, this is Swarnendu's case. Long back, this failed. So Swarnendu said, "Tomar ota niye esho to kore dekhi," and that was the case. He is sitting here. Ota ki nursing home ta chilo re Taliganjir okhane. So that has been done here, and I believe that patient is doing well, as Swarnendu said. So this is another case I got from one of my neighboring states. This is the way it came, and I did so. I was not very happy because cement loosening were there. Trust me, this is one of the best results which I could have in my lifetime on a monoblock. So that was the range of motion. Because if you go back to the X-ray, you can see the success was the meiosis integration. This patient has a wonderful meiosis integration. Rotator cuff was been exactly in place and united well. So I go ahead. Time is constrained. Trust me. This is one of the case of the GCT. Anando is sitting here. This case was from Anando's. So this was a school teacher. We did it. And these told us at that time, around 25 or around 30 years back, this reverse shoulder was not much there. But these give us idea that reverse shoulder will work. Because only the jerk of, what you call, jerk of this deltoid, this lady was able to do this. She had nothing. Everything was excised out. So this was the result of the monoblock, 5.5 years. So 79.5% were happy, and the mean shoulder abduction was 15.5. But that was the time which make us feel that we must have a modular one because we were feeling some problems while doing a monoblock. So this was the design of the modular stem, and this is the instrumentation what I planned for the modular stem, and this was the one of the case 55 years gone for the modular stem. I think I will not go for the surgical technique because you all know that. So main key of success of the surgical technique is the meiosis anchorage. Both sides you have to have these ties so that you can tie it back, and that meiosis anchorage should make the shoulder move. And this is how the reduction and trial and reduction. And this is how postoperatively it looks. Even this is not fully done. This should be a little bit down. The upper part of the dome of this humeral should lie 2 to 4 millimeter below. So this is one of the case. In one case, Swarnendu was there, John was there, bilateral. One was fixed and another was revised. You can see both more or less same after 4 weeks. So the rehab is small rehab. It starts after second week, and aggressive rehab starts after 4 weeks. I do because I wait for the osseous integration. If I say I don't have complication, I am lying. This is the complications which we have. This is instability. This is extrusion. First case, I am missing Chandan. My first case was referred by Chandan. Second was Professor G. Shendra. So Chandan's case, I have a stem exclusion. Chandan Pathak, but she was happy throughout. She never complained. We said they will revise, but she was happy. And this is one, migration of GT. This is one, we had an fracture. This is one, we have infection. This is on the late infection. It was initially done in PG and I revised it, but he is so happy with this, he don't want to come for the second stage. বলছে এই স্পেশালটা দিয়ে কাজ চালিয়ে নেওয়া আর করবো না তো so section 5, this is the time for the platform stem, a stem which will give us shoulder, total shoulder and reverse. So this has been, pencil drawing was there. That was the CD CAD model. Then this was the 3D CAD model on which the polyethylene printing was done. And this was the saw bone when it has been tested. And subsequently, this was the movement of the saw bone, tested well. And then we do it in the cadaveric. This is the hemi. The keeping the same stem, did the total, keeping the same stem, we converted the base, keeping the same base plate, we converted it to the reverse. So this is the Indian shoulder system which has been finally designed, and this is how on a human body, how you can change like hemi to total to reverse. Thereafter, this is the saying, this is the hemi, this is the reverse, and this is how it can be changed from hemi to reverse as it looks like. So this is one of the case. Two cases I would say. There is the one which has been put on the reverse. This is one which has been taken in the reverse. So about the scoring system. So this has said this is doing well. I will go pretty fast. This was the dynamic. And this is CT scan showing the same. The scoring system, this is good. And this has been clarified with all international standard and shown this is a good standard. Then we had a scoring system of our own. That scoring system said that this is also good. Thereafter, we do, as I said, we need, this is the time for glenoid 3D reconstruction. So we did a glenoid 3D reconstruction system with our OrthoTech company. And this is the HoloLens. As Swarnendu has also started HoloLens, we also started one HoloLens with this. And this is how HoloLens look like. So you have something which will be in the outside, you can make and you can match from the outside, taking that, how it will look like. So thereafter, this is the jig of the HoloLens. This is the only single case done with the HoloLens. This is how the simulation study works. And this was the cycle, how we started. And this is the Indian shoulder replacement system. So this cycle says how I have started. The monoblock, then reverse, then what I did till date. And with this, I said the journey is not complete. I had more things to work. Thank you very much.
Thank you, Amitabh, for your elaborate description of the journey for shoulder prosthesis. Now it's time for the rheumatology session. May I call upon Dr. Kingshuk Mondol to moderate the rheumatology session, and I request Dr. Partho Sarathi Sarkar and Dr. Vishnu to be there, and I request Dr. Amitabh Narayan Mukherjee to felicitate our chairpersons of the last session. May I request Professor A.K. Pal to be in the panel.
I start off. A bit while ago, I came across 10 golden rules an orthopedic surgeon could benefit his life with. And one was be happy with what you have. So this was what was given to me. I am happy with it because I hardly see rheumatic patients. I am very much thankful to Vishnu for helping me out, sending me cases. So the first case is the commonest case which we all see is this. A 4-year-old female working from 9 to 5, desk job, neck pain, sleep disturbance. So what is the diagnosis which comes to you first? Vishnu?
So it can be generally a muscular strain, neck pain because desk job 9 to 5.
Yeah.
So it can be a normal mechanical
pain.
Mechanical pain.
Yeah. And after giving analgesics, if it doesn't go down?
Then we have to further investigate through X-rays.
Further, anyone, sir?
Yes, definitely I am agreed with this. So this is maybe related with the workstation, the difficulties in walking in different workstation.
mainly the IT sector
There is a
people,
mechanical,
yes, they
but
come
if
to
it is a
you.
sleep disturbance,
Yes, sleep disturbance is
that
one
is
thing,
a clue
Yeah.
that it is beyond,
It's beyond
mechanical pain,
mechanical.
and then there is a possibility of associated with some pneumatology and also some neurological component.
Okay, fine. So this is what we saw in exam. Tenderness over both the trapezius, the neck movements was full and painless. X-rays were normal, blood reports normal. Now?
Now the most common cause
Is what?
there is a psychological component. That is this may be fibromyalgia
Absolutely.
kind of
So
situation.
this is the 90% of the patients, most of the females don't mind. They come to us with these vague problems and they all have this. No matter what you give them, they will never be happy. So diagnosis is fibromyalgia. So do you know what is Sperling's test? Sperling test is patient will complain of pain on the points. So you elicit that, you tell the patient, okay, where is the tenderness? So you see that point, you press it and she will give a jerk, feeling the pain, the same sensation. That can be anywhere. So that is Sperling test and that is diagnostic of fibromyalgia. Okay, so what is the treatment and what advices do you give, sir?
Yes, so in this case, just to rule out the first is the abnormal workstation. That is one. Second, these exercises. So that is initially we'll start with the static exercise basically. If there is for pain relief, there are several physiotherapeutic measures. If it fails, then there are special local pain that is pain portal block procedure we can adopt along with or without some intralesional steroid injection.
May I?
Dinesh want to say something. Dinesh, please.
So Sperling test is something different. It is checked for the impingement of the nerve from cervical spine.
Yes.
You'll have to bend the nerve sideways, then extend. There is
So
an
that is
impingement,
also
and
Sperling
that is
test.
the Sperling test. And for fibromyalgia, we see the trigger point. We will have to find out the trigger point where it is, and then we will have to go for that. So what is the criteria? How do you say that this patient has got fibromyalgia? Is there any criteria or any diagnostic point that makes you to think that this is a case of fibromyalgia?
Yes, I'm going to answer this. Basically, the fibromyalgia it is a diagnosis of exclusion. Okay, initially it was considered as a soft tissue rheumatism. Soft tissue rheumatism because sometimes it is waxing and waning of symptoms. There are several symptoms, or sometimes it is absolutely symptomless. But we have to rule out the neurological problem. Cervical spondylosis is cervical spondylosis symmetrical restriction of all movements of the cervical spine. If it is associated with radicular pain, so if there is associated neurological symptoms or not, Sperling sign is definitely there. But even in that fibromyalgia, that is sometimes associated with some radicular pain without signs, only the symptoms. And that is because of the weakness of these limb girdles. So there is some drooping of the upper limb and this weight that causes the dragging of these lower roots of the brachial plexus, and that causes this radicular pain. But there is no signs.
There is no sign.
There is no sign, and if I am not forgotten, my old memory says there are 10 places where you can have fibromyalgia, right from gut, lip.
This is yes, you can see these are all the trigger points.
Yeah, 10 points.
Yes. So these are the points which you can see again to test whether the patient is having tenderness over, and the patient can give a family history of such problems. That you can go ask the patient for job modification. You can even prescribe antipsychotics, and the patient may need psychotherapy in the long run.
One thing, another fibromyalgia which you come across nowadays in your practice, I have tried to correlate because I cannot say anything, get one, evidence for that. Especially ladies of 30 to 40, मेरे इस जगह को दबाव और ढिकार आता है. Have you come across this? पीठ में दबाव तो ढिकार आता है.
Yes.
Psychological, but they have a component of fibromyalgia also involved. So psychosomatic.
So how would you treat these patients? Does this work?
Yeah. Not steroid.
Yes, that is the first line of medical treatment. We can use that. So if it fails, then there is a local portal block procedure.
Pin portal.
So which one would you prefer, pregabalin, gabapentin, or duloxetine?
Yes, that is a very good, interesting questions.
Or a combination of them?
Yes, yes. So first of all, these are the what are the indication? Apart from the analgesics, indications in any pain which skeletal pain which persists more than 3 months, there is always some psychosocial component.
Yes.
We have to add
Then
this
you
sort
have to
of.
add antipsychotics.
This is either pregabalin. Now there is a comparative study shows that pregabalin and then gabapentin in both are potent, but pregabalin is more potent.
More potent than gabapentin.
So more potent than gabapentin. And then the most important clue and the tips is you have to use this drug with a very small dose, with a escalating dose, and you have to select the dose which is ideal for that particular patient, and you have to continue that drug till this complete remission. During this stoppage also, you have to make a very gradual lowering dose. This is a very, very important.
And what about the combination of
The
pregabalin
combination,
with-
that is pregabalin is a drug that reduces the pain perception.
Yes.
This is the mode of action. So there is a psychological component. So I think this would be the combined approach.
So
Only pregabalin
what
will
about
not act.
pregabalin with duloxetine? You can combine them?
Basically, if you use the single drug, after a certain period, it becomes adapted. So always combination. So
Always combination.
you have the pregabalin, not triptyline. There is ideal combination. Problem of duloxetine that alters the sleep cycle. So if you give in the night, there is a possibility of the sleep disturbance also. So if you add the duloxetine, there is a second line of drug separately and should be in the early part
morning.
of the day. Yes.
Morning, yes. So, fine. So this next case is a 56-year-old lady with multiple joint aches and pains and stiffness. And the left elbow is swollen with stiffness when she came to us. So this is the case which was given to my Vishnu. So this is the left elbow swollen and restricted movement. And the approach, blood reports, x-rays and treatment. This was the x-ray. So this is rheumatoid. So how would you go for the patient? Only analgesics, physiotherapy. The rheumatoid RF factor was 55.1, anti-CCP more than 500. The biopsy for Cox was negative. This was the USG.
In my practice, I'll start with the first line of drug, that is the methotrexate and also the folic acid, that is one. And along with this sort of CCP is more than 500. So in that case, that is another.
Strongly positive. Yeah.
Yes, strongly positive. So we have to add another, that is a sulfasalazine.
Do you combine all the drugs together or you just go for selective one or two drugs?
Methotrexate plus sulfa, this is my first choice.
First line is, as Anandu said,
Methotrexate.
methotrexate, hydroxychloroquine, salazopyrin, and methotrexate. This is the first line of treatment. As per protocol of the IORA and EULAR, this is the first line of treatment. You apply this. Along with this, you can add steroid on starting from 6 milligram. Not someone starts from 24, 30, but EULAR guideline says taper from 6 milligram to 1 milligram gradually as it starts. Then, if it doesn't work, then we have a lot of things, but this is the first line of treatment, what they said. And otherwise, other physical therapy and other things are always there.
Okay, so the DMRT was started and with NCQS, leflunomide, methotrexate, salazopyrin and steroids, and you can see the full movement in the elbow.
One point. The second drug, leflunomide, I have a personal inhibitions for that, because Dr. Reddy's once used to have a leflunomide and a case has been filed and a orthopedic surgeon has to pay a heavy penalty for writing leflunomide because it is written in the product that this is to be written by the rheumatologist.
Now I think, sir, that is gone.
That is wiped off?
Yes, yes.
Sorry, I don't know
Dr.
that.
S.S. Jha,
So
sir,
I have a
told us.
very scarce feeling about leflunomide.
No, this all the drugs are in combination. Okay, then you will escalate this drug, add one drug.
বল চিন্ময় কিছু বলবে চিন্ময় Yes, that cannot be. No, that cannot be. Very rightly said. People nowadays, unfortunately, people are using topacidine and this injection, what you call E, starts with E, like anything. But that should not be used. There should be, these drugs should be, these JAK inhibitors should be taken as the second or even the third line of choice. That should not be used rampant, which is now been used, sorry to say, even by the general physicians as a first line of choice. That should not be.
And what about biologics? Do you use it initially or you?
No, after this. That's third line or fourth line.
After, if the medicine fails, then only.
Then, please, fast.
So this is another case, 42-year-old male, habitual drinker, obese, history of gout, under treatment off and on, and they presented with acute flare-up of gouty arthritis. So how would you go? Treatment?
First line is the NSAIDs. That is the one. Second is the along with we have to add colchicine. There is a after 10 days we have to add the eucrosuric. Yes, febuxostate. If it doesn't remission occurs within 7 to 10 days, you can add some little bit steroid, but for short period of time.
Very short.
And how long should you continue with this treatment?
Which?
Allopurinol or febuxostate?
Allopurinol or colchicine, this is for 10 to 20 days, not more than that. Then you shift to any uric drugs like what you call febuxostate or Gyloric or whatever. But no homeopathy dose, full-blown dose.
Full-blown dose, but it should be ideally lifelong.
Lifelong. Shouldn't they kome galo bondo kore dao abar dao. Every attack of a gout kills 50,000 of your renal cells on your kidney.
Okay. So this is another last case. 46-year-old female with pain and swelling of her knees, RA factor 56, anti-CCP 150. You give DMRD steroids, you aspirate the joint, you give intra-articular steroid, intra-articular hyaluronic acid. How do you go with this?
Oh. Initially, we should start with the DMRDs, and steroid can be a short course steroid can be given because there is a acute inflammation, and then if the treatment fails, then we should go for this aspiration. If there is a collection is more,
Patient comes to you with this sort of knee. Will you aspirate or will you wait?
No, if it is a stretching pain, if this stretching pain causes pain, then we will definitely aspirate. Otherwise, we should not aspirate in the first instance.
Question to the house, how many of you aspirate this knee first?
Traumatic is the first case.
One, two. Aspirate and then inject.
I'll aspirate.
First aspirate everything and then inject. Inject steroid or hyaluronic acid both?
Steroid.
Ideally, what is now there's a study which shows there are three grades of effusion: mild, moderate, severe. So if it is a mild effusion, so we have to investigate. You can give some local compression bandage and everything. It will settle within 7 to 10 days. Then it's okay. It's moderate and moderate that will judge, but severe you have to aspirate, and at the same time you can give intra-articular steroid. Okay.
Thank you all. Yes, please.
Generally, these kinds of patients have diabetes. So then what is your say or what is your take? Do you really want to inject a steroid and such a flared up knee? So how much do you recommend injecting a steroid?
One shot of steroid in diabetes, whatever may be, as an anti-inflammatory is accepted. Swarnendu, what do you think?
Yes, it is a very good and interesting question. So,
yes, that has to be.
Cell count,
uric acid
protein,
crystals,
cell count, then cobweb formation, then everything. We'll have to check it out. After that, we'll decide whether we'll give steroid or not. There may be infection, there may be tuberculosis, there may be some sort of.
So that is why if it is a severe effusion, so in that case only you have to aspirate after workout. That is one. So now the dilemma is if in diabetes patient whether you can give intra-articular steroid or not. So now the consensus is in controlled diabetic you can give intra-articular steroid, but there are some steroids are already in the market which has a very low systemic absorption. So
Hexa.
Yes. So in that case you can use that.
Nothing we can hear from our president. Gigi kichu bolli na. Ha, ball, please.
Until and otherwise, we are extremely sure. I have never injected in my lifetime aspiration and steroid in one shot. That is out of the question.
Right, out of the
so
box.
I think this message should go loud and clear. So you have to have the diagnostic what Dr. Dinesh told. Otherwise, don't inject.
Full workout.
Full workout. And if it is a controlled diabetic, then you can give one shot of steroid because you know steroid is going to kill the cartilage.
Yes.
It is just for the pain relief.
Pain relief. My question to what Swarnendu said, that you can give steroid, but with full workup. You can give. And Kiran is there. Yes. Kiran.
So if you can show the picture, show the picture. If you look at the picture, there is less effusion and much more synovial inflammation because the suprapatellar pouch is full, but the parapatellar fossa is normal. So it's not common in a huge effusion. So in that case, there is a much more synovial inflammation, synovial thickening than the synovial effusion, I think.
Yes. Thank you. Thank you very much. Once more, before we leave, we request you all to join. Kiran is there, Anando is there in our Ayora spine in Sundarban, first and second. Please come and join and make ourselves strong in that. Thank you.
So, thank you very much for the panelists and moderator Dr. Kingshuk Mondol.
আরেকটা কথা বলে যাই, Midcon, don't forget, Midcon কত জানি?
13 July.
13 July, register yourself in Midcon too.
So, now for the sake of running for the time, we have to prepone the panel discussions one by one. First, next is a panel discussion for case-based discussion for the arthroscopy session by Dr. Shashinder, and the panelists will be Dr. Gigi Kaur, Dr. Swarnendu Samanto, Dr. Ananda Mondol, Dr. Biplab Dalui, and Dr. Shaman Desiri.
Hello, good evening, sirs. I'm a very small boy in front of your experience, so only I am allowed to ask you questions. You please don't ask me questions, okay? Okay, sir. So, so the first one is shoulder pain in adult. This gentleman, 55-year male, is a coach, volleyball coach. He came to me with pain in both the shoulders. The left side more than the right. But his range of motion is completely all right, but he always has nagging pain in his shoulder. And a lot of crepitus. That's his X-ray. I hope the X-ray is clear. And we have the MRI as well. Huge osteophytes, inferior osteophytes. Lot of wear and tear in the joint. And a bit of posterior subluxation as well. So, what would be your plan of treatment for this patient? Will it be conservative management or will it be surgical management? Gigi Kaur,
we have to think about the pain generator.
Yeah.
Pain is his main problem, not the stiffness, because he has got almost full of the full movement, and throughout of the range of movement, the pain is there.
Correct.
So pain generator probably is the inferior osteophyte and the inferior thinning out of the articular cartilage. Maybe we don't know actually. So in this case, I also maybe from the video I'm not sure about the shoulder drooping, and if there is a shoulder drooping and scapular dyskinesia, that has to be taken care of first. with the counseling, of course,
Yeah.
that it may require something more than that. But
Correct.
to start with, your scapular dyscharisia and your stooping posture, which will, actually crouch the subacromial space.
Yeah, he is a physical education teacher and a volleyball coach. So these guys are
that part
quite
I think you'll understand.
proactive about the rehabilitation and all that. He is quite active about it. Yes, a little bit of scapular dyskinesia over there. I don't think we can completely take it off because there is
No,
a
you cannot
pathology inside
completely
the
take it
shoulder.
off, but
yes.
yeah,
So
that
he
can
has
contribute to the
already
pain.
done a lot of physiotherapy. So he is not. He
No
has
response.
a problem.
No
He's
response.
not suffering from. I mean, he's not jumping with pain, but he has a problem. He wants to try
And
to get
how
rid
does
of
he sleep in the night? I'm
little
putting a
bit
question,
of,
sorry.
Correct. Very valid question. Very valid question. Yes, a little bit of disturbance is there, but his sleep doesn't go off because of this. But nagging pain there, he thinks he can be better.
Okay.
Certainly, sir. So, what will be your choice, surgical or non-surgical?
No. Surgery is the last option, probably because he has got full range of motion. Only thing is that if you see all the MRI pictures, the coronal, sagittal and the axial, there is lot of destruction, lot of osteophytes. Even the whole cartilage is gone on the glenoid side. It is a patchy destruction of the glenoid side. So, surface replacement, total replacement, reverse replacement is absolutely out of the list, first. Second thing is injection is also out of the list as because he have already lost the cartilage. So,
Why, sorry, sir. Why replacement is out of the picture?
I'm coming. I'm just coming. Because if you see the X-ray, you can see the big osteophyte. If you run this thing, this is the big osteophyte. This is a big osteophyte. Okay. So primarily, as because he has got good range of motion, I will counsel the patient for any replacement like surface or the total. Reverse is obviously out of question as because he is 50. So primarily you can go with the arthroscopy, you can clear some of the joint, then you can go for the physio and see what happens. But primarily I will not suggest the patient for any sort of replacement.
Thank you very much, sir. Anandamandal, sir, do you have any difference of opinion?
No, I will also try to conservative treatment first.
He has already tried a lot of conservative treatment. He is not happy. He thinks he can be slightly better.
From the MR, we can see that there is bicipital group effusion is there. We also try to do the during shoulder arthroscopy. We can try to do the tenodesis of the
Also, his
biceps.
problem is not primarily weakness or bicipital weakness.
Okay.
More of nagging pain, grating during his movements.
Okay.
Okay.
Then, if conservative treatment is lost, then we can do the total shoulder in this case.
Yes, that is a very valid treatment line. But considering his physical activity and his relatively young age, I went ahead with arthroscopy. The plan was to try and remove the osteophytes. What he already has a very good range of motion. He says a lot of crepitus is there. Maybe the pain is from crepitations and all that. But still, the cartilage is gone, so we cannot replace the cartilage. So, but still, with all the warning, I went ahead with an arthroscopy. Tried to. This is the arthroscopic picture. Absolutely no cartilage in most of the glenoid. The inferior part of the glenoid had a little bit of cartilage. Added a little bit of debridement. This is not everyday case, so we don't have a definitive plan for this particular patient other than arthroplasty, but this patient was not willing for arthroplasty and he was quite physically active. A lot of curating, removing calcific edges, debris, and then the little bit of curating on the humeral side. identified the inferior osteophyte on the femur, on the humerus, tried to remove most of it, and also the posterior osteophyte. There was a lot of osteophyte on the posterior side as well. Did micro drilling of the glenoid, micro drilling, a lot of micro drilling. I don't know. I'm not a person who is favorite of microfracture even in the knee, but I didn't have an option here. I did micro drilling, and then broke a micro drill and removed it as well, and then proceeded with bone marrow aspirate concentrate injection. Not very happy with the treatment, but this is something I tried after warning the patient. He is okay. I nerved them in a bit of abduction because if you see the X-ray, the superior part of the cartilage appears to be slightly better than the inferior part. So I wanted to offload wherever I did the micro drilling so that little bit of fibrous tissue will form. I don't know. Sorry. It works well in my computer, but it's turned here. Fortunately, he went on to recover well, also because of the motive that he has. He is a physical education teacher already. So fortunately for me, he went ahead to recover very well. He is around 4 years post-operatively. He has pain on the other shoulder now. He wants to undergo the same thing on the other side. I'm not saying that's the right treatment, but maybe this is helping. But I don't know what helped him. The motivation, the prehabilitation and rehabilitation, which he is very much warned about. Maybe CAM procedure is working, yes, but temporarily. We still can't say it will work long term, but that was not the aim at all. And maybe BMAC helped, we don't know. There is a bit of evidence, positive and negative, but it's always an area for controversy. Then we go on to a case of infection after ACL reconstruction. This is a patient operated by me in a hospital, in a peripheral hospital. The patient never turned up, and most of the time when we go and operate for another surgeon, we are not following up the patient. Suddenly, after 3 months, I'm being called, your case is infected and all that, and the screw is already coming out. So how would you manage this patient? Any role for conservative management here? Biplab sir.
I'll go for radical debridement, removal of all
Yes.
implants, including the graft,
Yes.
and do second stage revision.
Yes. So there's no role for conservative management here, absolutely surgical management, and there is no role for preservation surgery here. We need to be very radical. Any thoughts, Biplab sir, any thoughts about having to reconstruct the ACL later again for this patient? Will he need it?
Yeah, if he is symptomatic, then I'll go for revision later on.
Yeah. After how many months?
Maybe 3 months.
3 months.
Yeah.
3 months is good. Gigi Kar sir, do you think 3 months is sufficient after adequate antibiotic management?
Of late, I'm using the dowel of Vanco Genta impregnated calcium sulfate cement. It's like a dowel. Keep it there in the tibia. And after 3 months, yes, of course, the markers are also to help you. And patient's clinical symptoms are also to be taken into account. And then, of course, the counseling that, well, we may have to wait for a few months more unless the patient has, basically, these type of patients do not have their full range of activities, full range of sporting activities going on. So there is no urgent need for a replacement of the ACL at that point of time.
Yes,
so
correct.
you can delay.
Yes. And most of the time, these patients might not have an instability as well because of some fibrosis inside the joint that is possibly stabilizing the
And they
knee.
also cut down their level of activities.
Yes.
Even sporting
Agree.
activities.
Agree.
To that.
Unfortunately, this guy was.
Is there any protocol? I don't know. Is there any? Plus, you are talking about DIR kind of thing. Compared to arthroplasty, where we can have DIR modified DIR.
Yeah.
Okay, in this case, since we are taking out the graft, it is not an IR, that is retention of the prosthesis. Prosthesis retention versus graft taking out. Graft taking out easy. We are not taking out the prosthesis. So after you take out the graft, mostly the infection dries down, at least in a sizable number of cases. The offending thing, including your ethibonds, including your fiber tapes, everything to be taken out, then the infection dries down. The question remains that whether there will be continued instability for which you need a secondary revision at a cold time. That is the question, I think.
Yeah. And evidence says this could be the empirical IV antibiotics, but then these are empirical IV antibiotics. The antibiotics have to be directed based on the culture sensitivity, but most of the time there is staph aureus, so that's why these are the empirical.
He is asking that
how long?
Whatever antibiotic you are choosing, how long you are giving in IV mode or in oral mode?
Yeah, the guidelines says a minimum of 4 weeks, 3 to 4 weeks of IV mode, followed by around 3 weeks of.
That is the thing. At least 6 weeks coverage should be there. It is not like the joint PJI. It's not like your 6 weeks and aggressive therapy even with the IV. Protocol I follow is that I give IV for 2 weeks and 4 weeks oral medication. Whatever the sensitivity comes. Same like septic arthritis.
Septic arthritis or even acute osteomyelitis.
It is like septic arthritis.
Yes.
Otherwise, this will recur.
Correct.
That is the problem.
Correct.
Every time you just take out the thing, it doesn't mean that it will be quiet again.
Yes, because there is a lot of tissue there which can hold microbacteria and
Even if whatever synovium you are taken off by your naked eyes, you take off every synovium. Still, in the posterior part, some inaccessible part, you will leave there.
Yes,
it will be eaten up only by the antibiotics because you cannot make 100% synovectomy.
Correct. Okay, sir. So there is another patient. This is a 35-year female. I did the bundle preserving ACL reconstruction, maintained the posterolateral intact bundle, and did anteromedial reconstruction. She was on immunosuppressants for skin disease. She was absolutely fine. Post-operatively, around 1 month, she had a small furuncle near the surgical area. It appeared very, docile. Didn't appear to be a point of concern. But over time, she started showing up heat in the surgical area and a bit of swelling. There was no frank discharge through the scars, but this heat maintained. I did not give empirical antibiotics without any specific diagnosis. But then we went ahead with an MRI. MRI showed fluid along the ACL and around the small area of fluid around the screw, hybrid fixation button on the femur, bioscrew on the tibia. So, I'm sorry, I don't have the MRI images now. So, in this patient, any role for conservative management?
Yes, it can be tried for the conservative treatment, because if you see that intra-articular infection is not there, frank infection is not there, you can do just a washout in the joint, and you can do debridement, local debridement.
You mean you will do a joint preservative surgical management?
Yes,
right?
yes.
Meaning you will try to preserve the graft.
Preserve the graft.
But arthroscopically debride the joint.
Yes.
That's exactly what I did. But the patient came back after 3 weeks with persistence of the heat. No active discharge. Patient was absolutely never completely all right. So, I did the debridement alone, arthroscopic debridement alone.
Finding inside the joint.
Sorry. No. We did not remove the screw.
What was your
She was just 2 months post-operatively.
No, you told 8 months, no? 8 months.
So, see, this question I can put.
Yes, correct.
That what was your finding in clinic, arthroscopically? What was there inside?
Arthroscopically, actually, I did the arthroscopy first revision. ACL appeared to be very good.
And the
ACL was not damaged.
Anything
Also,
inside
I
the joint?
did the bundle preserving. So there was a native ACL bundle and reconstructed ACL bundle. It was looking very good.
And there was nothing inside the joint, no
inside
pus,
the joint
nothing in the
also
joint.
was looking good.
So there was no septic arthritis.
No septic
It's only
arthritis inside the joint.
Introduction site inflammation.
Yes. That was my fear as well. But unfortunately, I did not remove the screw. I'm not sure about the duration. 8 months may be wrong here, I'm sorry. She was quite early in the first revision stage, maybe around 2 months to 3 months. Okay, so then she returned again.
The problem is the screw. Problem is the screw. Because the screws, if this is he is on immunosuppressant, and also the screw can
inside
be it can be the source of the sterile discharge or whatever you find. Until otherwise we suppress this with some antibiotic, because if you tell it is like 2 months, then you cannot take out the screw. At least you have to keep the screw for 3 months.
Yes.
Just for the, at least for the integration at the surface fiber at the mouth of the tunnel. If
And
it is a tight,
that was my concern as well. So I did open up the surgical area on the tibial side and washed it a bit. I did not remove the screw, but that was a bad learning for me. She came again with a problem. So subsequently she was taken up for debridement of the whole ACL, and she was managed with stimulant antibiotic intraarticularly for later removal. This was the second revision was done by a friend because I was traveling out of the country, so it was done by a experienced friend. So then after that she became all right. Her ACL is not yet reconstructed, but she appears to be okay. I mean, this is a learning lesson. There was no right answers for the first revision. But if you go through the evidence, it also says in the early phase, you can go ahead with graft preserving debridement at least one time, and then go ahead with subsequent aggressive surgeries if the patient comes back. But the question of whether the screw can be removed or not, is a very difficult question to answer. Okay.
So unless you remove, actually you cannot judge the stability also.
Yes.
Maybe with the screw inside you can have the test and you are very satisfied.
The
moment you remove the screw, it becomes loose.
Yeah, then there is no going back. So this is a patient with massive rotator. Sorry, the patient detail is not here. This is a 65-year-old male with a massive rotator cuff tear, with proximal migration and lots of muscle atrophy, both supraspinatus and intraspinatus. Subscapularis is relatively fine. Very poor demands, no major demands. Village, old man, previously into farming, now does farming. Yes.
No, I think if you go back to the picture, I think there is some signal that somebody has reconstructed this cuff.
Correct.
It is a failed cuff, and with the it is. I think we can see the anchors there.
Correct.
And the thing is that it is the supra, infra, because there is only one cut. The subscap is looking okay. It is a massive cuff here, as a retracted pate 3 sort of thing. Okay.
Correct.
So it is, you cannot do something with the rotator cuff repair, re-repair is out of question. This is the only, what's the age of the patient?
He is 65.
65.
But he does, he uses
farming,
the
you told me, farming,
yes.
okay. So I think this is, in my if I think correctly, I will opt for the tendon transfer. Because if he is symptomatic, if he is compromised by his daily activities, because some people, even if some people fail like this, MRI picture looks like this, they are happy. They can do their daily activities, they don't agree for the surgery. So that is the problem.
He had a massive rotator cuff tear, absolutely not repairable. So we went ahead with the latissimus dorsi transfer like you suggested. At that time I was not doing trapezius transfer, so went ahead with the latissimus dorsi transfer, open, and attached, not the perfect way, but attached with a single anchor on the femoral head, and rehabilitated him over time. This is a few months after the surgery. he's quite happy with his shoulder. So not the right candidate for any kind of arthroplasty because he's a high demand person and who's also unlikely to follow compliance after arthroplasty. So choosing the right procedure definitely matters. Okay, this 15-year female, 6 months of pain in the joint. Anandamandal sir, any comments on the X-ray?
Yes, there is a cartilage loss on the medial condyle of the femur. It is a case of osteochondral defect on the medial condyle of the femur.
Okay, yes, you're absolutely right. The MRI also showed the same thing. Stage 4, stage 3, the fragment is still there, but it's completely separated.
How much old?
Sir, she is 15 years.
15 years.
15 years female.
How much old the injury is?
It's she doesn't have a specific history of. She's not able to say the specific duration of the injury. But symptom is for 6 months. Pain and swelling is for 6 months. So how would you want to go ahead? What kind of cartilage reconstruction would you advise? Biplab sir.
If I can fix it with biopin, then I'll try to fix it. Otherwise, I'll go for ORTS.
Any other cartilage reconstruction anyone else would prefer?
No, if we see these second line cuts, I think if we go with this scope, it will be looking like a fragmented detached. It may be looking 3, but actually it is 4. Well, in my perception, might be wrong. Because you see you see it is completely detached. If you go back the second picture in the second line from the left, then we will see the extent of the lesion properly. Yes, there. So it is loose, it is floating in the joint, it is completely detached, subchondral bone is exposed. So now it is 4.
Yes,
it is flipped. It is flipped. So you have to, and now you have to, once you go or if you see the cut and talk to your radiology guy, go to the console, you can measure the size of that defect.
Yep.
If it falls in the category of 2 centimeter, then you can go with the ORTS. If it is more than 2 to 4, then you have to think something else.
Okay. Do you think this fragment can be put back into place and?
No. This is beyond doubt. You cannot put that fragment in even with the biopin.
Okay. So there was a flap of osteochondral fragment there. I went in with a small after arthroscopy. I went in with a small open procedure. The fragment was around there. Proceeded with ORTS. I could manage with single cylinder of ORTS because the rest of the area was a bit more shallow. 10 millimeter area was quite deep, so I did only single cylinder of ORTS. And then it was quite close to the notch, so it was something like an uncontained lesion. So I took the donor area from relatively edge of the trochlea, similar to shoulder regions, in order to match this. And I had an oblique surface in the cylinder, so in order to match the geography of the receptor area as well. So this is 3 weeks post-op. 3 weeks, she's quite happy. Pain is gone. She's still under rehabilitation, but she appears to be in the right track. Okay. So I think I will stop here for want of time. Thank you very much, sir.
Thank you, Sashi. So let us proceed with the case discussion. Case discussion on spine, and the moderator will be Dr. Anindo Basu, and the panelists will be Dr. Kiran Mukhopadhyay, Dr. Dinesh Jaiswal, myself, and Sushmit Noshkar is not there. So Anindo, please take over, and you will get only 10 minutes because we have to finish it early.
Good afternoon, everyone. Spine হলো অর্থোপেডিক্সের সৎ ছেলে, শেষের দিকে সময় পায় 10 মিনিট। ঠিক আছে, 10 মিনিটে শেষ করব। No problem. So the first case, 46-year-old female had a fall while walking on the street on a rainy day, unable to stand or walk due to back pain. The patient can turn side to side on bed, and on clinical examination, no gap felt on midline palpation, and the patient is neurologically intact. And with this presentation, and this is the CT scan that we get. Can we have your comments, please, on the CT scans?
So it's a compression fracture, a bus fracture. I want to have an MRI to see the status of the PLC, posterior ligamental complex.
Right.
So if it's intact, then okay.
This is your MRI, sir.
So PLC, I think it's okay.
Yeah. PLC is intact grossly, and there is this compression fracture, no doubt. And any other investigations, the patient can turn on side to side in bed. What would you do with this patient? Any other investigations you like in this patient?
So how many days old she is?
She has come to us acutely after trauma. She had a fall, had severe back pain, came to the emergency and got admitted.
Immediately?
Immediately, yes.
So in such cases, we look for another parameters, whether I have to, the question is whether we have to operate or not.
Whether we can mobilize a patient with a belt, without a belt, or whether we need surgery, or whether we need to give the patient any word of caution that you can do this, that. What are we going to do? That is the question.
So, so first thing we have to see whether it's stable or not. So that's the
First
most
criteria.
important thing. So this is this height of the vertebral body seems to be almost 50% lost. Number one, and another thing in such cases, so we need a weight bearing and non-weight bearing lateral X-ray of this fracture vertebra.
So yeah, this is very like I like to perform a weight bearing X-ray, and so this is the one on the left is your supine X-ray, and the one on the right is your standing X-ray. Yeah. So, but the patient, this patient, we were able to mobilize with a corset, able to stand, walk with pain. So, clinically, grossly stable. I mean, it's a borderline case between stable and unstable.
This is potentially unstable.
Potentially unstable.
This is an unstable case, and there is no role of mobilizing with a corset. If you
even a corset is I mean, you can if it is
no
an
role of
unstable,
corset.
yeah, no role of
if
corset.
the patient is if the patient is stable, the fracture is stable, and if the pain is relieved, then you can mobilize it. But in this case, it looks like the fracture is not stable; it is borderline unstable. So to be on the safer side, and discussion with the patient that you may get late onset neurodeficit or late onset kyphosis. So if the patient opts for a surgery, then I'll do a minimal invasive fixation.
Right. So this is like potentially unstable because you say because the standing X-ray you see more significant collapse of the vertebral body. So yes, I mean Dinesh sir, what would you do with this patient?
I'll give a chance to the patient. This is potentially unstable, but we can do other things. So this is 46, female.
Yeah.
So near about menopause, whether DEXA is normal or not.
Yeah, DEXA was normal in this patient. Yeah.
So then we can, I think we can give a brace and wait for a few days, and the patient feels discomfort.
So what would be, if you treat conservatively this patient, how frequently will you follow up this patient, and would you do another weight bearing extra follow up or?
Yeah. So I'll have to look for the whether stability it is going to more unstable or not. That is a X-ray without brace in standing posture lateral view. That is important. Subsequent every 3 weeks, like so. If there is no improvement in the stability or there is no union and there is progressive kyphosis, then we'll have to go for the.
So with this, you can you will see another time if there is further progression of kyphosis, then you will offer surgery. Yeah, fair enough. I mean, both the things. So what I did was like had a discussion with the patient and had both these discussions, like whether like the patient I can go for upfront surgery and you'll be mobile the next day. And second option is, yes, you will be mobile, but we need to have a close follow-up. And if you worsen clinically or radiologically or neurologically, then we need to intervene immediately. So that is the discussion that I had with the patient. And so I did a minimally invasive fixation, and we could mobilize the patient the next day. And this is only a fixation, so I have taken out the implants after one year, so that we preserve the mobility of the spine. Basically, this was splinting the spine for the bone to heal. Any comments? Would you have gone on shorter fixation or longer fixation? Do you think it is adequate or overkill or?
Do you have axial view of the fractured bone? Whether a pedicle
initial?
Yeah.
No, I don't have the
Excel,
X-ray,
you don't.
unfortunately, no.
Okay, if
So,
we can hold a screw, half screw, in the fractured.
so index screw, you mean? Yeah, index screw. Yeah, index screw is
Index
also
to
an option.
fractured vertebra's pedicle is in the APP. It looks like intact. So you can
Have an index screw in the
index
body.
can
Yeah.
have an index screw over there. Or otherwise, if you open it and can reconstruct the anterior column, then you can get away with 4 screws. Otherwise, whatever you did was a minimal invasive fixation. So this is the right thing you did.
Yeah. So my philosophy of not putting in an index screw in this case is I just wanted the bone to splint. An index screw is a screw in the fractured bone, and it will interfere in bony healing. So that is why I did not put an index screw.
I'm very reserved about putting index screws.
Yeah.
It creates a lot of problems.
Sir, yes, sir.
Okay.
Short segment.
As already you have told that in the BMD you have done, there is no osteoporosis. Yeah. Okay.
So short segment is in a dorsolumbar junction. The
Yes,
stresses are very, very high. And short segment I have done, but a couple of my cases have failed with fatty ladies, with mobilization, with high BMI. I'm very skeptical of doing short segment fixation in the dorsolumbar junction. And in this case, I have removed the implants after 1 year. So this is only, I did not fuse. It's only a splintage for the bone to heal. That's it.
And what about the vertebral body reconstruction? So that could have helped it not.
Yes, basically the canal was not compromised. The patient was neurologically intact. So, and the height restoration on positioning was more than 50%. So I accepted it. Any other comments? Yeah. Move on to the next case.
Yes, you should.
How old is X-ray? Post-operative, just
This is post-operatively, immediate post-operative. So the second case, 70-year-old male patient with trivial trauma at home, very common scenario, unable to stand and walk due to pain. So 70-year-old goes to toilet, has a fall, no neuro deficit, but severe back pain, unable to stand and walk. And comes to us with this X-ray, and the DEXA scan is minus 3.2. So it is a osteoporotic fracture of the dorsolumbar junction and with severe pain. This is the MRI. Any comments?
So there is a cord compromise, maybe some amount of edema also there, though there is no neuro deficit. But this is a junctional area and L1. So I will go for fixation. I will go for fixation.
So for fixation, would you do a open, minimally invasive, fusion, non-fusion, any DEXA scan minus 3.2? What implants will you use?
Long segment, so augmented screw.
Augmented screws.
If possible, also anterior body augmentation of the L1, the fracture vertebra.
Right. So any role for trying conservative treatment, and any role for giving prolonged bed rest in these patients?
Prolonged bed rest is not advocated in these elderly people because I think there was a session today morning, sarcopenia. So if we keep him bedridden for 3 weeks, so there will be severe sarcopenia. So he will not be able to walk.
Again. So I get a lot of patients who come with elderly patients with osteoporotic spinal fractures who have been advised prolonged bed rest, and it is very difficult to again de-advise again and motivate for surgery in these scenarios. So yeah, I mean, does everybody agree that prolonged bed rest, anybody would keep in prolonged bed rest in these patients? Yeah. So
What conservative? What conservative? What form of conservative? What form of conservative treatment do you recommend?
Bed rest, out of bed as soon as pain pervades, paraspinal strengthening, bracing, correction of osteoporosis, so on and so forth.
So there are two components. So there are two components. One is osteoporosis that we will have to take care of. That's a different and totally important, very important issue. That is a different issue. But for the fracture, it's very unstable, looks like. And I think you'll have to ambulate the patient as early as possible, old patient.
So to be honest, in this patient, we tried for 5 days of hospital admission, we tried to mobilize the patient out of bed with a lot of analgesics, even with a brace, but the pain was such that we could not.
But first 5 days is too early, no?
Did you have any CT scan of this patient?
No, CT scan we did not have, but we could not get a weight-bearing X-ray, but because the patient was not able to stand. So I would have liked to have a weight-bearing X-ray that we did the other day.
Here, MRI, because the edema, everything, there may not be spinal compression, you can see the neurodeficit. It exaggerates that whatever the things. So MRI should not be the criteria for fixation. If you look at the X-ray,
MRI is not criteria for fixation.
all right, okay.
MRI
So
is not
if you see the X-ray, and then you can think at this age conservative management can be given trial, particularly if the
but
patient
this
comes to them.
osteoporotic compression fracture and osteoporotic burst fracture are two different things. Osteoporotic compression fracture, you can continue with conservative management, but osteoporotic burst
This is a burst fracture,
in the
actually.
lumbar region is it's unstable, and it will progress and it will cause neural deficit, and at this junction there will be blood available involvement if the kyphosis progresses, and that will be very difficult to treat. So osteoporotic burst fracture is something different. Osteoporotic compression fracture is something different.
This
So
is the
pure
burst
osteoporotic
fracture.
burst
Fracture, yeah.
So I think, to my opinion, is I should not conjure. I should go for operation.
Go for operation. Yeah, I mean, same thing, but it's very difficult at times with elderly people. As sir said, that conservative treatment can be tried. I did give it a try. But yeah, I mean, possibly because this was a burst fracture and the amount of, this was too high, so we couldn't get this thing out of, the patient out of bed with analgesics. So again, this is a minimal invasive cement augmented screws. So, and also anterior column augmentation with bone cement. So, what is your cutoff value of DEXA scan for a cement augmented screws, or what is your take on cement augmented screws? When do you go for it?
If it's more than minus 2.5, some say it should be minus 3.
Yeah.
But if it's osteoporotic, then
Better to go for cement augmented.
My cutoff point is 3, minus 3.
Minus 3.
Minus 3.
whatever you do, you have to treat osteoporosis.
Yeah.
So, doing the cement augmentation of L1 vertebra, did you use balloon or you just
No, just put in cement. Sometimes I do use balloon if the patient's money
because in this case, if you do not have any CT scan, then there is always chance of posterior leak. So I prefer either I prefer balloon, or if it is not available, I have this reamer. So kyphoplasty reamer. So I ream on top of the guide wire and create some space and put the bone cement through the sheath. So that will be doughy cement, and chance of leakage is much less than classical vertebroplasty.
Yes, I mean you can try all these things, bone this stenting, vertebral body stenting, ballooning, and everything.
Now, if there is a fracture in the posterior wall, in that case I use bone graft with artificial bone graft mixed. So that's a better, another good alternative option, because you have a long segment fixation, so you will have some time for that bone graft to be assimilated. So this mixture that will be in the anterior body, and if there will be no chance of leakage, then there will be no chance of injury to the cord.
Have you done decompression also?
No, only this was the intraoperative picture. No decompression. No neurodeficit.
No, not that was this kind.
Otherwise, what was the indication for surgery?
Pain.
It's an unstable fracture.
How do you establish it? I mean,
pain is there.
you don't have any. Pain is not the definition of instability. The interspinous ligaments look okay on the MRI.
What may be the other cause of the pain in
I mean,
this patient?
some dynamic film, sitting lateral, supine lateral, something like that.
No, basically the idea is, I mean, ideally, as I said, a film, a weight-bearing film would have been ideal. But this patient cannot stand, so how can you make
Within 5 days, you cannot take a decision that he cannot stand.
That was the question, like how
What
long do you
was the
want to
need
continue
to hurry
with
when
your-
there is no neurodeficit? 5 days you are taking this decision.
So that is
and you have not decompressed, and the whole, I mean, the first thing
No,
that
first
we
of all,
saw is that, well, it looks like there is a cord compression, and then you don't do decompression.
No, decompression is not needed in these cases. So the canal will undergo remodeling.
Then only stabilization was your
Absolutely,
indication.
absolutely.
Right?
So get the patient out of bed, prevent
for-
sarcopenia, mobilize early, and treat osteoporosis. Prevent further worsening of osteoporosis. That is the idea. Early mobilization.
And prevent further collapse.
Yeah, absolutely. Yeah, yeah. That is the idea. So yeah, I mean, I'm not saying that every collapsed body needs to be fixed, but this is a, as sir said, this is a basically a osteoporotic burst fracture, and with clinical instability, patient cannot bear weight. So if you see the first patient that I presented, it was basically the patient could turn on bed, and the patient could stand up. So that is again a potentially unstable fracture, which showed further collapse on weight-bearing X-ray. That's why we fixed. And this is another case where the patient cannot stand or bear weight.
That patient was young patient. So
Yeah. So again, another case, but let's see. This is another case. A patient with 21-year-old patient with lot of instability, with back pain, spastic paraparesis for 2 months, and with long segment epidural abscess. So how would you deal with this long segment epidural abscess? Do you go for a direct fixation or? So possibly we'll move ahead with this case, like too complex for discussion.
So you have
maybe.
to, yeah, this is.
So let's move on to this case due to paucity of time. So 63-year-old male with leg pain and thigh pain, paresthesia, difficulty in standing and walking for 7 days, back pain for 5 months, which worsened over the last three weeks, bowel bladder normal, but hip flexor and quadriceps weakness is there, and paresthesia over the L2 L3 dermatome. And this is so basically a man unable to walk with radicular pain and paresthesias, intact bowel bladder sensation, and this is the MRI.
So there is in the T1, it is T1, considering the T1 and T2 images, there is compression in the 5, 4, 3, 2, 3 behind the variable body, of 2 and up to the 3, and there is edema.
This is radiologically a hemangioma of the spine.
Looks like a yeah, it may be a hemangioma. Hi. Yeah. This may be a case of hemangioma, but it is a it is a rare variety causing the neurodeficit. So it is symptomatic with neurodeficit. So you have to go in and.
So like hemangioma, as we know, is vascular. So any role of any preoperative biopsy? Would anyone biopsy this?
Yeah.
Because somebody was asking, sir, should we do a biopsy or not? So should we do a preoperative biopsy?
It's very dangerous to do a hemangioma like this, extradural hemangioma to do biopsy.
So only if there is suspicion of any EBC, where there will be fluid level, that's separate issue. Otherwise, no need of for hemangioma the biopsy.
Any role of angio?
Yeah.
And pre-op embolization or something like that?
Absolutely.
Angio and if we plan, then
embolization.
Yeah.
Pre-op embolization has a dubious role. Many a times, if the radiologist is not very competent enough, then first thing, it doesn't work. Second thing is, I had a case in which after embolization there were paralysis. Yeah, worsening of the neurodeficit.
So possibly the glue went into the anterior spinal artery or something. Yeah. So yeah, I mean embolization. So
it depends solely on the ability of the neuroradiologist to do that.
Many a times embolization is a costly procedure, and many a times you find patients who are not able to pay for it. So any other option?
That is another aspect.
No,
but the clinical aspect is most of the times it does not work.
Yeah. No, but
if the radiologist is not very expert.
If you don't have a radiologist who is performing embolization, any other techniques you use for these patients, or like how do you reduce blood loss during surgery? So for paucity of time, we'll go in. We had a DSN embolization of this patient. You can see the blush in the left-sided image. and on the right side the blush was completely lost after embolization. And basically what embolization does is absolutely shrinks down the tumor and does half your job. And you can go in, do a decompression only, and fix the spine, and basically with time the tumor shrinks and disappears. So this is what the canal looks like after decompression. And basically it's a separation surgery that we do to separate the spinal cord from all sides from the tumor after embolization. And you can see that the good spinal diameter is. So basically for me, if patient cannot afford embolization, what I do is I do vertebroplasty with bone cement, and also I do an ethanol embolization with alcohol, absolute alcohol. We have a series of 14 cases we did ethanol embolization, and it is very, very cheap, absolute alcohol only. Only thing is you have to get it from somewhere, and it gives good result.
How did you get this ethanol?
Ethanol gets from Calcutta National Medical College pharmacy.
Okay.
So this is ethanol gets from Calcutta National Medical College pharmacy.
Okay.
So this was the histopathology, and this
thank
brings
you
us to the end of the presentation. Yeah.
Thank you very much, Anindo. Medal to Shivli, Dr. Shivli. And may I request Dr. Amio Bera to hand over the memento to the chairpersons, panelists. Next will be the case-based discussion on trauma by Dr. Swanendu Samanto. May I request Dr. Swanendu Samanto to come on dais and take the charge. And the panelists would be Professor A.K. Pal, Dr. Satish Mutha, Dr. Shovik, and Dr. Kostov.
I think we are running short of time. We are not going to discuss many cases. Just we'll take the gist of the thing. I think এইখানে একটা স্লাইড শটার ভিউ করা যাবে নাকি ডাইরেক্টলি করতে থাকবো? ঠিক আছে, যেটা করো কিছু একটা দাও। I think we are skipping through because we are very little time. So as because it was not been printed what to be discussed, I just took on some arbit cases. So the horrendous part of the trauma surgery is the infection. So better to suppose this case, Professor Pal is a child, and with this much of infection, how you are going to manage this?
So what is the clinical scenario? A little bit.
No, you see this much of bone loss, the post-traumatic. This was a compound injury, and you see the nothing was left on this thing. Too much of.
So you have to do thorough debridement. There's a maintaining the length, the alignment, and also with the help of local antibiotic and with or without negative wound pressure therapy. And it should be a stage surgery. So
obviously, you have to counsel.
The response, we'll go the next step.
Your opinions, you have to counsel the patient, obviously, because we don't know the soft tissue. I don't have the picture.
It's going to
obviously,
a long process.
A long process. The
sequestrectomy, maybe fixator, and subsequently managing the defect.
Yes. Also, we have to include the plastic surgeons.
Yeah, we have to see the skin condition also.
Skin condition, soft tissue, muscle, and everything. Yes. Yes. Yeah. So I think the most dreaded part of the traumas, any orthopedic surgery, we are frightened of any infections because we discussed in length in the arthroscopy session too. You see another one patient like this. Okay. So this was referred to, and you see it was doubly plated, probably first surgery failed. Then this patient came to me, I think in the year 21. You see now the condition. It was discharging. The elbow motion was hardly range from, it is 90 to 70, 70 to 90, 2-3 sinuses. Now how you are going to manage?
So I think, sir, we have to do a thorough laboratory checkup, see the
Yeah, you
infected
do
parameters.
all the parameters because it is a
And,
chronic infection.
yes,
Okay.
and the first thing has to be the hardwares have to come out. We have to remove the implants, and we have to do a thorough debridement. Maybe keep a cement spacer in between, allow for the infection to settle down, and may do a stage reconstruction later on.
No, even if you suppose you take out the implants, you do the thorough debridement, take out all the necrotic material, and you take obviously you save off the some part of the necrotic bone at the ends of the fracture.
Yes, sir.
You will put the cement spacer along with probably the beads.
Yes.
Your opinion?
Yes, sir. My plan would be like almost same. I would remove all the implants and opt for thorough debridement. And I would assess the condition of the soft tissues. And my plan would be to put towards muscular technique. I would put a spacer and I would do some kind of stabilization.
Yes.
Maybe
How that? Because unless you stabilize, your nothing is going to work.
Exactly, sir. Yeah, right, sir.
How you are going to stabilize, Professor Paul? Muscule, cement bead, whatever you do, debridement, it is there.
Yes, if it is infected, potentially infected.
No, it is gross. I told you, 3 sinuses are there.
So it's thorough. That is along with that, skeletal stabilization by the elbow spanning external fixator. So that is the first stage. If it the complete the absence of infection is everything is what is going off, then it is a reconstruction with the help of the bone graft. That is the fibular graft or the without iliac crest bone graft, and there's a dual fixation. There is the internal fixation along with the external fixation. Internal fixation by the nails through these condyles. The condyles are intact, and external fixation is the long plate.
And basically, you want to put 2 tens inside.
Tens or any the
retrograde humerus nail.
No. The intermedullary nails, the other elastic nails, or by the any new nails are.
So basically, nail and plate.
Yes, nail and plate.
Achha, anybody suppose the mic for my learning, I am asking the question to sir. Suppose you do, how you can plan for a external fixator, which is going to be the elbow spanning. Suppose you put some 2 screws in the 2 pins in the your olecranon, and 2 pins in the proximal part of this fragment, how the fracture is going to be stabilized?
You mean a temporary fixator?
Obviously, you suppose just like the tibia, we are putting some fixator.
There will be no need to span the elbow. There is a significant big distal fragment you have. So you can
you will put the screws to sandspin in the distal fragment.
To proximal. In fact, if once I remove the implant and do thorough debridement, I might even leave it without an implant. Without a fixator.
I may answer your question. I had to put it sub cases. So 2 pins above, 1 pin in the olecranon, 1 pin here. Okay. So connect this and that too.
No, I mean,
okay.
What Professor Pal is telling, that he is giving 2 pins in the proximal fragment and 2 pins obviously in the, you have to span in the olecranon in the ulna. Obviously, we are putting the pins in the ulna, not in the radius. Anyhow, you just put something just to stabilize, but it is not very stable situation.
Right.
Because it is 20-degree motion is there, already the elbow is stiff.
But that's preferable because I want to avoid any pin in the distal part of the because I am to extend the plate after the distal proportion. So that's why I don't want any pin track infection anymore. So that will be better than this one. Okay.
So we'll plan for a elbow frame. 2 pin above, as Ananda said, 2 pins in the olecranon and 2 pins in the middle of the ulna, and you'll have to fix the frame triangular side by side also, so that the elbow is fixed and is in the stable position in a 90-degree flexion.
No, obviously, whenever you do the elbow spanning fixator, you have to make it modular so that the elbow doesn't move. The problem is that once you take out the plate and once you take out some part of the necrotic bone, the fracture segment it become unstable. That is the problem. There will be lot of motion even with your. Okay. So the concern is that if you see the osteolysis around the screws, then if you put some pins over there, you will be already apprehending that my pin might be doing something wrong when I put the final implant. Is there anybody who is in support? Suppose I take out this implant, can Elizaro be an option?
Elizarov can be an option, sir.
So you will remove the plate?
We'll remove the plate, we remove the dead bone amount which looks intraoperatively, and then we can put distal humerus 2 pins, K-wires, that are around 5 to 10 degrees angle, and then proximal we have good hold of shank spin. We can do the
No, that I am not asking about the construct.
We can do it.
Construct, we know that how to do the Elizarov in the humerus, because you have to give at least 3 pins in the condylar region. It's not 2, it's 3. Then you can construct according to your pin, and this is the hybrid one. Okay.
Yeah.
So I think Elizarov is an option. So you see, this is another one infected non-union with loose implant. It was also draining. So I think what Arindamda told in the morning, that for last 20 years of his journey, because I passed in 1993, so it is more or less more than 30, it is nearly 32 years. So that time also we never thought what to do, because that time it was a stage surgery, take out the implant, put the X-Fix. Even the antibiotic bone cement, it was not been in the concept. Only some streptomycin powder we used to put. I think everybody, I think Arindamda তুমিও তো নিশ্চিত streptomycin powder দিয়েছো। কোনদিন খাতায় লেখা হতো না, ওটা গান্ধী খাতা বলে। Otherwise কারে শুনতে না পেলে মুশকিল। সুতরাং কতটা, if there was no dosage of the streptomycin, you put whatever you feel like. হ্যাঁ, সেটা মুশকিল। So this is also now in this, suppose in 2025, you get this picture with the patient with the 2 draining sinus, it is loose implant. What is your first choice of how you will manage this?
Sir, first of all, I would always assess the soft tissue condition. And my approach would be, I would always, it is basically, it involves multifaceted approach and multidisciplinary team. So I would always seek opinion of the plastic surgery team. So in this case, like the previous one also, I would do the thorough debridement and implant removal and excise the sequestrum and everything, and put cement spacer, antibiotic spacer, followed by fixation. So now, depending on the soft tissue condition, maybe and the plastic surgery opinion, I can go for a locking plate. Fix internal fixator with the along with the muscular technique.
Oh, that means in the primary setting, you are once you remove this plate, with the plastic surgery, you are debridement day 1.
Yeah.
Then in day 1, your fixation inside is the day on the day of debridement. You are putting the blocking plate at internal fixator.
Internal fixator.
Then you are putting your cement as the muscular technique, or it is not the classic one in between. If it is in between the fragments, obviously it is a sort of muscular. Then at what point of time you are going to revise it, or you graft it, or what is the ultimate fixation mode? Because somehow you have to unite the bone. You take out the cement after 6 weeks.
Yeah, exactly, sir. So after 6 weeks, after the recommended, the concept is like after 6 weeks, once the membrane forms, then we can proceed for the bone grafting after satisfactory infection control.
Is anybody in the hall, like I think Arindamda, Jaronek Senior, Omyoda?
I object to these things in the same sitting plating. In this case, at least internal fixator, because with this kind of segment of involvement, infected segment, how can I exclude that I can be sure that there is no infection? So
I think this is a very, very valid point, because you see too much of infected tissue, which in the naked eye, probably you find that I have made a surgical wound, but it is not possible.
It's not possible.
It is not possible. It is impossible microscopically.
Okay.
Correct.
So I think
remove the plate, do the debridement, clean it all out, put some cement
cement beads or spacer,
and follow it for a while, and then CRP, I don't know if it's going to be helpful because post-operative CRP is very unreliable, so you won't get anything. But at least you need to get the clinical features to settle down and then revisit it after a few weeks. You can't wait very long also because it's upper limb.
So here again, will you put a fixator or no?
No,
Internal fixator, not in
No,
stage
not
1.
internal, external fixator.
So, I think
somehow we have to stabilize the bone part.
So, you have space below.
So by not putting pins in the distal fragment, you are not going to stabilize anyway.
Yes.
Your elbow is stiff. The same job will be done by a humerus slab or a U slab or anything. Why do you need a fixator in that?
Yeah, so that's
just
that's,
let the
that's what I
tissues
was.
in.
So what I wanted to say, the stabilization. There are two ways you can do it. One is put the X-fix as you know above and below, or there are these orthosis which you can apply, which are pretty good and which can be applied and
So that
maybe
means
because
that-
you are going to revisit it in a few weeks. The upper limb you cannot leave, like it's not femur, so it's not that you're revisiting after 3 months. You will have to go in there in.
No, even for the femur.
Sir, what to my mind, you have established very well. Any kind of movement is going to flare up the infection. So why we are shy and shaky about putting the X-fix instead of plaster or all these things? We can take it out. Even then, so that there is large segment rate, so you can put a bone cement mantle so that the end-to-end some contact is there, there will be less toggle, and you can also put some stimulant for the soft tissue part also, so that can be combined. Okay, that gives.
So I mean, as I said, X-fix is an option, but certain situations, these patients often come. This type of problem you'll see in the low economic status patients usually.
No,
that's the type of surgery you can. By seeing this, you can see this has been done in some center, which maybe not an advanced center.
Probably, I think
So you may not be able to do two surgeries.
We don't support this plating anyway in 2025. You cannot put this plate inside anywhere. I think anybody in the hall is not going to put this plate inside for the humerus. That is another one technique. That is another one technique that is mainly described for the tibia. That is the locking plate used as the external fixator. But there is no harm in putting the classic external fixator, because if the why to spend so much of money and why to spend this much of big holes, so many holes in the humerus, it already been loose. To me, yes.
One more point is, okay, it is infected, but do you accept the day one failure because it doesn't follow the principles of?
No, that we have already discussed.
Yeah.
It is a day one surgical error.
Okay.
Infection is added to it.
Exactly.
I think infection is the second part.
Yeah. So
even with this screw and plate, this humerus is not going to ignite.
So because the
this
principles
is
have
a
been
big
breached here.
that's why I told Arindam joined in this, because this is never the principle of fixing the humerus. The principle of the fixation of the was wrong, and I think the proper sterilization was not been maintained during the surgery. That might have caused that. But this place is a big no. This is not the fixation technique for the humerus at
And
all.
regarding the pins, there's no place distally if you can put the pins X-fix we were discussing. So could be difficult again, because if you want to put X-fix, again there might be chances of infection, because
Yes.
distally it's not a big segment where you can put
The
an
same
X-fix.
thing. Suppose you forget this is the humerus. Just you consider this is plating done for the tibia. What you have done? You are definitely not putting the pin in the tibia where you have already been taken out some soft tissue. The pin, the screw tract already been loose and lax. It has been infected. You have scraped out with your curate, but you don't know how much the intermedullary extension. Even you can do the intermedullary reaming with the flexi reamer, whatever you do. But in the tibia, the thing is that you have the advantage of putting one antibiotic rod in the middle. But the humerus, it is difficult to put something intramedullary. That is the difficulty. Agreed? So I think I'm not going to discuss too many things, just to have some idea that the humerus infected non-union is a big challenge. It's not like the femur, not like the tibia. Because here you can nowadays we are having the antibiotic loaded sterilized nail, which is available also in Kolkata, that we can use in the tibia, in the femur, in the first go. So it is not very costly even. It is hardly 28,000. So if you can make yourself, or else you can do the antibiotic with a locking thing. Then after 6 weeks, 8 weeks, you re-ream and put a big nail. and graft and plate, whatever augmentation plate, whatever is the fracture will dictate you whether you put the augmentation plate. Okay. All agreed on that? I think in this hall probably lot many surgeons have not been very fancy about the Ilizarov. Nobody is mentioning for the Ilizarov. I think I've been হ্যাঁ সেটাই তো তোমাকে বলছি এখনই না না তুমি তো দাঁড়িয়ে তো বলতে হবে তা না তুমি না দাঁড়ালে বুঝবো কী করে মনের ভেতর তো ঢুকতে পারছি না আই ক্যানট এন্টার ইন টু ইউর হার্ট সো দ্যাট ইউ ওয়ান্ট টু স্পিক সামথিং আই এম ফোর্সিং ইউ টু দ্যাট সামবডি না 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 ইলিজারভ তো আমি জিজ্ঞেস করলে ওই যে তো হিন্ট দিলাম যে ইজ এনিবডি ইন ফেভার অফ ইলিজারভ অ্যাট অল এভরিবডি আই থিঙ্ক ইলিজারভ it is the ideal case of Ilizarov. Oh, that means you are talking about the one group is Ilizarov. You can also use the LRS system for the compression of the fracture. You take out the necrotic bone, necrotic tissue, put some antibiotic, and day one you put the LRS as your final fixation. Okay.
But for LRS is problem is there is already pin track, there are screw holes are there, right? Okay, so the hold is not good here. Okay, so that's why compared to Ilizarov or Ilizarov with the 360-degree control, that is much better biomechanically than these things. And when the fragment is shorter, in this case, definitely that will be better if the expertise is available there. When that is not there, of course, LRS can do it.
Problem with the Ilizarov in the humerus is your expertise. Problem in the but the thing is that the how to construct it is not as easy like tibia. Even the femur is difficult. Nowadays, femur has been done easily
with the LRS.
With the LRS and also the hybrid, the Caterni frame and all this. So we can do the Ilizarov in the femur is much easily what we did in 1993-92. So I think Ilizarov is an option, LRS might be an option probably, but problem is that if you put the pins in the infected area, always your fingers are crossed, that probably the LRS pins might be loose. So either of the way you have to take out the implant, thorough debridement, or else you fix as you have told, like the locking plate sort of thing for the infix, then mascale, then go again with the plastic surgeon colleague, then take out that, redo something or replate, or you do double plating, whatever you do, like all the principles we know. But I think
the consensus, if it is the second stage osteosynthesis, is always a intramedullary plus extramedullary.
That's why I'm telling you, it is a nail plate or a double plate. Double plate problem is that the bone will be like a tube light. Bone will be like a tube light. You have taken out all the periosteum and it look like a tube light. Okay, so that is the problem. I think if your expertise is there, the safest would be like your Ilizarov friend. This patient, you see, this was referred to me in the year, I think, লেখা আছে বোধহয় দেখো তো 14, I think 2014, okay. 10 years back, 8 times operated, okay, done with Ilizarov and everything, and he is now I think he is at now he is 14 years না কত একটা কিছু লেখা আছে 14 ওটা 6 বছর আগের একটা এক্সরে তারপরে ও এসেছিল 14ই আগস্টে ওটা করেছে এক্সরেটা যখন আমার কাছে এসেছে তখন ওর বয়স হচ্ছে অ্যারাউন্ড ওই 6 এর এক্সরে এটা 6 ইয়ার্সের মতো 6 he was 6 you see that year just before that year mark on the left picture that year is mentioned. So how we manage this? It is not infected, all femur scarred down, this much of shortening, and now he has Ilizarov also done for this child, LRS done. I think some grafting from the one grafting from the mother was done. Then everything, whatever was possible in the textbook is been done. Now it has referred from the place. It has been done in many centers throughout the country. 7 operations in 7 centers. Anything?
Any defect in the distal part of the shaft looks some lytic lesions.
No, this is because of the footprints of the previous surgeries.
That may be.
These are not there is no metabolic problem. These are the footprints of the surgery, believe me.
Unusual, huh?
Is atrophic.
This is we have to go in, we have to cut the area, the avascular part. We have to make the bone grafts, the fibular graft. There's a slotted fibular graft anterior, at least 2 or 3 sides. Intramedullary 2 tens, and outside there is a plate through the long plate from bridging the.
It is a problem, because the problem is that even if you see the what he was mentioning too, that is there is some problem in the distal part, why this is looking so lytic and everything. Then I think even if you cut this femur, you see this much of non-union, 6 years, too much of shortening. It was like 4 inches shortening sort of thing at 6 years. Okay, he was using like this much of heel just to maintain the balance. আমি সেইটাই শেষ করে দিচ্ছি, দেখে নেবো, একটুই চলে যাচ্ছি. So it was
osteosynthesis. Then you have to.
ওই বাচ্চাটাকে ম্যানেজ করেছিলাম এইভাবে, এটাকে তো ডেব্রাইড করে দিলাম, এটাকে করে দিলাম ইলিজারভ. Ultimately it healed, because I am lucky that I had the chance to learn the Elizarov from one of the masters in the country. This was done, and ultimately it united, God's grace. I was the 8th person, but still united with the locking plate and whatever the compression I could do, because already the mother has already been donated the graft, so it was done.
No
so
graft was used, sir?
No, it was just, I just prayed God after we just chopped off everything end to end and just did the plating. So the least possible intervention, because the 8th time I was going, there was, I think if I go too much, there was no anatomical plane. So I was really scared, and I was told them, probably this is also again not going to unite, but we are just taking the chance. This, ultimately the boy united. This is the picture of. না শর্টনিংটা সেটেলড হয়নি, এখন তো 14 ধরো, এখন তো লিম লেন্থেনিং পরে যদি করে সেটা তো পরের ব্যাপার, সেটা তো টিবিয়া দিয়েও করা যাবে, বাট অ্যাটলিস্ট না এখন তো আমরা এখন হিল রেজ দিয়ে ওটা দিয়েই আমরা, নাও উই হ্যাভ পুট দ্য হিল রেজ, দি শু রেজ, হিল রেজ না শু রেজ, সো দ্যাট হি ক্যান, অ্যান্ড দি গডস গ্রেস হি ইজ নট ইনফেক্টেড, অ্যান্ড বিলিভ মি হি হ্যাজ গট ফুল রেঞ্জ অফ নি ফাংশন, as because he is child. Otherwise, 8th time surgery in adult with this much of, this is the quality, probably he will have a stiff rod sort of knee. Thank you very much.
Sir,
for your
one question. Sir, I mean, this is wonderful really. I mean, also lucky that it united. But once you plan for operation, like the X-ray picture was like atrophic kind of non-union. So didn't you think of putting some kind of biological material in the.
No, biological material, always the base thing is the graft.
Yeah, so
base
some kind of graft.
Base thing is the bone graft.
Yeah.
As because his mother is already donated the iliac crest ones and also the fibula ones.
Yeah.
So that is the problem. So I could not approach for any graft, because at that time I cannot put any graft.
Yes, sir.
And I am completely against your synthetic graft.
Yes, sir.
I don't use that, because it will. I have very bad experience with the when it came into the market. Okay. So that day I crossed my fingers. I am not using the synthetic graft anymore. The later part, the later grafts, whatever the beta TCP and all this, these are good. These you can use, but not the earlier ones.
Okay. If allograft is available, can you think of putting like?
I think you are not. The question is very good. The thing is that allograft you are for like your spacing. Yeah. Here you need the compression. Allograft, you don't have the osteoconduction. Okay. Osteoinduction, sorry.
Sir,
osteoinduction.
I've recently seen some cancellous allografts material is available outside. So I don't know whether it is in India or not. Yeah.
No. It is not. There is no osteoinduction.
Yeah.
Consistency, it does not provide osteoinduction.
Yeah.
You see,
BMP, yes, BMP, yeah.
You can use BMP.
Yes.
That's why I told you the last one, the BMP, beta TCP and whatever, and this is the clinical picture of that boy. And I prayed God hard. It is because the my surgery probably helped at 10%, and God help him 90%. Thank you very much for your kind and patient hearing.
Thank you very much. And now it's time for two lectures because the speakers have to leave for their flight. Dr. Siddhant Goel will talk on multiligamentous injuries of the knee, and after that Dr. Satish Mutha will deliver his lecture. And may I request Dr. Ananda Mondal and Dr. Sani Kumar Mollik? Dr. Ananda Mondal and Dr. Sani Kumar Mollik to chair the session. May we have a quick photograph before that? Dr. Ananda and Dr. Sani Kumar Mollik.
Thank you, Arindam sir, for this opportunity for having me here. Without wasting much of a time, topic allotted today is multiligament knee injuries. So, by definition, it involves two or more ligaments, main four ligaments out of the knee. Incidence is quite low because it's underreported. Mostly less than 50% get reported, and majority are life-threatening or limb-threatening with neurovascular complications. So it's a gray area basically if you come around as acute or chronic multiligament knee injuries. So we'll just discuss in brief some management controversies, whether conservative or operative, timing of surgery, whether we should have repair or reconstruction, use of allograft or autograft, partial or total repair, and what should be the rehab protocol, immediate and delayed mobilization. Some papers which I have read with reference to these topics. So acute and chronic, we're just going to discuss in brief how about acute, how we'll manage with the flow chart. So if we have a multiligamentous injury, we should see any associated life-threatening injuries. If it is, then we need to manage it in EOT with damage control orthopedics. And if no, then we see a vascular compromise. If yes, do an angio-CT and an ultrasound, reduce. And reduction is something which is prior with a vascular surgeon in your team. Or if no neurological complication, then it's straightforward reduce and with have X-fix. Majority of the acute multiligament injuries, in them 30% are having popliteal artery injury and around 35% with CPN. Acute multiligamentous knee injury, emergency management, what we should obviously train our residents is prompt reduction of dislocation in ER, reevaluate the neurovascular status and splint the limb. So see the pulses, ankle brachial index, which is very important marker, revascularization with a vascular surgeon in your team, and a temporary external fixation. Regarding the chronic multiligament knee injuries, depends now both cruciates are involved, single cruciate with a collateral, or both collaterals and both cruciates. So depends on the surgeon specific if you want to do a staged reconstruction or a single sitting. I generally do a staged one. So this is a MRI which shows severe soft tissue injuries around here. If you can note, there is a chronic tear of the MCL with a torn meniscus and torn ACL with a bone contusion. X-rays do play an important role in diagnosing the ligamentous injury. If we just have a stressed views, here we have a stress varus test. So you see a joint opening, which clearly indicates the collateral injury, lateral collateral, as well as the displacement anterior and posterior. In chronic cases, long leg radiographs are often important to evaluate. So patients with chronic PCL injuries or varus malalignment should be having treated with an osteotomy to correct the alignment first prior to doing in PLC repair or reconstruction. Surgical versus non-surgical, literature supports surgical post-operative functional rehab and multiligamental injuries. Rare occasions, conservative is advised in advanced stage or immobility or another comorbid conditions. Repair versus reconstruction, patients with repair of cruciates have tendency of having a flexion deficit of more than 6 degrees with higher rates of posterior instability. I'm talking about patients with repair, Higher reoperation rates is seen in patients with posterolateral injuries treated with repair. Hence, anatomic reconstruction with the biologically validated techniques have improved or better outcomes. So in multiligamentous injuries, otherwise, torn ligaments, reconstruction is better advised. So timing of surgery. As early as less than 3 weeks shows higher incidences of post-operative stiffness with FFD, with higher rates of manipulation under general anesthesia as compared to delayed repair. Delayed repair, there are chances of scarring of the soft tissues with more difficulty in identification and navigation of the soft tissues for repair. Hence, it's very tricky and non-conclusive to identify the timing of surgery. Depends on what is your expertise and how well the patient has come to you and amount of injury and the trauma. Acute injury is generally favored within 3 weeks. Some textbooks literature say within 6 weeks are advised, and chronic is not recommended unless there is a forced injury or a vascular repair done. Regarding the autografts and allografts, these are some of the autografts and allografts that's advised. So we use the modified laparate technique for medial MCL and the PLC complex. Regarding surgical techniques, what things one must avoid is the surgical tunnel congruence confluence as well as the tensioning sequence. We just had a discussion before how would we tension the MCL and PLC sequence. How would avoid the tunnel confluence is tunnel confluence increases the risk of graft failure, widening of the tunnel, potential damage to reconstruction of the grafts and fixation devices, not having sufficient bone stock in between the grafts for fixation and graft incorporation. This is the sequencing method. Major pitfalls in doing a multiligamentous patient positioning, graft preparation, oversizing to prevent oversizing and ensuring availability of the graft as in wherever we need, tunnel confluence, then meniscal root tears generally should be avoided because we do multiple drills, malpositioning of PCL or ACL, neurovascular complications and fixations. So some rehab protocol that we follow is 1 week with partial weight bearing, then can be started with continuous passive movement, then bracing with full weight bearing, and then after 5 weeks we have a non-restricted full weight bearing. So in summary, it's a complex problem where assessment of vascular and neurovascular injury is paramount important. Data is lacking of definitive and management tools. Any intervention that needs to be individualized by the presence of any life or limb-threatening condition or complication, and early operative treatment yields better improved functional and clinical outcomes as compared to non-clinical or non-operative or a delayed surgery. Thank you.
Siddhant, what is your opinion if a patient comes with a dislocated knee?
Yes.
Will you reduce the knee before X-ray, or you will do the X-ray first, then will try to reduce?
I think learning from the residency, any dislocated fractures should invariably reduced if reducible, and then just X-ray done.
Now, may we request Dr. Satish Mutha for his lecture.
Thank you, chairpersons. Thank you, Dr. Arindam sir, for having me over. So I'll be speaking today on this new kid on the block for proximal humerus fractures, the multi-lock nail. I'm sure all of you who do trauma must have started using it. So as opposed to the conventional earlier humerus nail which had a 5-degree bend in the upper part, this is a straight nail which has certain improvised design features, Because it is a straight nail, it does not enter from the footprint or the insertion of the rotator cuff. It enters through the muscular portion, and therefore the violation and healing is much less eventful. It goes through the stronger subchondral part of the head as compared to the greater tuberosity. It has a multi-directional screw construct, so you can have a very good purchase in the proximal head. It has a very new thing known as a screw-in-screw technology which enhances your purchase, and it has a beautiful calcar screw to prevent varus in varus type of fractures. So here you see the bent nail, the red one would usually insert from the head and the GT, which is the footprint of the cuff, which is a tendinous portion. So when you violate it, it does not heal, and very often you may have shoulder dysfunction. As against this new nail which enters through the muscular portion, the center, and hence cuff healing is not much of a problem. Also, it enters through the more dense subchondral bone of the head compared to the GT. Very often, even in two-part fractures, you may have a GT fracture, even an undisplaced fracture, and the initial nails would end up passing through the fracture site. Here, this nail avoids this kind of a pitfall. And you have multi-directional screws bisecting into the nail in the center of the head, which give a much superior purchase. This is the screw-in-screw technology. You have a 3.5 screw which locks into the 4 mm screw, enhancing the purchase. So you can have 5 to 7 screws in the proximal fragment, even within a distance of 3.5 centimeter. So this is a classical case. I'll quickly take you through the steps. A 2-part or 3-part fracture in a 64-year-old lady. This is the position that we normally give. It's supine. You may give a little beach chair position also. Volume hai? Nahi hai. The head is tilted to the opposite side. The C-arm. There is a bump underneath which throws your head into extension. The patient's head to be tilted to the opposite side as much as possible, and the entire arm to be draped free for manipulation as and when required. The C-arm will come from the opposite side. No armrest is used on the same side. So the approach is usually a anterolateral approach, which is between the anterior deltoid and the middle deltoid, where a classical raphe is there. So it's quite a avascular plane. You don't need this much of an incision, but you mark the 5 centimeter critical point of the axillary nerve. So a small incision split the deltoid and usually come on this reddish white structure, which is usually the bursa. And we remember the cardinal rule that anything that moves with the head is the cuff, which does not move is the bursa. You separate the bursa and then you land onto the cuff. Before you start making an incision in the cuff and getting into the head, correct the deformity of the head with the help of a wire. The head is usually retroverted, so with the pin you correct its retroversion, make it look like a true AP, and then start entering the nail. So you make a small 13 millimeter rent in the muscular portion of the cuff, which is at the highest point of the head. You can put 2 stay sutures or Vicryl on either side to control it, although it is not really necessary. Having done that, you put in a wire and you confirm your position in both AP and lateral by moving the guide pin itself. You need not move the hand. After you confirmed it, you pass a sleeve over that which rests on the bone. And this is the most crucial part of the surgery. You have to have an assistant who will hold this sleeve onto the bone throughout your reaming, etc., till you put in the nail, so that there is no further cuff damage. So then this is the guide pin going in, the sleeve, the initial reamer, and then you put in the nail. The nail has calibrations to sink it 5 or 10 or 15 millimeters subchondrally. So you have markers outside. You usually choose 5 millimeters, although you have end caps up to 15 millimeters available on table. Once you do that, you confirm, and the first screw that you usually put is a calcar screw. So you maintain your length in such a way that you are able to get the calcar screw in the inferior portion of the head. Having done that, then you start putting the screws in the head, and once you put the screw in the head, there is an arrow on the screwdriver which lets you decide where your screw-in screw will be. So it can either be posterior, anterior, whichever you want. So that's a parent screw with a screw-in screw going behind. Similarly, you put 2 other, and it has got 3 multi-directional locking holes distally, which can be done through the jig. So you can have really good purchase in the distal porotic fragment. This is for the smaller nails. And this is at the end how the incision looks like. This is the rent in the cuff at the end of it, which can be repaired nicely. And once you repair it, the whole thing gets nicely covered. The whole thing moves one piece, and it's really a very small violation in the cuff. So it's a very good tool that can be definitely used for 2-part fractures. even 3-part and 4-part fractures, because those locking bolts have holes in them. So you can take sutures through the GT and LT through this incision and put them into the bolt. So the final incision is pretty small. You can put them in a simple arm pouch and then you can start mobilizing them in 2-3 days. Passive abduction at the end of 1 week and active abduction at the end of 3 weeks. Yeah. Thank you, sir. So I once again congratulate Dr. Arindam, sir, for taking this small step towards a giant goal, as said by some famous Chinese thing. The journey of 1,000 miles begins with a single step. Thanks.
So one small question. We are damaging the articular cartilage. Are we not damaging the articular cartilage? And what is its effect?
Yes. So that is probably the biggest controversy which always gets spoken of, is that you are damaging the articular cartilage. Now 2-3 things, they have done enough cadaveric studies. If you see the new AO injury journal also, that there is a fibrocartilage which gets reformed very well in that void. So that's really not any function. We have been putting intra-articular implants in distal femur, in elbow, everywhere. And we know that they do get covered with fibrocartilage and they always don't lead into a functional deficit.
It is not like a hip joint also. The articular part of the cartilage is not come into the glenoid cartilage.
Only in extreme abduction, it can come.
Yeah. For that reason, it does not affect much.
So thank you very much, Dr. Satish Mutha, and have a safe journey. Now I request Dr. Himangsu Patro to take the chair of the for the next session, that is a free paper session. Along with that, you stay there with Ananda Mondal and Dr. Ananda Mondal and Dr. Sani Kumar Mullik. So there will be 2 free paper. First is Dr. Anubhav Goswami. He will speak on functional outcome of paceplasty for habitual dislocation of patella in a tertiary care center of Eastern India.
Just a comment, this is not being competitive. This session is not going to be competitive. We've decided, but we will have a special session for virtual competitive session for the PGTs, etc. That will be, we'll organize a special date for that. So this is just going to be a good paper presentation, and then you can ask questions as well in the two papers which we have.
Good evening, everyone. Good evening, judges and respected seniors. Myself, Dr. Anubhav Goswami. I did my MS from Medical College, Kolkata, and I'm currently an SR first year. Topic is a functional outcome of paceplasty for habitual dislocation of patella in a tertiary care center of Eastern India. Now, habitual dislocation of patella is a condition where the patella dislocates with each and every flexion of the knee and spontaneously relocates with extension of the knee. It is termed as obligatory dislocation when the habitual dislocation of patella is congenital. Very little literature is available on isolated habitual dislocation of patella, as most of the studies have combined cases of recurrent dislocation with habitual dislocation. Many different surgical techniques have been described in the literature for the treatment of habitual dislocation of patella. The pace answeriness transfer procedure for habitual dislocation of patella described by Dr. Bakshi is a biomechanically sound technique with predictable long-term results. The dynamic pace answeriness sling counteracts the lateral quadriceps contracture and keeps the patella relocated till the vastus medialis activity is restored and takes over. Now the pathanatomy, the patella is a sesamoid bone in the quadriceps mechanism. As we can see, it serves biomechanically to provide an extension moment during range of motion of the knee joint. The trochlear shape of the distal femur stabilizes the patella as it tracks through the range of motion. At 20 degrees of knee flexion, the inferior pole of the patella contacts a relatively small area of the femoral groove. With further flexion, the contact area of the moves superiorly and increases in size. The medial facet of the patella comes in contact with the femoral groove only when the flexion reaches 90 to 130 degrees. Normal lateral alignment of the patella is checked by the medial quadriceps expansion and focal lengthening of the capsule in the areas of MPFL and medial meniscopatellar ligament. The quadriceps blend with the joint capsule to provide a combination of dynamic and static balance. The tightness or laxity of any of the factors involved with the maintenance of the balance leads to a variety of instability. Now this is the Q angle. Risk factors are abnormal Q angle, significant genu valgum, lateral femoral condyle hypoplasia, trochlear dysplasia, vastus medialis obliquus atrophy, elevated TTDG ratio, hypermobility of the patella, compensatory coxa vara. Now, my aim and objective of the study was to study the functional outcome of paceplasty for habitual dislocation patella in children, also to study for any complications. It's observational prospective study, total 3 participants, follow-up duration of 2 weeks, 6 weeks, and 3 months and 6 months. Age of the patients were 5 years, 10 years, and 17 years. Thorough clinical examination was done, and it was noted that contracture was confined to the elliptical band versus lateralis and lateral fibers of rectus femoris. Release of technique was release of lateral tight structures followed by medial implication, medial plication, and paceplasty done using 2 separate incisions on lateral and medial side of distal thigh. A long leg cast applied for 2 weeks with knee in 30-degree knee flexion. Range of motion was given in post-op care with brace of 0 to 30 degree for first 2 weeks, weight bearing in knee brace after 2 weeks, range of motion 0 to 60 degree after between 2 to 4 weeks, and between 4 to 6 weeks 0 to 90 degree. Straight ahead running is allowed after 3 months. Return to athletic activity when full range of motion is achieved. This is the pre-op images of case 1. We can see the critical angle of dislocation of around 10 degree. In case 2, we can also mark the tibial tubercle and the patellar tendon, and this is the case 3 of pre-op images. This is the intra-op images of 2 distal incisions. Now this is the intra-op 90-degree knee flexion achieved without any dislocation. The post-op images at 6 weeks, at 3 months, at 6 months, a full knee flexion. This is the video of a 5-year-old girl with the knee is showing without any dynamic patellar tracking or J sign at full flexion. Another image of post-op patient with 17-year-old female showing the knee is fully extended without any dislocation of the patella. So no dislocation with a painless knee, full range of motion is achieved in all patients. Knee stiffness was present, definitely in all, which gradually corrected with physiotherapy. After 6 months, full range of motion achieved. Quadriceps lag present in 1 patient. So transposition of a part of pes anserinus was used to treat 96 patients in 78 patients with recurrent habitual or permanent dislocation. The knee with habitual 48 and permanent 27 dislocation also had release of supralateral contracture. Patients were reviewed at a follow-up of 9 years and 8 months. The medial stability of patella improved in all cases. There were 4 recurrences and with habitual and permanent dislocation of patella due to inadequate release of the supralateral contracture. Correction of these technical errors prevented further recurrence. So conclusion, after adequate release of lateral contracture, the medial stability was improved by transposition of the lower 3/4 of the pes anserinus to the medial border of patella and the patellar ligament. This created a relatively unstretchable physiological sling with ensured dynamic stability of the patella. These are my references. Thank you. Thank you, everyone.
Thank you, Arnab. You have said that basically it is a multiple risk factors are there.
Yes.
Have you tried to determine which risk factors was present in which cases?
Yes, sir. Yes, sir. So in my slides, in case 1, sir, in case 1, the 5-year-old child, the risk factors are there were increased Q angle, and the ligamentous laxity surprisingly was present in the 5-year child as well as the 9-year child. In out of 3 patients, 2 patients had ligamentous laxity with a Brighton score of more than 4. It was 6. And also, sir, in the 2 patients, I have also studied that there is a trochlear hypoplasia was present in the 17-year-old child. 17 trochlear hypoplasia was there. And because I could see from biaxial X-ray and also CT scan.
Then how you decide that paceplasty will cure the disease?
Actually, sir, paceplasty we have tried. Trochlear dysplasia we could rarely see trochlear dysplasia treatment of trochleoplasty we couldn't try. So we tried in paceplasty using inferomedial dynamic sling with the use of pes anserinus. We tried after lateral release and a medial imbrication.
Actually, when the cause is
Trying to ask, or he's trying whether this is a tool for all pathologies?
No, sir.
Increased Q angle, how will your paceplasty work?
In case of increased Q angle, we can try some other operations like Hausert. There is a Hausert technique where the tibial tubercle along with the patellar tendon is transposed medially to reduce the Q angle.
This is restricted for what indication?
Paceplasty, sir, paceplasty, we have seen that it is, it can consider in case of children where the Q angle is not raised, but mainly there is a lateral tight structures. The lateral structures are if there is tight like iliotibial band or the vastus lateralis, in that case space plasty can be done.
It is a dynamic sling.
Dynamic sling
Operates only in case of there is tightness of the lateral soft tissue structures. If there is bony deformity like hypoplasia of the lateral condyle and also the trochlear hypoplasia, then it will not work. Also in the what Dr. Mutha told, that Q angle, Dr. Ekepal has vast experience on this.
So what is your highest age limit?
it's probably 14 to 17 years.
That is the key. Because the bony abnormality, if whatever bony abnormality is there, if you done in the immature patient, this corrected soft tissue alignment, that guides the bone to realign. That is the answer why the patients, this patient's transposition is effective in immature age group. Whatever the genu valgum, whatever the Q angle, whatever the hypoplasia of the lateral condyle is there. So this corrected soft tissue alignment that guides the bone to develop in its normal alignment. So that is the rule of it. It is not that it is confined to only the soft tissue contracture. So that is actually, I have learned a lot from my master, Dr. Bokshi, and I am also
immature
I have improved that technique a little bit, but that is the key.
Dr. Pal,
if it is a mature one.
You are not able to do the bony procedures in the skeletal immature patient.
Absolutely that. Absolutely.
Dr. Pal,
is not required.
Have you ever felt any necessity to, it's a more dynamic sling and as well as inferior medial aspect, but that superiorly. Have you ever felt that at some times MPFL type of reconstruction is needed?
Yes, absolutely. It is a very good, intelligent question. That is how I improved that technique.
Yes.
So the initial he has used that. This is the only transposition is a classical technique. So this is the patient's it is priced up and only the medial border is tight. In my technique, what I modified this is the medial border. Once he priced up like this, the medial border, so that is it is imbricated, and that is tied with the lax medial retinaculum and the capsule. It is tied from medial aspect to the patella till up to the adductor tubercle. So that is the modification, and that is adding with the same
like
effect
MPFL like superior stabilization, that will give better result, right? Okay.
So one thing just I want to add, in the cases we have tried, one case which actually failed, that patient had a glide test positive also. So the MPFL was insufficient and we didn't do the MPFL reconstruction, we only did paste plasty. So that patient had recurrent also. Thank you.
The next free paper will be delivered by Dr. Shivli Dasgupta, and that is a case of postoperative infection in a multimorbid patient managed with collaborative care and gallstone resection.
Good evening. It's my pleasure to present this case to you today. In a day full of lots of anatomy and complicated orthopedic discussions, unfortunately, I'm going to bring a little bit of medicine in here with one of my cases that recently made our department completely lose their minds for a good 3 months. So this is a complex recovery, a case of post-operative infection in a multimorbid patient managed with collaborative care and girdle stone resection. My name is Shuli Dasgupta, and I'm currently working in Salisbury District Hospital in the UK as a junior clinical fellow in trauma and orthopedics. Patients presenting with hip fractures often present with multiple comorbidities as well. This often leads to pre- and post-operative complications, requiring careful medical management to prevent further disability and mortality. Psychosocial factors also add a layer of complexity to the care of such patients. The purpose of this case report is to highlight the importance of joint medical and surgical input in the management of medically complex patients and the potential impact psychosocial factors have in the decision-making process. In this report, it follows a 66-year-old female who notably had COPD on long-term prednisolone, type 2 diabetes, heart failure, and a long-term catheter, all of which could contribute to high risk of immune compromise and post-operative sources of infection. She mobilized with a mobility scooter outdoors, which is shown in this video. This is not how they usually use it, but this is what they use a lot in the UK, especially when they're not able to mobilize well. She fell on the 10th of February, and on the 12th she had her left hip hemiarthroplasty. A week later, we started to see her infection markers have been rising. Within a week, she started to severely deteriorate. Her bloods reflected an AKI of 3, post-op delirium, fluid overload, and she grew E. faecalis in her urine culture. This severe deterioration also followed with a sudden onset purulent discharge from her surgical site on the 24th of February. On the 25th, we did our first washout. We did 2 further washouts with a DARE procedure and VAC application on the 28th and 5th of March. And this showed that she significantly improved with the medical management of the orthogeriatric team and the surgical management with multiple washouts. On the 9th of March, we could finally close her wound, and we changed her vac dressing as well, and it showed significant clinical improvement in the patient. Over the next few weeks, there were multiple discussions with the hip team, the anesthetic team, the geriatric team, the patient, and all the pros and cons of the revision arthroplasty versus girdle stone operation were laid out. The patient chose to have the girdle stone procedure, which was performed on the 1st of April. Orthogeriatric care has emerged as a key clinical research focus in recent decades. Geriatric medicine supports older adults across all care levels, emphasizing function, autonomy, and quality of life over life extension. The introduction of orthogeriatric services and treatment guidelines for fragility fractures has helped reduce mortality in elderly surgical patients. In this case, we have used the orthogeriatric co-management model of care, which is highlighted on the diagram. The patient faced a life-threatening situation due to post-operative infection. Her severe infection, AKI, and fluid overload were managed through combined efforts of the orthogeriatric and surgical teams. Recent research shows that the adaptation of the combined orthogeriatric model appears to be widely used in Europe and less so in Asia, despite greater geriatric population in the latter. This is likely due to lower financial resources, lower awareness, and limited geriatric services. In addition, the implementation of orthogeriatric care is a rather recent evolution, with some countries just starting research in this field. The head and neck resection of the femur was popularized by Gathorne Robert Girdlestone in 1928 for the treatment of tuberculosis of the hip. In most cases, they allow a certain degree of functional autonomy compatible with acceptable daily life. Previously, it was just the removal of the native hip, which was riddled with infection, but now we use it concomitantly even with prosthetic joint infections, so we use the same term for either. Due to severe COPD and limited mobility, the patient opted for a girdle stone procedure to avoid further surgeries, prioritizing her quality of life. This procedure remains an important, underrated, and even compassionate option, with absolute and relative indications presented as above. Highlighted in red are the indications followed in this case, where the patient rejected further surgery and she was highly immunocompromised. This operation should be considered not a marker of failure, but as a definitive procedure that gives predictability to patients and the surgeon in challenging situations. Successful recovery from a girdle stone operation is influenced not only by physical healing, but also by a range of psychosocial factors. In this case, the patient was lucky to have a number of things in her favor for successful recovery from this operation. She had excellent family support to adjust to difficult recovery. She had support from the NHS for physiotherapy needs and medical follow-up. She also had additional support from the government to help install equipment necessary to improve her independence and quality of life at home. Thus, despite her reduction in mobility and independence, her strong psychosocial support and access to physical therapy allowed her to be well prepared for optimal recovery. This case demonstrates the growing need for similar systems in place in the face of ever-increasing aging population at the risk of fragility fractures. It also highlights the importance of the multidisciplinary approach to patient care. The patient recovered well post-operatively and was finally discharged to a rehabilitation facility on the 28th of April. These are my references.
Thank you. Good presentation, Shuli. Would you, if the patient had opted for surgery, would you have considered revision?
Yes, so we had offered the patient revision arthroplasty after a lot of discussion with the anesthetic team, the hip team who would have to do the operation. But, and we laid out the risks and benefits for her, of course. And she said that she had had enough. She'd had enough surgery. She'd had 5 operations in 2 months. And she said she does not want us to touch her ever again. So we hope that maybe in the future there are cases where we do more like arthroplasty in the future once they're healed and much better. But we don't know if she'll accept that in the future. But we did accept it.
She's completely infection-free.
She's
right
completely
now.
infection-free.
So you can consider it at a later stage after checking the CRP.
Absolutely.
So thank you very much, Shuli. And then 2 lectures are left. Now, may I call upon Professor Kiran Mukhopadhyay to deliver his lecture on recent trends in management of the TB spine.
Good evening. This may be useful, though there are very few audiences are there. So my topic is recent trends in management of tuberculosis of spine. So as you all know that the tuberculosis is one of the oldest demonstrable disease of mankind. In 4,000 years ago, in Rig Veda, it has been designated as Jokha. Many of us also today, till today in our villages, so it is termed as Jokha. Tuberculosis of the spine has been documented in ancient mummies from Egypt and Peru. And Sir Percival Pott in 1779, he described the classic description of the tuberculosis spine. Tuberculosis spine causes serious morbidity, including permanent neurologic deficits and severe deformity. Medical treatment or combined medical and surgical strategies can control the disease in most of the patients. Unfortunately, India bears the major load of the tuberculosis patients of the world. 27% of the world's TB population in India. And almost 1,000 patients die every day due to tuberculosis in India. And of all the majority are pulmonary tuberculosis, but all the tuberculosis patients, the 5% belongs to the skeletal tuberculosis. And among the skeletal tuberculosis patients, 50% belongs to spinal tuberculosis. And among the spinal tuberculosis patients, almost 50% has got some neurology. So before managing, you have to first identify who are the tuberculosis patients. So these are the presumptive spinal tuberculosis patients who has localized back pain for more than 6 weeks, along with tenderness over spinous process, with fever, with weight loss, and with or without signs of cord compression. But in advanced stages, there will be severe pain, there will be deformity, and there will be neural deficit. Now, for diagnosis, so X-ray chest is a must for all of the patients suspected for tuberculosis spine. HIV test nowadays is a mandatory for all patients suffering from tuberculosis, suspected or suffering from tuberculosis spine. X-ray spine is not useful in the early stages because it takes minimum 3 months, 3 to 6 months to appear in plain X-ray. But MRI for all suspected tuberculosis patients is mandatory nowadays. CT scan is not useful for diagnosis of the tuberculosis, but is useful for the selected patients. It's mainly useful for surgical planning. It's not valuable for diagnosis. Biopsy. Wherever possible, all patients should have a preferably CT-guided biopsy. And this material should be sent for microscopy and culture for pyogenic bacteria, microscopy and culture for microbial tuberculosis, along with histopathology and cytology. all of we know that the treatment is basically the medical treatment, the chemotherapy. So what is the recommendation of National Tuberculosis Elimination Program? There should be no doubt about it. So it's for skeletal tuberculosis, it's 2 months of intensive therapy followed by at least 10 months of continuation therapy. It may be extended up to 18 months on case-to-case basis. So at least 12 months of ATD must be continued. And how to follow up these patients? So if the patients don't have any neurodeficit, they are advised to return to clinic immediately if symptoms appear, or should be assessed weekly by the tertiary, by the primary caregiver. And with neurodeficit, initially staging and grading should be done, and with neurodeficit, it should be assessed weekly to know the progress. Repeat X-ray should be done every 3 months following initiation of antitubercular treatment. MRI, if possible, it's preferably to be repeated on 6th month, 9th month, 12th month, and 18 months following initiation of ATD. But at least one MRI should be done at the completion of the ATD. After completion of ATD, the patient should be followed up to 2 years every 6 months clinically regarding the recurrence or any reverse of symptoms. Now the indications for surgery. The surgery for tuberculosis spine are done for mainly two purposes. One is to establish diagnosis, and another is to treat spinal deformity, instability, and neurological deficit. So indications for surgery in tuberculosis spine with neurological deficit. If there is a neurological complication which is developing or getting worse or remaining stationary during course of non-operative treatment up to 4 weeks, 3 to 4 weeks. If there is a paraplegia of rapid onset, or if there is a spinal tumor syndrome, or the disease is a neural arch disease, or a severe paraplegia, or a paraplegia with severe pain, a minor degree of paralysis with a severe pain. Now the indications for surgery in spinal tuberculosis without neurological deficits. So these are mechanical instability, spinal deformity, when diagnosis is uncertain and open biopsy is indicated, and if there is suspected drug resistance. So what do you know about mean about the deformity or mechanical instability? So if there is bony destruction leading to a kyphotomy more than 40 degrees, so that is that deformity to be corrected surgically. If there is a spinal instability, that is if there is a more than 50% collapse, or there is a anteroposterior or lateral translation. If it is a pan-vertebral disease where bony involvement of both the vertebral body and posterior complex seen on imaging, or disease affects the facet joint bilaterally. So these are all signs of the mechanical instability. So what are the indications for instrumental stabilization? So these are the pan-vertebral disease, long segment disease where a more than 4 to 5 centimeter long graft is required to bridge the gap after surgical decompensation. For correction of deformity, that is mainly the kyphosis. If these are relative, that is if there is lesion in the junction area, or if the lesion is in the lumbar or cervical region. Regarding approach, the approach may be on the case-to-case basis. In the cervical spine, it's usually anterior approach. In cervicothoracic approach junction, it's also anterior approach preferred, the mandibular splitting approach. In thoracolumbar tuberculosis, anterior approach or posterior approach according to your preference, and other factors also. Sometimes you may need a combined approach, both the anterior and posterior approach. And in an established deformity, a post-tubercular spinal deformity, so in this case you need a pedicle subtraction osteotomy, that is a corrective osteotomy. And there are some cases where you cannot classify, so you have to modulate your approaches. So like these cases, you have your own approach to correct the deformity. This is another case where you can't define the deformity, so you have your own approach. You have to the case to case, you have to modify your case approaches. And nowadays, in selected cases, the minimal invasive surgery is done for tuberculosis spine, but it is in selected cases the result is very good. The resources and experience are the key factors for decision making for a surgical approach. The most appropriate method of reconstruction depends on the level of the vertebral spine involved and the extent of bony destruction, the lesion site, extent of vertebral destruction, and the presence of cord compression or spinal deformity determine the specific operative approach. This is the recommendation accepted by the Government of India, and it is published that all the spinal tuberculosis patients should be referred and managed in a referral clinic only, referral center only. And being a tuberculosis endemic area, biopsy or bacteria negative cases can be treated with ATD based on strong clinical and radiological evidence. Thank you for your kind attention. Bolo.
Advice for the non-weight bearing time for spinal as well as knee tuberculosis. Non-weight bearing. How long you advise to be not to bear weight? Number one. Number two, what is the incidence in your case of MDRP resistance cases? And MDRP resistant cases. Thirdly, associated with it, what do you feel, what to be done to reduce the incidence of MDRP resistance cases?
So first the MDR. MDR is a different thing. So that needs a lot of discussion. So if it's if is diagnosed as MDR, so the entire regime is
you faced. What is the initially? What is the incidence of MDRP resistance cases in your series?
In
your series. In your series of concerned patients.
No. So you have seen, but not so much.
You have not seen.
We have seen. We have MDR cases.
A percentage.
It's very few.
Very few.
Less than 5%.
Nearly 5%.
And for your first question, so the term is either ambulatory management or non-ambulatory management. So if you say ambulatory, if we prefer ambulatory management, so there is no question of bed rest. So this is the patient can be ambulated.
From day one?
Yes, depending on the substance of the pain. When he or she can tolerate.
Tolerability of the pain, depending on.
Yes, either if we choose ambulatory treatment, then there is no question of bed rest.
Choose on what basis you choose?
So I have all I have discussed. What is the indication of surgery? So what are the
indication of surgery is clear.
Indication of surgery
is clear. Yeah, surgery indication is not there. But to get better result, non-weight bearing, what you feel is not important. To have a good result out of ATD drug. Just like knee tuberculosis, very important.
So
if you allow weight bearing, the chance of resistance or response to the ATD is very clear.
So that's why these my last slide was on MIS approach. So and I am doing MIS in NS Medical for last 3 years. So it's almost 30 cases I have done. So the philosophy behind this MIS fixation is what you are telling. That is like a internal external fixator. So you are fixing the mobility is.
If you want ambulation, then you need to fix the segment for non-weight bearing to the affected area.
So that's the philosophy for the MIS tuberculosis, but for ambulatory treatment, so there is no scope for bed rest except.
Don't you feel that ambulation or weight bearing induces non-union or resistance to ATD? Non-responsive to, not resistance, non-response to the ATD therapy. At least so far the time and dose is concerned. You may need 1 year to heal, but if you allow weight bearing from the day one with painful spine, with ATD, standard ATD.
No, I have told that after the subsidence of pain, you can ambulate the patient.
Initially, you need to put the patient non-ambulatory.
If you ask him, he will not move because of pain.
People will walk around, go to toilet, etc. with pain. And in that case, don't you feel that you will have to face the consequence of early weight bearing? Means delayed union and resistance cases.
Bed rest, normally average 3 to 4 weeks we keep it.
And braces, use of
Sir,
braces.
I had a question, sir.
Number 3, please let me complete. Please, one question. The MDRP resistance cases worldwide is a concern nowadays. It is a paper publication, web publication. You know it. What do you feel? How can you improve the immunity? Or how can you improve the result of ATD drug in tuberculosis?
So the cause of the cause of multi-resistance is basically the failure to complete the to stick to the regime as prescribed by the doctors. So that's the
other than the ATD drugs.
And second is the HIV.
What is your advice?
No, HIV. These are the common. These are the causes for
Proper
MDR.
ATD drugs, standard ATD drugs. Other than those, what are the extra advice you need to give to the patient to get better result?
To improve the immunity.
Yes, number 1. Number 2, non-weight bearing, so long possible. So improve the immunity. What are the advices you need to put?
So good diet.
Good diet, yes. Number 1. Number 2. I mean, this is my concern. I want to put something extra. Yes. I know vitamin D. Definitely it is immunobooster. And I wanted to work on this, but I failed for the last 10 years. I went to head HOD of chest department and in some institutions to get a result, patient-oriented result. Otherwise, they are the subject. How can I get? I am a private practitioner. I could not. I request you to have a work on this. With vitamin D or without vitamin D, the outcome of tuberculosis patient in spine, in knee, and wherever it is, the much more. Number 1. Number 2, incidence of MDRP resistant cases will definitely be reduced. My opinion. And there are some points also. So why not we are working on this? I don't have scope, but I want to work on this. I tried in 2-3 institutions, could not poke my nose there. Can you help on this matter?
But one of the main causes is the failure to continue the regime as directed by us. We get often we get cases when we have to refer the patient to the nearest NTP center. They have to take drugs from there. But after 6 months, they do a sputum for AFB is negative, and they stop the drug. So it's a regular feature.
So in our country, it is a very big topic.
Sir, the question was that the duration of chemotherapy, how do you determine? Is straightforward 18 months or 1 year?
No. 12 months.
12 months.
2 plus 10. And
now, after 12 months, for extension
after 10 months, if you have the symptoms, if you do an MRI, so if the radiological or clinical symptoms you suspect, then you can continue. But minimum 12 months, and that is the standard protocol nowadays. 2 plus 10, 2 intensive, 10 continuation, and extended up to 18. And if MDR, so the regime is different.
So, do you add any extra chemotherapeutic drug along with national regimens?
No. You are not allowed to do that.
If it is not,
allowed to do that.
You cannot give outside. In fact, you have to report. You have to follow the RNTCP guideline, and you cannot do it. And you have to report it to the district tuberculosis officer. So you are not given. You are not given power to do that.
TB is notified disease nowadays. You have to notify as well as the drugs to be taken for the NTP.
You can invite a police case if you do not actually there. It's police case. So don't do that. So now the last lecture will be by Dr. Professor Ananda Kishore Pal on controversies in management of the intercapsular fracture neck of femur. This is the last topic.
Okay. So good evening, everybody. I think it is the evening already has been done. So there are several controversies. I am standing between this, enjoying this evening and also the topic. So just without, there are several controversies like from the birth to death like this of this neck femur. So this is the classification, treatment, everything. So the several list cannot be coped up with one slides. So there's a classification. All of you know the Powell's. It is a no predictive value of non-union. It was initially it was given considered. Now Garden is as high inter-observer variation. AOTA, it is also, it is not very practicable. The most important, it is whether it is a undisplaced or displaced fracture. So this is because it is directly related with the vascularity. Now this is another, sometimes we are encountered in a clinical practice, whether it is when you call non-union, when it's a delayed union like that. So for that is as per Parker and Pryor, in untreated cases, so fresh fracture means when it is less than 3 weeks old, delayed means 3 to above 3 weeks and above, and non-union is considered when it is untreated, it is 3 months, that's a universal classification, whereas treated case, internal fixed, this delayed union is considered when it is 6 months down the line from the date of osteosynthesis, whereas a non-union is considered when it is 12 months from the date. Now, in the controversy, is there any entity of minimally displaced fracture? So, yes. So, there as per book, it is a fracture with less than 10 degree varus in AP or 10 degree apex anterior angulation in the lateral view. It is considered as a minimally displaced, and the deformity beyond these ranges is indicate the displaced fracture. As you can see on that side, is definitely it is a displaced fracture. Now another criteria it is again it is whether it is the neck intracapsular neck femur fracture can be considered as a stable or unstable. So the stable fracture basically is a valgus impacted. Unstable means there are two entities. It is whether it is the verticality of the fracture and the comminution. So the feature of instability as per radiograph and CT scan, it is the vertical fracture line as you can see here, and it is the comminution. It is considered as, it is assessed by the modified Bowles angle, just I am going to discuss. And the comminution is basically fragment without connection to the head and neck. It cannot be used very loose term, is comminuted. So I am going to, what is the comminuted fracture? So basically it is considered, and this fragment which without any contact with either the head or the neck fragment, especially in the inferior and the posterior part. So comminution, basically the posterior cortex of the neck is needed to protect the internal fixation devices from rotated in the shear forces to implant failure. That is why comminution, especially in the posterior posterior cortex, is very, very important. See, this is it is a benign looking fracture, but it is once we do the CT scan, see this is a large fragment which is losing contact from the proximal fragment. So this is the actually area of posterior comminution. Now the verticality, how will you assess? The problems of the first fracture, it is the instabilities. One is the verticality, I have already told. Initially, it was considered as a Powell's angle. It was considered when this angle is measured. This angle of the fracture is basically it's a post-reduction film. But now it has been modified as per first I have to draw the axis of the shaft of the femur, then at the right angle to that line, then we have to make the line across the shaft, across the fracture surface of the proximal fragment up to this line. So this is the Powell's, is a modified Powell's angle. Now, what is the most important factor for this verticality? It is the most shear forces. So it produces the more shear forces, so that leads to various angulation and inferior translation even after the stable osteosynthesis. Now, importance of this verticality, basically there is no predictive value of the non-union. Basically it helps in intraoperative guide for the acceptable reduction. Now, what are the preoperative investigation mandatory? As all of you know, there is a standard radiograph and the MRI, especially for the pediatric age group. And prediction of the viability is only the displacement. There's nothing can be done in the preoperative. There is a notion the MRI should be done every there is special MRI type. But as per literature review, I have found only the displacement, especially the rotations, is the only directly related with the vascularity. Now, dilemma of the management is directly related with the age. So the modality of the treatment according to the age, classification, non-operative or operative, timing of the surgery, internal fixation versus arthroplasty, internal fixation device, whether the additional procedures are needed or not. If there is arthroplasty, which one is the ideal? It's the hemi or total.
Now, the chronological age or the physiological age, as per literature search, I have found that this is the most important relation with this age of the menarche and the menopause. There is a reproductive age groups. If it is a longer reproductive age group, it is protective for the neck of the femur fracture, and in those, especially those cases, they are very much good candidate for internal fixation device. But if it is a lesser reproductive age group, they are very osteopenic, because they are getting less estradiol in their life, so they are not very good candidate for the internal fixation. Now, the activity and the lifestyle, that is always you have to consider the physiological age. Now, basically, as per Parker recommendation, whether just these two factors should be considered, whether the individual is homebound or the institutionalized. And now, what is the cutoff age? This is also another important factor. So, it is a younger age group. Now, the young youth or group or younger age group. Now, you are very encouraged to know it is should be extended up to the 60 years. Life begins from the 60. Okay. So I think that the young chap is not born, I think. Okay. Okay. So anybody below 60 years, the life starts from this age of 60, I think. Okay. So below 60, it's young. 60 to 80, it is the middle age. And above 80, it is the exact geriatric age group, I think. So Madam Aspe already is orthogeriatric care. Treatment of the undisplaced fracture, there is no controversy, it is the internal fixation, and the conservative should be reserved for the frail with high risk of anesthesia, present late and stable fractures, the valgus impacted fracture, especially in this group. Now, the later arthroplasty is better with less incidence of the dislocation as capsular scarring. That may provide the stability. Now, as per I have already learned, surgeon should not be the bravado that should be mobilized from the evening. We have to do the orthoplasty, and from the evening we have to start with the mobilization. It should not be, and I am also follow this notion. And most of the surgeons, because of this, they encounter the dislocation. But it's the late mobilization that causes the capsular scarring, that will for the stability. Now, the minimally displaced fracture in any age group should be internal fixation. And the reserved option is the arthroplasty in young age group, especially in case of severe osteopenia, there is a comorbidity, and it is specially reserved for the salvage for the complications or the poor outcomes. Now, timing of the surgery is very, very important. Now, there should be no emergency, but early should be operated as early as possible, especially in the young. Best is the 6 to 8 hours, better as early as possible, but at least below up to 12 hours from the time of injury. Now, for the aged 60 and above, operate within 48 hours. Why I have just found some I am going to show the results. Now, displaced fracture in the younger patients, as the ideal is the anatomic reduction in internal fixation, preferably in 6 to 8 hours, maximally up to 12 hours, I already told. Preoperative MRI is not mandatory. It is several authors suggested. It is because it is a time consuming and it is not predictive of the avascular necrosis. Only is the displacement, initial displacement. Basically, this is the technique, is the gentle close reduction once using the gentle disimpaction of the fracture in the external rotation position, followed by internal rotation, and the adduction is checked under the CM. If that attempt fails, then we go for the open reduction. Now, ideal fixation, whether you should cross these physis or not, yes, we have to cross the physis, should not be DHS, CHS, CCS, it is the same. If you consider the stability, it doesn't provide any difference of the results. Criteria of anatomic reduction, not going into detail. So I think the Gardner alignment index, and another important factor, which is most important, it needs, this after significant internal rotation adduction, this has been given. This just needs some little bit elevation of the foot. Now, another important factor, the post-operative radiograph is a tilt. Is a posterior or the anterior tilt, that is it should be corrected paraoperatively. Now, whether anterior rotation should be given before DHS or after DHS, it should be given after the rimming and before actual insertion of the DHS. That is the consensus. Now, this type 2 fracture, as if you see this anti-parallel screw should be ideally as parallel as possible for the exact compression. Decompressive capsulotomy, it is still controversial. Somebody calls it very beneficial, somebody not. if the only internal fixation is sufficient or the additional procedures. Yes, there are several procedures are there, but there is no consensus at all. But in delayed union, non-union and the internal fixation if it is insufficient, then you can add to provide the stability, the additional procedures like the intertrochanteric valgus osteotomy or the muscle pedicle bone grafting. Now, multiple screw, I'm not going to detail. Key of success, all of you know. I don't important to have to show. This is the one case. It is displaced. It initially treated by the DHS. It is failed. Then PHLP, the splint, it's again failed. Then again, it is this osteotomy. This is the ideal case of the osteotomy. So displaced fracture in the middle edge, highest dilemma is a higher complication rate after internal fixation. So consider that several factors, the demographic factors, expeditious treatment, attitude towards rehabilitation, and surgeon factor is the most important. There are several demographic factors on which we have to depend. We have to just the one thing I have to already highlighted. Just I want to highlight, this is the proximal femoral anatomy, as it's an interesting fact like the reproductive age period. So this is the neck trochanteric ratio and this intertrochanteric width and the hip axis length. So these are the very, very important factor to providing the decision whether it's internal fixation or arthroplasty. Now, post-operative mobilization of weight bearing. Start mobilization as early as pain subsides. Start the partial weight bearing as it is tolerated by the patient, followed by full weight bearing. It is the same thing as tolerated, as you have already asked in the TV. So, the partial weight bearing, there is no question of non-weight bearing, because non-weight bearing increases the forces across the fracture than partial or the full weight bearing. Now, displaced fracture, there is no consensus, is arthroplasty. Weight bearing is allowed once the pain subsides. Okay, delay for the surgery in this age group, that increases the mortality and the complication rate. So we have to do, as we have already seen, this orthogeriatric case, you should not delay. We should be operated within 48 hours. Okay, partial or total replacements is always, if it is possible, it's a total replacement. So there's no doubt. But if there is some comorbidity, we have to make a shorter, quick in, quick out. Then we can go for the modular bipolar prosthesis, because that causes a reoperation rate is high. So it is difficult to conclude. There are several controversies and the miles to go before the slip. Thank you.
Thank you very much, Dr. Professor Ekepal. May I request Dr. Arindam Banerjee to felicitate Chairperson Dr. Himanshu Patra, and I think Dr. Ananda Mondal and Dr. Sani Kumar Mullik. Photo. So at the end, there's আমরা কি ওকে মিস করেছি? So now, Dr. Gurupada Bera. And Dr. Dipankar Mukherjee. So at the end of the tedious day, this first inaugural annual conference of World Orthopaedic Concern India chapter comes to an end. I think we have discussed orthopedics in a different angle, but in thoroughly from arthroplasty, trauma, pediatric orthopedic, spine, and whatnot. So it is time to thank all of the different organizations and the authorities and the persons who have helped to make this conference successful. First of all, I like to thank Dr. Arindam Banerjee, our president, and also president of International WOC International. I like to also thank our vice president, Dr. Shashindar Sanmugasundaram. I like to thank the treasurer of Dr. Siddhant Goel, and also all the members of EC who are here. Dr. Shovik is here, and Dr. Kostab is also here, but rest outstation faculties and outstation EC members have to leave for their flight. I like to thank West Bengal Orthopaedic Association to be a big support for this conference, all the executive committee members and all the general members. The North Calcutta Orthopedic Club, they also supported us, and Soiles Memorial Educational Trust to be our side, especially in our crisis. And I also thank Professor D.K. Taneja for sponsoring a lecture, an oration in his name. Unfortunately he could not make it to be present physically at this conference, but this oration has started, and it will be continued in the next second conference also. I like to thank WOC International. I like to thank the Park Hotel group for providing us the venue, and our event manager, Roshni Enterprise, and else is the chief person, Mr. Rohit, and his team. I like to thank all the pharma and implant companies who have supported us to make this conference successful. Are Strassenberg, Albert David, who has also sponsored a session and workshop, Intas, Torrent, Meyer Organics Private Limited, Depusynthesis, IPCA Laboratories, and MSurg, who has sponsored the arthroscopy workshop. I also thank all the delegates without whose presence this conference would not be successful. I thank the audiovisual persons and all other staffs, the food and beverages staffs, to be our side and to make this conference memorable and successful. We hope that we will be able to organize this more successful conference in future, and especially in the second edition in 2026 at Chennai, and we will announce that date of the conference in a short while. And I request all of us who are present in this hall to come forward in this dais for a photo session at the end of this conference. Thank you very much.